Good morning to everybody. It's a little bit of a overdraft there. Anybody want to welcome everyone to the 2023 Kidney Disease Impact Conference. We have so many that are following online. Welcome to everyone. Every year, this is a huge opportunity for global collaboration between all stakeholders to strengthen primary healthcare, providing patients, caregivers, and the community a chance for improved quality of life. Questions continue to arise about living with kidney disease. How does one's diet and lifestyle affect kidney disease? Does diabetes and high blood pressure lead to kidney disease? And if not properly controlled, long-term dialysis? What new scientific discoveries are in the pipeline, promising a more hopeful future for those with CKD? Some of the event topics by professional experts and specialists we will go through today: diabetes and chronic kidney disease, understanding diabetes, diabetic neuropathy, dialysis and diabetes, HSHG network, immigration, and mental health. It gives me great pleasure at this time to welcome the president of the Kidney Quest Foundation. And for those that are here, give a warm round of applause. But let us welcome, please, to the podium, the president of the Kidney Quest Foundation, Carolyn Lemos-Irikides.
Okay, testing. Can you hear me? Hi. Good morning, everyone. And wow, we made it. Okay. You know, coming out of this COVID, it's so many years after, but still going on our third year now. And I'll tell you, it's still a lot of hiccups coming out in the community. So thank you for making it today. Again, we're here. The Kidney Quest Foundation is always looking out as a collaboration with all these great organizations, as well as with the community of the patient and the people in the community that just need to know how they will get here if they don't take care of themselves. So this is the big factor that we continue to drive in our mission, is bringing awareness, bringing a lot of great education, and as well as taking care of our professionals and our patients as well. So today, thank you all for making it happen today. Thank you to our volunteers, to everybody that made this happen today, and especially the patients that came out, oh my gosh, and who are online. I know it's a challenge, but we have a lot of people online as well. So I thank everybody for just being here and making it happen today. With that, have a great session.
Thank you. Thank you so much, Carolyn. You do an amazing job year after year after year. Couldn't have this without you. Okay, we have our first guest speaker of today's session. Before we let him take over on the video, Dr. Rajesh Davda, Physician Executive Board Certified in Internal Medicine, Nephrology, and Clinical Informatics. His experience includes utilization management, physician productivity measurement, quality and total medical cost measurement, performance improvement, clinical informatics, and analytics. He has extensive experience in quality control and management in clinical practice. He has an MBA from Southern Methodist University, Cox School of Business. He is a certified physician with the Executive American College of Physician Executives. So we will ask at this time if we could have Dr. Davda, please get us started. And we welcome you, Doctor.
Thank you. Thank you very much for the introduction. And I hope you can hear me. If you can't, please let me know and we'll figure out something. I do want to thank Carolyn and the staff of Kidney Quest for all their hard work. I've been involved for the last year with them, and it's really been impressive to see them. So thank you for inviting me. I'm going to start sharing my screen. If somebody could let me know, I'm going to assume everybody can see my screen. If you can't, please speak up and let me know. So today we're going to talk about chronic kidney disease and diabetes. We'll start off the talk a little bit about the demographics and things like that for kidney disease. I'll talk a little bit about the pathogenesis of kidney disease, and this is really the pathogenesis really be directed towards professionals. But then we'll kind of jump into some of the newer things that are going on and some of the newer treatments. And we'll end with really where we were with slowing down disease progression of kidney disease in patients with diabetes and where we are now. And it's pretty impressive to kind of see the changes we've made over the last 30 years. So let's see. Okay, so the kidney disease is a frequent complication of diabetes. Kidney disease develops in 30% of people with type 1 diabetes and about 40% of people with type 2 diabetes. Now, that's not to say that many people end up with kidney failure and dialysis, but they do have some degree of kidney disease. And so, and diabetes is the most common cause of kidney disease and dialysis in both developed and developing worlds. And depending on the race in the United States, it can cause between 66 to 86% of kidney failure. So it is the most common cause of kidney failure in the United States. And then really the other important factor I'd like to leave you here with is that it's not just a kidney disease, right? The people who get diabetic kidney disease really have a much higher risk of cardiovascular disease, heart attacks, blood vessel disease, and so strokes. And so we need to focus on that as well. Slide change. So as a public health issue, kidney disease is pretty significant. There's millions of people that are affected by it. It's really expensive on the Medicare budget. I've shown you 2013 data. It's just increased more. It causes a lot of deaths, a lot of heart attacks, and it disproportionately affects African Americans and Hispanics. So although the incidence of end-stage renal disease and kidney is sort of stabilizing out now, we still see lots of people with diabetes and hypertension still end up on dialysis. And really that's the current focus is to slow down the progression of people developing kidney disease and dialysis, and to reduce the cardiovascular side impacts. The natural history of kidney disease in diabetics is kind of what I want to go over here. It really hasn't changed over decades. People get high sugars at the top, and then when that occurs, the kidney function actually increases as a compensatory mechanism. And then eventually what happens is you get injury to the kidney. We'll talk about microalbuminuria and macroalbuminuria, which is just protein excretion in the kidney. The kidney function starts to fall. You get hypertension, which contributes more to kidney injury. You get heart disease and infections that contribute more to this. And then eventually, after about 15, 20 years, you get kidney complications. Now, I want to say that this isn't 15 or 20 years after the diagnosis of diabetes. This injury and pattern starts with a lot of people not being diagnosed with diabetes. So screening for diabetes is a recommended therapy or care for everybody. And everybody should have their sugar checked at least annually. If you've never seen this type of a slide, I kind of want to go over it, kind of to show you what actually happens in this process. This is a really old slide. It's been around for a long time. We've known it. So this is the glomerulus on slide A, which is normal. This is the filtration unit within the kidney. If you take a kidney and take a slice of it, look at it under the microscopes, that's what it will look like. Slide B is in the middle to the top is really what starts to happen when you start getting high sugars. You start seeing this really delicate membrane on the left-hand side start to thicken up. So you start getting what we call mesangial thickening, and this is again a response to sugar. But not only that, these are blood vessels on a little bit to the right on slide B, and you start seeing the blood vessels themselves start thickening up. And this is kind of the hallmark for diabetic kidney disease. As you progress to slide C, you'll start seeing these nodules kind of start developing where the black arrows are. And then again, to the right, you see the blood vessel kind of thickening up even more. And then slide D down at the bottom on the left is really what we call classic Kimmelston-Wilson disease, which is you get these nodules starting to form. And as you see, the filtration unit is now starting to be damaged. Slide E is really where you start getting vacuoles, and slide F is really now the filtration unit is gone. It's all scarred up and what we call fibrosed over. And really, once you start going down the pathway of C, there's really no, and F, and certainly when you get down to F, there's no reversing this process, right? So once the damage and the scar occurs, you can't really reverse it. So this is, again, for the experts who kind of have seen this, there's a combination of genetics, which is if you have a family history of kidney failure and dialysis, and environmental, which is really uncontrolled sugar and high blood pressure and those sorts of things that eventually lead to diabetes. And then you get a lot of hormonal changes that occur. And the three I sort of want to kind of focus on in this big slide is really the renin-angiotensin system, because we have medicines to kind of deal with that. Control of blood pressure and sugar, because they lead to inflammation and hormones that cause further damage. And then eventually, you start getting down below to what we call renal functional and structural changes, which is the scarring that I showed you guys, and it will eventually cause diabetic kidney disease. This slide is new. It's really important because we've sort of had to re-understand diabetes and kidney disease. We used to think you got kidney disease, both the filtration unit and the tubules in the kidney, and you got protein excretion, and that caused what we call a rise in the filtration unit intraglomerular pressure, or rise in the filtration unit pressures, and we treated that with medicines that reduce that pressure, or ACE inhibitors or ARB agents you might have heard of. And that was our understanding, right? And then now we understand that there's a lot of other things that tend to happen when sugar starts flowing into the tubules of the kidney, and because of your sugar level is high, you get upregulation of what are SGLT2 receptors, and all of this further contributes to continuing damage to the kidneys. And this is where the new medicines and targets have tend to occur. So we had to upgrade our understanding over the last 30 years of this disease. I do want to talk about costs, because that's what I do almost every day, is try to help control costs so that we can all afford health insurance and Medicare will still be around and all those good things. This is an old slide from 2013 from the National Kidney Foundation, but it kind of shows you the point that it's really expensive, right? We spend a lot of money on diabetic kidney disease and kidney disease in general, in older people as well as younger people. This is a slide of how expensive it really is. If you've never seen this, this slide is the cost of Medicare. This Truven Health Market Scan is the cost to private insurance. And as you can see, the cost tends to rise in a few months before dialysis. And then as someone starts dialysis, the costs increase significantly, and then they come back down, but never back down to normal. So they still continue to cost thousands of dollars every month. As we move into diagnosis, one of the newer things I do want to talk about, and I'll show you here, is testing for protein in your urine. But I kind of want to show you, this is again an older slide from the National Kidney Foundation, but it's still true, is that if you look at screening by primary care doctors, the screening is still not completely appropriate. As you can see, if you take a bunch of patients, only very few of them, 10 to 15%, get complete accurate screening. And another 40% are actually screened, tested appropriately, but the primary care physician doesn't establish the diagnosis and doesn't begin the therapy for it or refer the person to a kidney doctor. And then a good 50% of people are not screened at all appropriately. So there's still a lot of gaps that we need to work on and increase awareness with professionals, particularly primary care doctors. And this is where the patients can help us. You know, if you have diabetes, you need to be screened annually for kidney disease. Now, what is screening? Screening traditionally has been the eGFR, and eGFR is basically a formula that we use. We measure your blood creatinine, and then we run it through a formula, and we get a GFR. And because GFR, your actual kidney function, is hard to measure, it's cumbersome, can be done, but it's cumbersome, and it's mostly done in research settings. So it's really considered the best overall index of kidney function. What your kidney function is actually varies with age. If you get older, normally your kidney function will decrease. Your sex, your body size, and all those things tend to occur. And we now know that we were inappropriately adjusting for African American population in this formula. And so after, you know, a good 30 years of inappropriately doing it, we've now moved to doing it appropriately. And if you want to know, if you know your creatinine, if you want to do that, you can just go online. There's lots of these calculators available. Once you know your creatinine, you just plug in the rest of the information in there, and it'll give you your kidney function. So it's not secret or magic or anything like that. Hold on just a second. The other thing I sort of want to talk about is the urine albumin and creatinine ratio, which is the screening part. So you get an eGFR, and this is all primary care doctors used to do, but we now know that you have to look at the urine as well. And this is actually a ratio. And what they do is they measure the urine protein or albumin, and then they measure the urine creatinine in the lab, and then we just create a ratio. And we divide the albumin by the creatinine and create a ratio. So it allows us to take care of the urine concentrations. And you can do it on a spot urine. You don't have to do it on a 24-hour urine. You can do first morning is preferable, but not necessary. We used to, again, have to make people urinate in a jug for 24 hours, put it in the refrigerator and all that stuff. And what's really cool now is there are home urine screening tools that are available it doesn't give you the urine albumin creatinine ratio, but it tells you if there's protein in your urine. Now, we've been able to do dipstick protein in the urine for a long time. You go to your doctor's office, you can actually go to the drugstore and buy it. And you can do it at home, but it was a little complicated to figure out where it was and if it was important or not. So I want to show you something new, and this is something my company has done recently, and I work for Cigna. And so what we did was we basically used this company called Healthy.io, and right now they're only working through insurance companies, and many insurance companies are doing this. And what they do is they have a urine dipstick, which is right here, and they send you a cup and this urine dipstick. and you don't have to measure it by looking at colors or anything like that. Basically, what you do is you dip your urine in it, you put the dipstick on this board, and you take a picture of it on your iPhone. You load the picture up onto an app, and it basically tells you whether you have any protein in there, you have a moderate amount of protein, or you have a very high amount of protein. And it also will send that result to your doctor if you let the app send the result to your doctor. So you get the result, your doctor gets the result, and you can go to the doctor's office and have a conversation and get more tests done if you need to get it done. So we think this is going to be a really important tool going forward where you can do it annually. And if it's normal, then you know that there's no protein in your urine. And if your blood test is normal, then you know you're good. And if it's abnormal, you know you need to get more tests done. So that's really useful to do that. So what are the criteria for kidney disease, right? I kind of want to go over this just a little bit. The first most important thing is it has to be around for 3 months, right? So you can get protein in your urine with fever, with a virus infection, with lots of different things. But so if it's abnormal, you got to be retested, right? So just one test doesn't mean that's all that you have kidney disease. And what you have to have is a kidney GFR or eGFR that's less than 60. You have to have protein in your urine, which is greater than 30. And you got to have some other marker of kidney damage, right? In other words, lots of protein. There are other symptoms and signs that you can have, hypertension and all of that stuff. And most of the time, this is not really hard to diagnose, right? I mean, the lab tells you the eGFR to your doctor. They can calculate the urine albumin creatinine ratio, like I told you. And, almost everybody will have some other symptoms. So it's not a really hard diagnosis to make. And then once you make the diagnosis, then obviously you have to start thinking about treatment. This is a complicated slide, but I want to kind of show you this because you'll hear the stages of kidney disease, right? And so what we do is we take your GFR, which is on this portion of the slide, and we take your urine protein, and forget all the other numbers in there, but then we come up with a stage, right? Stage 1, 2, 3 is recently been divided into A and B, 4 and 5 is really, and you're end stage and you're on dialysis. And as you can see, your GFR goes from normal and starts going down to less than 15. And so you can get graded on the stage of your kidney disease. And this is really important to know, right? Once your doctor tells you have kidney disease, the question next is, what stage is it? Because what stage is it is determines what treatment you need. And it's important for you to know that in case you end up in the emergency room or something like that, that you tell the doctor there that you have stage 3 kidney disease, because it impacts the treatments that they give you. So I'm going to switch to management, and because we started late, I'm going to try to be on time and try to finish a little bit early. So the management of kidney disease is basically right here, right on this slide: diet and healthy lifestyle, sugar and blood pressure control, ACE inhibitors or ARB agents. And then the newer ones we'll talk about is SGLT2, mineralocorticoid antagonist. And we're going to talk a little bit about lipids because we do want to manage cardiovascular disease. Okay. So this is the triangle, right? This is the pyramid, if you will. Exercise, smoking, weight control are key. Okay. None of this, if you smoke, none of this works. Basically, right? We have no medicine that overcomes smoking if you smoke. Exercise, you just got to walk 30 minutes a day. That's kind of the recommendation. And then weight control, and there are new medicines for weight control if you have severe weight problems. I won't go into them here, but there are newer medications that are available to help lose weight. Sugar control, RA's blockade is ACE inhibitors and other medicines to control your hypertension, and statins. Notice these are first-line drug therapies for diabetics, right? Metformin, SGLT2s, which we're going to talk about, RA's blockade with ACE inhibitors, and statins, right? So if you have diabetic and you have diabetic kidney disease, you should be on all four of these. Then we can talk about other diabetic control for people with kidney disease, and we'll talk a little bit about that. And then, the goal here is sugar control, blood pressure control, and cholesterol control. And you reassess every 6 months, okay? So the goals of blood pressure control, this is kind of a little bit of an old slide. I want to show you how things are kind of changing here, right? Is we used to say the goal of blood pressure control and care in kidney disease was to slow down kidney function, decline in kidney function. Blood pressure control and sugar control were key. Blood pressure control, depending on how much protein you had in your urine, but typically less than 130/80. Individualize the targets and use an ACE inhibitor or ARB, right? So this was 2013, 2012. Here's the new ones that came out last year from KDIC, right? KDIC is an organization that produces guidelines for doctors for doing this, right? And so the blood pressure target now is 120, okay? So if you have chronic kidney disease with or without diabetes, their target is 120. But if you have other conditions going on, you have to sort of individualize the target. Older people, you might not have as much lower of a target because older people don't necessarily tolerate low blood pressures. Same with the people who are very frail. Some people have white coat hypertension and their blood pressure is elevated in the doctor's office, but it's normal at home. So all these things have to be kind of taken into factor. If you have stage 4 and 5 kidney disease, it's pretty hard to get below 120 as your kidney disease advances. Sugar control is also something we have to think about. You may have heard of the hemoglobin A1C, which is a long-term measure of sugar in your blood. We used to think the impact was by blood. All you needed was the blood sugar and the hemoglobin, which is your red blood cell concentration count in general. And you got a hemoglobin A1C. We now know that there are other factors that impact it, right? Whether you have chronic kidney disease, which causes acidosis and these things, whether you're getting medicines, or whether you're getting medicines to increase your blood count, whether you're taking iron supplements, right? So all these factors influence this, and we have to be mindful of this. The other thing is the target, right? We used to think the target was if you were younger than 65, it was around 7, and if you were older than 65, it was just make sure it's less than 9. But now we know it really depends on lots of other factors, right? Whether you have chronic kidney disease, whether you have other complications, what your life expectancy is. An 86-year-old probably doesn't need a hemoglobin A1C of 6.5. Whether you have low sugars and frequent complications of that, right? So all these factors have to be taken in. And so again, we want to individualize the target. Still less than 8, but not a static number that we used to all think about. The other thing I want to sort of bring up is some of you may be using these. These are continuous glucose monitors, right? Which are things you've seen them on television. You plug it in and your iPhone kind of tells you what your sugar is, right? So this is kind of revolutionizing our thinking of diabetes. Again, we used to think about check your fasting sugar in the morning and check your A1C and you were done. Well, the new concept is really what is the time that you spend in normal range, right? Because here's a person on this slide, right? The normal range is described as 70 to 180. Your doctor can kind of adjust that depending on your condition. But look at what happens here, right? Here I am eating breakfast and I get a big spike in my sugar, right? When I eat lunch or dinner, I get a big spike in my sugar. It happens normally. If you have diabetes, you know this happens, right? And you may take insulin or medicines or things like that, right? But what we want to look at is the time that it's normal. So yes, we know you'll get a spike, but if you eat foods that, like a piece of fruit or a banana or an orange, it will jump up, but it will come back down very quickly, right? Whereas if you eat a donut, it's going to go up and stay up and then come down very slowly. So the time in range is really going, as you go forward, is going to be the critical factor as we go around. Now, unfortunately, we don't give this out to all diabetic continuous glucose monitors because they're still very expensive. So not everybody can get these, but I think it's something that will happen in the near future. I want to talk about statins or lipid management, right? Everybody should be, who has diabetes and is age 40 to 75, should be on a statin, right? I mean, it's a class 1 up here on the right-hand side, green recommendation. So it doesn't matter what your cholesterol is, right? You should be on a statin. Then what we do is we say, okay, now we have to figure out whether you need to be on a low dose statin or a high dose statin, right? And many of you may be taking a medicine called Lipitor. So have to figure out whether you're on 10 milligrams of Lipitor or 40 milligrams of Lipitor. And we do that by assessing your risk, or your cardiovascular risk. And then we do it. If you notice down here, because I'm going to beat up on smoking a little bit, is if you smoke, you're in the high risk category. And you should be, doing that. So again, if you quit smoking, you'll lower your risk. It's very important. But you should be on a statin. And I will tell you that close to 60% of patients are not. So, this is something to think about. This is a graph telling you about cardiovascular disease, right? If you have diabetes, but you don't have chronic kidney disease, your cardiovascular disease of heart failure, strokes, or heart attack is high, but about 40%. If you've got kidney disease, it rises up significantly, right? So, again, we want to manage cardiovascular disease along with the kidney disease, right? Okay, so we're going to continue on this, and I want to talk a little about ACE inhibitors and ARBs. They've been around for about 20 years, right? And I will tell you that still about 50% of people with diabetes and kidney disease are not on these medications. We've been trying to push this for 50 years, for about 20 years, and we still cannot get everybody on these, or 80% of people, which is the target. So you need to be on this, right? And you don't have to worry about this graph, but it's to show you that a lot of doctors your potassium could go up a little bit, or your kidney function could go up, go down a little bit. And a lot of doctors will just stop these medications. This particularly occurs if you go into the emergency room or if you go into the hospital. You're on this medication, your primary doctor started you, something else happens, and you get discharged, and the doctor say, well, stop taking these medicines. That's not right, right? We want to assess why this happened, and then even if you need to be off of it for a little while, put you back on it later down the line, okay? Now, why is this important? These are 2 studies. One, and I'm not going to go over the studies a lot because they've been known for a long time, that if you take these, they provide reduction in kidney disease and protection for type 2 diabetics. Well known, right? The concept, again, I want to talk about is residual function risk, right? So even though, yes, if you take a sugar pill or placebo and you take the medicine, your kidney risk goes down by 16%. And in this trial, it went down by 20%. But you still have a lot of risk left for developing kidney failure, okay? And so we're starting to think about more risk, time and range for sugars, time and range for blood pressures in a more sophisticated way rather than just a number. I want to show you that that's going to become really important here in a second. And so if you look at glucose inhibitors, SGLT2 inhibitors, these are medicine that basically, when you take them, you excrete some of the glucose that's instead of reabsorbing it and keeping your glucose higher. So they're used for were designed for reducing sugars, right? And then we found out that they work to slow down progression of kidney disease as well, and they reduce the risk of heart disease. So the current recommendation by KDIC is everybody that has a kidney function that's greater than 20, this is a little bit of an off-label, right? Because doctors, the FDA label says, we haven't tested this in people who have kidney function less than 30, but we now know this is a grade 1A, which is the highest recommendation you can get, right? And there are multiple different types of SGLT2 inhibitors. And so it's really important that your doctor consider this. And many doctors are not considering this because it's new. These are some studies to kind of show you that it's really important, to reduce your risk of kidney disease, especially the earlier you are, right? So the earlier the higher your kidney function is, the lower your risk of kidney disease progressing. And I'll show you some slides. It's really impressive at the end. So again, this is a study. Remember, we showed that if you took an ACE inhibitor, your reduction in risk factor was 20%. If you add one of these SGLT2 inhibitors, or if you're taking your reduction in risk is 43%, right? And this was such a phenomenal study that the FDA stopped it in the middle of the trial and approved the drug for this. This was the first trial that came out. Remember, we talked about residual risk. So here's a trial that shows that if you take just the ACE ARB agent, this is your residual risk, right? You got all this left over. If you add the SGLT2 inhibitors, your residual risk goes down even further, right? So we want to take care of blood pressure, sugar, and kidney disease to keep reducing your residual risk. This slide kind of shows you, I'm going to skip this slide in the interest of time. Really, how they work, we don't know, right? This is a slide that shows you some hypothesis, but the key is it works on kidneys, hearts, and it's really important. It's a really, really important medicine. The other medicines that are coming out now are what we call mineralocorticoid receptor antagonists. And the one that's out there is called finerenone, or Kerendia. Kerendia is approved for diabetic kidney disease, and it's for people who have kidney functions greater than 25 and whose potassium is normal, right? Because it increases your potassium. Now, again, I'm going to skip this slide in the interest of time, but it works in lots of different mechanisms, works for kidneys, hearts, it reduces inflammation. So lots of different ways this works. And that's how we're now thinking about this. We want to look for drugs that impact lots of different places in the body. You may have heard of mineralocorticoid receptor antagonists, spironolactone, and I can never say this, eplerenone has been around for a long time, right? But they weren't really specific, right? And they had more complications. And now finerenone is what's called a non-steroidal, and it's very high potency, very high selectivity, doesn't have any metabolites, and it's very balanced in the heart and kidney. So this is a significant improvement in diabetic kidney disease. And again, this is a trial that shows you that finerenone is effective. This is another trial that can, from the Flidio DKD, is that it slows down progression of kidney disease. And a second trial, I want to show you that it does decrease protein excretion, and it does work in heart failure as well. So although not approved for heart failure, we use it in predominantly kidney disease. And I'm going to finish here with the last slide, try to get us back on time a little bit. But this is kind of probably the most important slide I've shown you today. When I started practice, there was no specific therapy for kidney disease. Right? This was before, I'm an old man. This was before captopril and the ACE inhibitors came out. And we used to say, if you had diabetic kidney disease, you came in my office, I could predict your kidney function was going to decrease 10% per year. So if you came into my office with a kidney function of 30, I knew in a couple of years you were going to be on dialysis. There was nothing I could do for you, right? Except get you ready. Then the ACE inhibitors, ARBs, came up, and you notice that the kidney function decrease per year went down to about 8. Okay, a little bit of an improvement, but really not significant, right? Then the IDNT trial that I showed you came out where we added norvascular amlodipine. And we said, oh, wow, now we're starting to make a little bit of an increase, right? We've reduced kidney function decrease by 40%. But still not great, right? I mean, if you came in with a kidney function of 30, okay, instead of 2 years being on dialysis, you were going to be on dialysis in 4 years. It's better, but really not great, right? But look at what happens now when we come out with Credence, which is the SGLT2 inhibitors, and Fidelio, which is the trial I showed you on Finrenone or Kerendia. We're now getting down to about a 2% decrease in kidney function. So if you came in with a kidney function of 30, we were down to saying, well, maybe I can do something to slow down your kidney function and you won't be on dialysis for 10 years. That's a huge move and a huge improvement these drugs have done. We're headed towards 0, right? So with improved screening, improved testing, knowing your stage of diagnosis, making sure you're on these medicines, including a statin, you really have a significant chance of reducing and slowing down disease progression. And so this is where we're headed these days. And so a huge change. So I will stop here and I will figure out how to stop sharing.
Dr. Damda, if we could real quick, it looks like we have a question that came across. It's from Jessica. She put on here, did Lilly just put a cap on their diabetic meds and their cap was like $25 or $35? And also, what if she doesn't have an iPhone? Can you address either of those?
Yeah, sure. So Lilly did put a cap at $35. It follows the Medicare cap that President Biden just instituted. It's for really commercial patients because Medicare already went to the $35 cap on insulin. I will tell you, most of the insurance companies had already moved to that. My insurance company had already moved to that about a year ago, not costing patients. But now, the cap's helpful for employers and that sort of stuff. But Lilly, it uses insulin, right? So it's for insulin. It's not necessarily these newer types of drugs, right? So insulin's great for sugar control. But as you recall from the pyramid I showed you, you still have to be on these other drugs, right? So I want to kind of emphasize that it's not a replacement. If you don't have an iPhone, obviously, if you have an Android, it can still do the same thing, the home testing. But really, the key is to get your doctor to do it, right? So eventually, if you test yourself at home, you still got to go to the doctor to make sure that you get screened appropriately for protein and creatinine. So my best recommendation to you is, if you have diabetes, you should be seeing your doctor every 3 to 6 months and getting screened annually at the minimum, if not every 6 months, for kidney disease.
Doctor, thank you so much. So wonderful. What a great way to kick off today's event. And we appreciate all your wisdom and guidance. Thank you so much.
Oh, thank you. And I'll see you guys at 2:30 for any other questions on the panel meeting.
Sounds great.
Have a
Okay,
great
everybody who's following online, we're going to take just a couple-minute break and we'll be back with our next doctor. Dr. Vishaka Modak. I hope I said that correctly.
Yes.
She is a junior resident at the Bangalore Medical College and Research Institute.
Mm-hmm.
Dr. Vishaka is an MBBS graduate who is currently serving the government by working as a junior resident at BMCRI, India. Thank you so much, doctor. You graduated magna cum laude and you're not only interested in academics, but research. You love teaching and believe strongly that patient education is the most vital and crucial step in disease prevention. So at this time, I will quiet down and let you take over. Thank you so much, doctor.
Hi, good morning to everyone present here. Like he gave a great introduction, but I would like to do a little bit of it myself. I'm Dr. Vishaka, and I'm a junior resident in Bangalore Medical College and Research Institute. And today's presentation that I am going to be giving is about understanding the pathology of diabetes mellitus, specifically type 2 diabetes mellitus, and also about certain key points regarding diabetes self-care and diabetes management. So it's going to be a talk about all of this, and especially for the patients affected, the caregivers who take care of the patients. So I'm going to cover a few points that summarizes all of this. So my talk will be for about an hour, and at the end of it, I'm willing to take questions from all of you. So I hope I can start. So understanding type 2 diabetes mellitus. So let's get to certain facts about diabetes, okay? I'm talking about the prevalence of diabetes that's present in the United States of America, and 11.3% of the population suffers from diabetes, and that's about 37.3 million people. That was the latest statistic, which was given by CDC. And out of the pool of 37.3 million, 28.7 million adults are diagnosed, and 8.5 million people remain undiagnosed. So that's 23% of people remain undiagnosed. So what exactly is diabetes mellitus? Diabetes is a chronic metabolic disease which is categorized by elevated blood glucose levels. So it's chronic in the sense it lasts for your entire lifetime if you have it. And the whole, in chronic conditions, what we usually focus most on is managing the condition. There have been many studies which suggest that diabetes self-care and management can really go a long way in controlling the blood sugar levels. And it's very important why the blood glucose has to be controlled, as most of you are aware that diabetes just affects a lot of organs in our body, right? From the skin, you have increased chances of infection, you have higher risk of atherosclerotic disease, neuropathies, diabetic nephropathy, which is diabetes eventually, if unmanaged, can affect the kidneys, causing nephropathy. So that's why it's very important that in a chronic condition, we focus our goal on managing it at our level best, right? That's very important. So the classification of diabetes has changed, but broadly speaking, it's type 1 diabetes, type 2 diabetes, and gestational diabetes. So gestational diabetes essentially means that this is a sort of new diagnosis that happens when some ladies experience this during their pregnancy. So that's why we call it gestational diabetes mellitus. And then there is type 1 diabetes mellitus, which was referred to as insulin-dependent diabetes mellitus, because the pancreas in this case are not producing insulin. Okay, but the type 2 diabetes mellitus was also referred to as independent or non-insulin dependent diabetes mellitus. This requires insulin in the sense that the insulin is produced by the pancreas, but the cells stop responding. So the goal of therapy is not just replacing insulin or controlling the blood sugar levels, but also really making sure that the cells that are supposed to be responding to insulin do adequately respond on medication. So that's the whole goal. The goal differs in type 1 and type 2 diabetes mellitus, right? The goal is the same. We need to control our blood sugar levels, but the pathology of type 1 is very different from type 2. So, what is insulin? So, insulin is a hormone that is produced by the beta cells of our pancreas. And this hormone is extremely important for allowing the glucose in the blood to enter the cells. This is very important because each cell in our body requires energy to function, right? Every cell many cells form tissues, many tissues form organs. So the basic unit of any organ or organ system is a cell. And the cell, like, any of our vehicles, like they require fuel to drive them, like that, our cells require energy to function. And where does this energy come from? A lot of substrates, right? From sugars, which is glucose, all complex sugars are broken down into glucose, or fats and proteins. But the primary uh, fuel for our cells is glucose, right? So this glucose has to enter the cell. And what insulin does is it's a mediator. It helps the glucose to enter inside the cell so that it can be used up for generating energy. So, like I mentioned earlier, in type 1 diabetes, insulin is not produced, and in type 2 diabetes, the cells are not responding to the insulin produced. So, in type 2, the insulin is produced, but the cells have become resistant to insulin. They just do not respond. So essentially, what really happens is that although this insulin is present, the glucose is present in the blood, the cells are incapable of uh, absorbing that glucose to convert into energy. That's what happens in type 2 diabetes. So this is a pictorial representation of the same thing that I spoke about. Like, as you can see in the picture, there is a cell, the orange thing with the thing in the middle is the cell, okay? And there is glucose. Glucose is the pink tiny ball, and there is the yellow color peg-like structure, which is an insulin. So first, the insulin has to unlock the glucose channel. And once the insulin unlocks the glucose channel, it kind of opens a doorway, for the glucose to enter inside the cell. So without insulin, the glucose does not enter inside the cell, because of which the cells cannot use the glucose for making energy. And that's why, this is how I personally correlate. That's why many people who are with type 2 diabetes or type 1 diabetes, they do not feel energetic on most days. Like, they tend to feel very fatigued because, the cells are not utilizing the glucose at all, because the cells are not responding to the insulin, which is supposed to unlock the channel for the glucose to enter and do its function, which is help the cells to produce energy. So this is again a pictorial representation of what insulin resistant really is, So on the right, you can see a structure uh, over the letters which say make insulin. Those are the pancreas. So the pancreas are producing insulin. The cells therefore resist insulin. So when the cells resist insulin, what really happens is that it's telling the body, it's telling the pancreas that, hey, we aren't getting any energy here, you know. So what the pancreas does is like, okay, I know you're not getting energy. How can I help? I'm going to produce more insulin. So as that happens, the pancreas produce more insulin because your cells are resistant to the normal quantity of insulin that's being produced. And what we need to realize is that insulin just does not have a single function. The most important function of insulin is to allow glucose to enter the cell so that it can be used up for energy. But the other function of the hormone is storing fat. So this is known as, it stores fat. That's why the more insulin that's produced by the pancreas, because the pancreas believes that the cells are not getting enough insulin, more insulin gets released, and insulin is a fat storing hormone as well, which is why there's a lot of adipose tissue deposition or fat deposition that can occur when a lot more insulin is produced. But the patients usually feel very tired and hungry. Why? The reason for this is because the cells are not absorbing glucose, right? So that is the whole essence of type 2 diabetes, that the cells are tricking the pancreas by telling them, hey buddy, we we aren't getting any glucose, and the pancreas is like, okay, I'll produce more insulin. But the problem is at the cellular level. So these are the symptoms of diabetes mellitus, increased thirst, frequent urination, increased hunger. The reason for hunger, like I mentioned earlier in the previous slide, is that, the cells are fatigued. They believe that they don't have energy. So there's a lot of glucose in the blood. There's a lot of insulin in the blood, but the cells aren't getting that glucose to function. So it's very common to feel tired. And as a result, hunger also increases, right? And then there is blurring of vision, slow healing of sores, frequent infections, numbness or tingling in the hands and feet. And there are in certain people, there are areas of darkened skin, usually in the armpits and neck. And that's what we call as acanthosis. And that's a marker of insulin resistance. So, what are the risk factors for causing type 2 diabetes mellitus? There are many risk factors that have been found, and one of them is weight. Being overweight or obese is a major risk factor. The second one is fat distribution. So, the trend has sort of changed. There was a lot of focus on the BMI. I'm not saying that BMI does not matter or is a poor predictor of obesity, but the trend has sort of changed, that now what we essentially are looking at is the waist hip ratio. So it's very important to understand what waist hip ratio is. So somebody with a larger waist to hip ratio is storing a lot of fat in their abdominal region, right? Which is why the numerator, which is the waist number, increases. And so this is a very important predictor of amount of fat that is stored in the abdominal region. Okay. Then inactivity. So the less active anyone is, the greater the risk of diabetes, because I'll get to why activity is so important. I feel like, there's a lot of uh, jargon, or, that everybody should be physically active. But no, like I haven't heard anybody go into the specifics of why exercise is important. So I'm going to be covering that. There is a very particular reason why exercise is very important in case of patients who are affected with diabetes. But we'll get to that later in the presentation. And family history. So somebody whose parents, the first generation family, has diabetes, then not 100%, but the kids have a greater likelihood of developing diabetes compared to somebody's family where the first uh, relatives or siblings are not affected. So people with a family history are at a greater risk of diabetes. Race and ethnicity. So certain races have higher prevalence of diabetes that's present. Other risk factors are blood lipid levels, the age, pre-diabetes, and pregnancy related risks, like I mentioned, because gestational diabetes mellitus is something that occurs in pregnancy where the hormonal changes during pregnancy sort of make the cells resistant to insulin. So, gestational diabetes mellitus, as the name suggests, is that the patient must not have diabetes prior to pregnancy. This is a condition that is very unique to gestation in the sense that insulin resistance sort of develops during the pregnancy. And then there is polycystic ovarian syndrome, very common in young females. The cause of this is also insulin resistance. The body cells are not responding to insulin because, and there are also other hormonal factors that come into the play while we're talking about PCOD. But one of the components in the whole PCOD spectrum is insulin resistance. So, what are the complications of diabetes? There is heart and blood vessel disease. Diabetes is a very strong predictor, is a very strong risk factor for development of atherosclerosis. Atherosclerosis is basically hardening of your blood vessels and narrowing of your blood vessels over time. Nerve damage, or what we call neuropathy, and kidney disease, what we call as nephropathy. There can be the eyes can also get affected. This is what we call ophthalmopathy. So in this case, patients affected with diabetes are more prone to develop cataracts and glaucoma. Certain skin conditions like repeated fungal infection, oral candidiasis is something that we commonly see in patients affected with diabetes. And this is because it even alters the immune response. Diabetes really can act on our immune system in such a way that the patients tend to get a lot more infections. They're prone to getting these infections more commonly. And slow healing is also another feature that occurs in diabetes, and hearing impairment can also be a certain complication. So, when I am going to be talking more about diabetes self management, because this is a very, very crucial area in managing diabetes. Since it's a chronic condition, self management really goes a long way, because in case of self management, you as a patient are an active participant in managing your condition. And that is what I want to stress on, because since it's chronic, the damage sort of is done over time. It's not acute, it doesn't happen quickly. Diabetic neuropathy, nephropathy, all of these take some time to develop. And if the blood glucose levels are monitored and are kept in check at an earlier stage, it can really prevent these complications from occurring. So, self management is a very key component in managing diabetes. Earlier the start, the better, but it's also never too late. So, this is a diagrammatic representation of what I feel self management should entail. All the pieces of the puzzle really should fit, because we're not just talking about actionable steps adhering to medical management, but we're also talking about emotional well-being in case of patients affected with diabetes, because you essentially have to learn how to cope with the disease only and accept it on a certain level, which is very important. Healthy coping is extremely vital, because healthy coping is a way for, it's like a doorway to get motivated to manage the levels, the sugar levels. So this is like a pictorial representation, like I mentioned. It includes healthy eating, being active, healthy coping, medication management, and monitoring. So we'll go into detail, further into detail about each of these. but all of these are very important. So how can type 2 diabetes be managed? The first step to management of anything is understanding. Understanding the disease is very important. And this can take place at many levels. There are certain well equipped professionals called diabetes educators. So you can reach out to them and they would definitely answer the doubts, any queries, and make sure that the patients really understand what diabetes is. The second most important step is discussing treatment plans and different medications with the provider. This is very key because, like Dr. Raj mentioned in his previous talk, that the therapy of diabetes, is very individual. It's tailored individually. It might be the same disease pathogenesis, which is insulin resistance. That's the common denominator, but the varying levels of blood glucose in different patients clearly tells us that it's a very individualized sort of a disease. No, it's very unlikely that two patients will have the same blood glucose profile when they chart it at home. So the treatment has to be catered in a very personal way, in a very individualistic way. The third is staying active, which is important. I will get into how insulin really affects, exercise really affects our body. And active participation in self management is very key. It helps us gain a certain level of control when we are actively participating in self management. And diabetes foot care practices are very important since diabetic patients are exposed to, frequent tiny hurt or tiny lesions becoming very large because of the poor and slow wound healing process. So, diabetes foot care should also be included in the management of diabetes. The next is managing blood lipid levels. Like Dr. Raj mentioned, that 40 to 75 years of age, all the patients must be started on either low dose statins or high dose statins, depending on the risk, the 7-year risk that we call. If it's greater than 7.5%, high risk statins, high dose statins are started. If it's lesser than 7.5%, low dose statins are initiated. But managing blood lipid levels is very important to prevent cardiovascular complications of diabetes. The next step is glucose monitoring or charting. Glucose monitoring and charting is important because it's not an individual number that we're looking at. It's a trend that we want to monitor, over a long period of time to tailor the best treatment for the patients. So glucose monitoring and charting is important because, we as doctors aren't physically always around, nor do we know your charts perfectly. So when somebody monitors their glucose over a long period of time and shows us a logbook or a home chart, we can actually understand the whole trend of glucose levels. And that is important to tailor the treatment regimen. And lastly, but not the least, this is a very important tool is quitting smoking. It can be hard for a lot of patients, but it's very vital as to why quitting smoking helps or aids in diabetes self-management. So what are the obstacles in coping with type 2 diabetes mellitus? Anxiety and depression associated with coping with the disease. There was a study done which mentioned that these were the highest prevalent psychiatric conditions in patients affected with diabetes, or the most prevalent diagnosed conditions are anxiety and depression. In the older adults, there is a lot of distress because they have to adhere to medication use and complex treatment plans. Then another obstacle would be self-monitoring, fear of injections, uh, lack of motivation, level of education, because not everybody is in a place to understand, unless you read and you talk and you communicate with your provider. uh, it's very important to educate yourself regarding diabetes. And lastly, making changes in lifestyle. These are the most common obstacles that we see among patients affected with diabetes. Sometimes it's just one of these, like not able to adhere to medication use, but sometimes it could be two or three obstacles that, sort of come in the way of uh, the treatment plan. So, this is a pictorial representation of psychological factors in patients with diabetes. So this is showing us the different levels of emotional distress that happen in patients with diabetes. So it's the psychological reaction of patients who are affected with diabetes. Not all, but like I said, it's a spectrum, right? So some people, the first picture that you can see is emotional crisis or reactions. When a patient is first diagnosed, he might be shock, denial, anger, might even feel a certain sense of guilt and anxiety regarding the condition. Then, so common emotions faced by the patients are denial, anger, guilt, and acceptance. So going back to this slide, there is also diabetes associated distress, like feeling overwhelmed, especially when it comes to self-management. This is most commonly seen in the older population. Frustration, difficulty in communication, and distress on differential food treatments in the family. You know, then there are phobia reactions that can occur, like fear of starting medication, fear of needles and injections, fear of hypoglycemia, and other complications. So these are the phobia reactions. And lastly, the diagnosed psychiatric disorders in patients with diabetes are depression, anxiety, delirium, eating disorder, and schizophrenia. So this shows us that, poor glycemic control, uh, to improve the glycemic control, self-care behavior and treatment adherence is very, very important. And because if this is not addressed, then the quality of life of the patient really decreases. So self-care, healthy coping are cornerstones apart from the medication in the management of diabetes. So I covered this slide. The most common emotions faced by the patient are denial, anger, guilt, and acceptance, finally. So, if you catch any of your family members, or if you're a caregiver, or even as a patient, if you hear any of these phrases, like one bite won't hurt, of the dish that you really want to eat but can't because you're on a strict glycemic index control diet, or the sore will heal itself. So I came across a patient, and the patient back in India, he had an ulcer, and we spoke to him and we told him that, you should wear appropriate footwear because the hurt could be very small, like in a non-diabetic patient, if they get hit somewhere or their nail chips off, very less chances of it becoming major. But in patients with diabetes, because of poor wound healing, what essentially happens that even a small lesion, like even a tiny rock, scratching the sole of your foot can become worse. So it's very important to uh, address this. Even phrases like "I will go to the doctor later," missing scheduled appointments with the provider, "I don't have time to manage my diabetes isn't serious, most people have it," you know, all of these are common phrases. And it's very important that denial is first stirred out, you know, and to recognize how denial sounds to gain better access to care, you know. So anger is another common emotion. What I really suggest is that as a caregiver or as a patient, if you do feel angry, it's very important to sort of understand the root cause of anger. You know, is this anger towards myself? Is this anger stemming out of guilt? Is this anger stemming out of, the overwhelm that I have to do so much to manage my disease? Or is it an anger towards, the loved ones because they really can't relate to what I'm going through, or towards the caregiver? So it's important to understand what's making um, you angry, and when that happens, uh, slowing down a little bit, taking a light walk, breathing deeply, drinking enough water. Hydration is very important, and communicating your feelings in a healthy way, if you feel like, or even journaling can really help manage anger. Like I said, there are phobias also that are associated with diabetes apart from anxiety and depression. One of them is the fear of needles and injections, or fear of insulin initiation and hypoglycemia. Although insulin is the mainstay for the management of diabetes, non adherence to insulin is most commonly observed in patients. And the reason for this is phobia. So, why is addressing the psychological well being of the patient important? Because certain studies have observed that by addressing psychological needs, there's an improvement in the HbA1c levels by zero point 0.5 to 1% in adults with type 2 diabetes mellitus. So, it's very important that psychosocial well being is also addressed while managing diabetes. And moreover, physicians believe that psychological problems are associated with worse outcomes. So there are certain guidelines that have been provided to ensure that proper psychological support is provided to the patients, and managing the negative emotions well when they arise in the patients living with diabetes. It's very important. So it's important to manage ABCs. So, what are the ABCs? So, one, A stands for A1C levels. So, A1C, HbA1c is a good marker of average blood sugar levels over 3 months. So, the goal set for many people is less than 7%. But what we're really trying to understand in this condition is that the goal can also be variable among different patients. And this is a very tailored goal that you have to make with your provider. Setting a goal is very important because once you set a goal, you automatically will have the interest to actively participate in your disease management. And it feels really good, to know that your blood glucose levels and A1C levels are in control because of the little steps that you have taken to help manage the A1C levels. And it's very important that everyone talks to their provider or their endocrinologist and make sure that they set a goal for themselves. blood pressure is the second one. That's the B in the ABC model. So blood pressure is a confounding factor for causing heart disease. So the goal is very important, that the blood pressure levels are less than 140/90 for most people. Cholesterol levels, LDL, or what we call as bad cholesterol, it contributes to atherosclerosis and cardiovascular disease. What we call HDL is the good cholesterol. So HDL removes the bad cholesterol from the blood vessels. So getting that balance right, lowering LDL levels, it's raising HDL levels. This is very important because heart disease is a common complication of diabetes, like I mentioned earlier. And we want to make sure that the lipid profile is at least taken care of, to prevent the onset of such complications. And smoking. So if you smoke or catch a loved one smoking or using tobacco products, steps have to be taken to quit smoking. So what is HbA1c? So what are the HbA1c levels? So the sugar in the blood that's present is known as glucose. So when glucose is present in the blood, it ends up binding to the hemoglobin. Hemoglobin is it makes up the red blood cells, you can say. So HbA1c is a marker of glycated hemoglobin. It's essentially saying how much of hemoglobin is bound to this glucose that is floating around in the blood. So the A1C test measures how much glucose is found, and it's a good predictor of the glucose levels that are there in the blood. Excuse me. So HbA1c level is very important because it's giving an update over a long period of time. It's telling us how the blood sugar level range has been over the past 3 months. Because, like I said, hemoglobin is a compound present in the red blood cells, and the average lifespan of a red blood cell is 3 months. So HbA1c levels are going to give us greater information about the trend of glucose levels over a period of 3 months. So this is a pictorial representation of HbA1c. The normal ideally is less than 5.6. Diabetes, the HbA1c levels are between 5.7 to 6.4, and for diabetes, the cutoff is usually 6.5 or 7. So, like I said, emotional well-being plays a very important role in self-care. So, negative thoughts and feelings, can affect how you view yourself. So it's very important that active participation by engaging in healthy coping practices is very important to manage the emotional side of diabetes. So what are certain healthy coping activities? One is being physically active, meditating, finding a hobby, joining a support group, writing in a journal, participating in faith-based activities. These are some of the ways in which healthy coping can be exercised. What is unhealthy coping? Smoking, overeating, binge eating, not finding enough time for activity, avoiding people and social situations because of stigma or fear of being judged, drinking alcohol, taking drugs. These are certain practices which we can refer to as unhealthy coping. So it's very important that healthy coping is introduced while diabetes is being managed. So here are some strategies to use when feeling frustrated frustrated or overwhelmed, start a conversation. This is very important with the healthcare team. It's very important to start a conversation and get the doubts cleared. So tell them what is causing the most concern for you when it comes to care. Talk about your emotions, about your meal plan, the stress levels, the sleep hygiene, medications. It's very important to talk about all of this. Tell your healthcare providers or your care team about what you find hard or frustrating about the concerns mentioned above. Is it that sticking to a complex treatment regimen is hard? Or are you experiencing side effects of medications? Is there any phobia? Is there any guilt? It's very important to communicate what you're finding hard, so it's easier for the provider to talk it out and collaboratively work on finding a strategy for managing the blood sugar levels. And it's important that you describe your thoughts or feelings about your concerns. Labeling the feelings sometimes does help. Find a support group. So support groups are very helpful because these are a very nourishing open space where you can talk about your feelings and emotions in a non-judgmental space without the fear of being judged. It's very comforting to find people who can relate, and it's a common ground for motivating one another. So find a support group. The next thing that I would like to talk about in self-management of diabetes is healthy eating. So the American Diabetes Association offers a simple method of meal planning. The method is described in the pictorial form. In a sense, it focuses on eating more vegetables, such as spinach, carrots, tomatoes. These are non-starchy vegetables. So half a plate should be full of non-starchy vegetables. A quarter of the plate must be full of protein, such as tuna, lean pork, or chicken. Another quarter should be filled with carbohydrate foods. But there are certain carbohydrate foods that do not spike up the blood sugar level very quickly, such as millets, brown rice, and if you have heard of something called fox millet. So all these millets are carbohydrates, but they are complex carbohydrates. They are not broken down into glucose very easily like our flour. So, these can be a good carbohydrate option. And lastly, have a fruit or dairy and a drink of water, or unsweetened tea or coffee, like a 0-calorie drink. And it's also important to use good fats in the plate, like avocados or a handful of nuts, like pumpkin seeds, chia seeds, sunflower seeds, or even hemp seeds are a good source of protein. Seeds are a good, some certain seeds are a good source of protein, but also a very good source of good fats. So diabetes diet, healthy diet and wiser food choices start with planning. So it's very important to plan the diet and sticking to the plan, and planning can go a long way. So it's important to find a registered dietitian or a nutritionist who can really understand the goals of your therapy and can work collaboratively with you, to come up with a diet plan based on your health goals, tastes, and lifestyle. And it's very important to talk about portion sizes that suit the needs for your size and activity level. And what are the essential components of diabetes diet? So a diabetes diet is based on eating 3 meals a day at regular times This is important to sort of tune the insulin response, to make sure that you get used to the insulin that your body is producing or gets through medication. So timing the meals is also very important. So what is glycemic index? When we come to diabetes and food, especially, the word glycemic index, or GI, is spoken about a lot. So I just want to simplify what it means. So the glycemic index is a value used to measure how specific foods increase blood sugar levels. So foods are then classified as low, medium, or high glycemic foods on a rate of 0 to 10. So this is a graph that describes what high GI and low GI foods do to the blood glucose levels. So high GI foods spike up the glucose levels very quickly. Low GI foods spike up the glucose level, but in a very slow fashion. So it's not like going up and down quickly, it's tapering down slowly. So the GI ratings are low, which is 55 or less, medium is 56 to 69, and high GI are 70 and above. So what we're trying to say is that low GI foods are vegetables, non-starchy vegetables. So these should occupy more than about half a plate. Medium GI foods could be certain lentils. That's why proteins are important in the diet. High GI foods are sugars or carbohydrates or flours or chocolates. They spike up the glucose level very quickly. Since diabetes is also associated with foot and foot related complications because of poor wound healing, osteomyelitis, and ulcers, foot care is an important step in the management of complications of diabetic foot. So check your feet every day for blisters, any calluses, corns, for any redness, swellings, or cuts. And why is this important? Because unmanaged blood glucose levels, like I mentioned earlier, can affect the nervous system and cause something called diabetic neuropathy. And as a result of which, patients feel no pain. So when you feel no pain, you don't know if you have been hurt in any way, if there has been a prick. And as we know in diabetes, because of the poor wound healing, the prick can even become a big lesion. So it's important that certain signs are picked early on to avoid a larger lesion. So it's very important to check your feet every day for blisters, calluses, corns, any redness, swelling, or cuts. So this is a checklist that I have made. It's called the diabetes foot care checklist. So firstly, wash your feet every day in warm water, not hot water. After you wash your feet, dry it completely. Make sure it's not moist because that can give moisture can give rise to fungal infection. So make sure that the feet are dry and apply lotion to the top and bottom, but never between your toes because between your toes, the area has a lot more moisture compared to the above and below surfaces, and it can lead to tiny pockets of infection in these areas. So it's important to dry the feet and apply lotion on the top and bottom. Third important part of the checklist is never go barefoot and always wear shoes and socks or socks even while wearing slippers in the house. It's very important to wear socks to avoid injury because even tiny pebbles or any other tiny objects inside the shoes or on the floor can really cause a lesion that can turn big. So fourth important point is always sock your shoes and slippers. It's very important. It's tempting to kind of remove the corns and calluses on your own, So I strongly suggest not to do that. And also not to use over-the-counter products to remove them, as they could burn the skin layer. Get it removed by a trained podiatrist or a trained provider, but don't attempt to remove corns or calluses by yourself. Wear shoes that fit well. For the best fit, try on new shoes at the end of the day when your feet tend to be the largest, but break in your new shoes slowly. Wear them for an hour or two, until you're comfortably settled, until you're comfortable, but wear shoes that fit well. So when to see your provider, these are the common points. If you notice any of this, it's best to go to your provider. Any tingling, burning, or pain in your feet, loss of sensation of touch, loss of sensation of heat or cold, a change in shape of your feet over time, pain in your legs while walking, or cramping in the buttock region or thigh region or calves during physical activity. If you notice any dry skin on your feet, a change in the color and temperature of your feet, thickening of yellow toenails, ingrown nails, any blisters, sores, ulcers, infected corn, any fungal infections between your toes, all of these are certain key pointers to look out for. And if you notice any of this, it's better to visit a podiatrist or a provider before things get worse. Being active is one of the most powerful tools for managing diabetes. Physical activity helps control blood sugar levels and lowers the risk of developing diabetes-related complications. So there's no pressure in the type of activity you choose. You have to be an active participant in your self-care, and that really means that you have to choose an activity that you enjoy, like yoga, cycling, dancing, or spending time with your partner or your children, or being active at the gym. You tailor the kind of activity that you want to perform and set goals. It's very important to set goals. This is essentially to manage weight, So not just that, but also the goals are initiating a certain sense of accountability. And when you naturally are more accountable, it translates into better management of the condition. So the big question, this is very important as to why exercise helps in glucose absorption. So as you can see in the figure on the left, the yellow color dots are the glucose in the blood. Insulin is binding to the blue color peg-like structure and kind of opening a gateway, called the GLUT4. It's insulin binding to its receptor on the cell surface kind of opens the GLUT4 channel, and GLUT4 channel allows the glucose to enter in. So GLUT4 requires the cell to bind to insulin to let the glucose in. It's like a passcode. You want to enter a room, but it has a private passcode. So the only way you can enter the room is if you know the passcode, right? So, or somebody inside the room lets you in because you know the passcode. So passcode is essentially like insulin. Somebody inside the room is the GLUT4 channel, and you are the glucose. The ultimate goal is for you to enter the room. But why exercise is very helpful is that it's the only state in which the GLUT4 channels open up and allow glucose to enter in without the need of insulin, without the need of insulin to having to bind to the receptor. So it's very important that exercise is a part of your regimen because you're increasing the cell sensitivity to glucose without having to need insulin to do that. What is the optimal exercise that's required per week? According to the AHA, it's 150 minutes per week. So setting goals is very important in management of diabetes mellitus and its complications. So working with a doctor to determine what level of physical activity you should engage in. This is also very important because certain comorbid conditions, high intensity training is generally not advised. So speaking to your providers, since they know your history the best, can, communicating them with them and asking them what activity is good for me, or can I engage in this, is very important to know. Figuring out how much time per day you can devote to exercise, setting goals, because once you have clear goals, you are more accountable and you constantly stay motivated. And consider actionable steps. Would you like to work out in the gym or in the neighborhood or in a park? Find the workout that makes you happy. It's very important. And build different activities in your daily routine. And it's important to start slow. It's not mandatory that you rush into something that you aren't ready for. So start slow, be patient with yourself, and allow time for recovery. It's okay to take rest days. You don't have to work out 7 days a week, but try reaching the 150 minutes per week target. And keep track. It's very, you can have an accountability buddy to keep track of the goals that you want to meet and the progress you're making.
Thing. Both mother and daughter were.
It's also important that you speak about your medication regimen and your treatment regimen with the providers, asking them questions openly regarding the treatment plan, the blood glucose target levels, the side effects of any medications is very important in having a collaborative approach to managing diabetes. The next cornerstone of managing diabetes is benefits of glucose monitoring. It's very important to monitor the blood glucose level trend, like I mentioned, since diabetes is a chronic condition. Kind of seeing the trend of how the glucose levels are is very important to tailor medication, tailor the food, that you're eating, and sticking with a healthy eating pattern. To stick with a healthy eating pattern, you need to, we as humans want evidence, right? So the evidence speaks for itself. If when you're eating healthy, if your blood glucose levels are in control, if they're not spiking up, it's a reward mechanism for your brain to want to do more of that. Being able to check your medications and what impact new medications have on the glucose levels, being able to see overall trends and have a positive outlook, when the blood glucose levels are in range, and lowering your risk of high or low blood glucose by having actionable information. So it's important because in diabetes, certain complications of diabetes are hypoglycemia or hyperglycemia, ketoacidosis, and these happen because of either ketoacidosis occurs because of very high blood sugar levels, and hypoglycemia occurs because of very low blood sugar levels. So keeping a track of your blood sugar levels essentially helps you monitor these type of unforeseen situations. So once you rush to the ER, if you have a blood CGM machine and they can see that the trend, or they can see the last blood glucose level, it's below 50. If you're hypoglycemic, they can start an infusion, a glucose infusion or dextrose infusion. So it's important to monitor the blood glucose levels. So there are two kinds of monitoring. One is continuous glucose monitoring. Is a sort of a machine that tracks the trend of the blood glucose levels. And the second one is blood glucose monitoring, which is the finger prick method. But there is a good amount of transition that's happening where patients are opting for continuous glucose monitoring, as this reduces or the chances of phobia that are associated with needle stick or injections, and it is less invasive. So self-care tips for caregivers, because managing diabetes is a collaborative effort between the patient, the doctor, the support system, or the family, the caregivers. So it's very important that I address the self-care tips for caregivers. So a caregiver should also seek social and emotional support when needed. They should reach out to a therapist or join social support groups where they can discuss about their thoughts and emotions in a open, non-judgmental space. They should receive or update their caregiver skills training. Education about the condition or conditions the person you care for is living with is also important. And activity planning for you and your care recipient is also important. Any fun activities, just to sort of break the mundanity is important. And you could also redesign the home environment to make the caregiver's task easier. And it's a beautiful job, having to take care of patients with diabetes and to do it uh, with so much motivation and dedication every day. It's very important that you take care of yourself as well, by reducing your stress levels. Yoga, meditation, um, any physical activity can help with this. Accepting that you're doing the best you can is also very important. And talking and communicating your feelings when you're overwhelmed with a professional or a trusted friend, that's very important. Taking care of your own health, eating healthy, having a good sleep hygiene, sticking to your medication plan if you are taking any medications for any disorder is important, and following a healthy lifestyle overall. So this is for all of you guys that I made that, you're a winner every day. There's no one day that you're going to wake up and be like, oh, today is the day that I excelled, you know. Managing diabetes is a daily process. It's a step-by-step process. It's a lot of baby steps. And each day, each one of you is a winner for me. In case nobody told you this, all of you got this, by attending seminars as such or educating yourself, talking to your providers, you are doing the first step that's required in managing diabetes. Thank you all for listening.
Thank you so much, Doctor. Wow. That was absolutely fantastic.
You're
Coming
welcome.
from India. Yes.
Yeah,
We sure
you're welcome.
appreciate you.
Yeah, I'm so happy to help.
Thank you again. All
Yeah.
right, Jasrina, you want to make your way up here?
Anyone has any questions?
I don't believe we had a question. I checked chat and everything.
Okay, sounds good.
Thank you again, Dr. Modek.
Thank you so much. It was my
Yeah,
pleasure.
Jasrina, come on up. Jasrina, do you want to sit and speak here or do you want to sit up here, stand up here? Okay. While Jasrina is getting set up, I'm going to speak a little bit on her behalf. She is in her final year of medical school, aiming to pursue residency in internal medicine. She is currently completing her fourth year clinical rotations at various hospitals in Los Angeles. Originally from Ontario, Canada, Jasrina has a passion for helping people, learning about the latest medical advances and community issues. So excited to have her here today. And I will turn it over to her.
Okay, hello. Okay. All right, good morning, everybody, or good afternoon, depending on where you might be listening from. Oh. Okay, sorry. Is this better? Okay, hello? I feel like this is better. Okay, good morning, everyone, or good afternoon. Okay, my name is Jasrina Kaushal, and today I will be speaking about diabetic neuropathy. I'm in my final year of medical school, as previously mentioned, and I've had the honor of working with many different members of the healthcare community here in Los Angeles in various medical placements. And for today's presentation, I definitely feel like this hits home a little bit more for me. So before I actually begin, I wanted to just kind of quickly introduce why I'm here today and why I'm speaking about this very important complication of diabetes. So when my grandmother had diabetes, type 1 diabetes, and unfortunately, she's no longer here with us today. She passed away when I was younger, but I have seen how it can affect an individual as well as other members of the family. So I really hope that I can do my part in helping manage and treat diabetes and help people. I have been told by many family members, especially my mom, that I'm very similar to her in certain ways. She had a certain zest for life. She liked bringing the community together. Actually, she was a principal in India, so she really liked helping children and bringing the community together in that aspect as well. So this presentation is dedicated to my grandmother, Shobha Malik, as well as anyone else who might have diabetes or have family members that have diabetes as well. Okay. So during the presentation, we will explore the signs and symptoms of diabetic neuropathy, ways to slow the progression, care management, and interventions. Additionally, we'll delve into the impact of diabetic neuropathy on the quality of life of individuals living with diabetes and the importance of managing and preventing this condition. There are different things that we can look into to help slow the progression, which I'm going to be talking about as well. And we'll also discuss the importance of proper blood sugar management, lifestyle changes, medications, and other forms of treatments that can help manage the disease. By the end of the presentation, I hope that you have a better understanding of diabetic neuropathy and how it affects those living with diabetes, as well as various options available for managing and treating the condition. So I thought I would just give a really brief introduction about diabetes. I know there have been other presentations about this, so I'm not going to spend too much time. But basically, as we know, diabetes is a group of metabolic diseases that's characterized by elevated blood glucose, and also known as hyperglycemia. So when our body breaks down food that we eat into the bloodstream as glucose, the pancreas secretes the hormone known as insulin, which then enables the glucose to be entered into the cells and utilized as an energy source. I like to think of it as insulin being the key that allows glucose to be entered into the cells. And then with diabetes, so diabetes is actually a pretty broad term. As you may or may not know, there are different types of diabetes mellitus, type 1, type 2, gestational, for example. And I'm not going to go into the details of each specific type of diabetes, but essentially your body doesn't make enough insulin or it's not being able to be utilized as it should. And when there isn't enough insulin, our cells stop responding to the insulin. This can lead to hyperglycemia. Chronic hyperglycemia is associated with microvascular and macrovascular contribution, which I'm going to explain a little bit in the further slides. This can ultimately lead to kidney disease, nerve damage, also known as neuropathy, visual impairment, amputations, and heart disease. So neuropathies is actually a pretty broad term as well. It's characterized by progressive loss of nerve fiber function. Our body is composed of so many different types of nerve fibers, which have different functions. For example, touch, or, movement, feeling temperature, feeling pain, for example. And diabetic neuropathy is actually one of the most common complications of diabetes. It can affect as many as 50% of patients. So it is a really important condition, something that we are hoping we can help treat, and especially with ways to slow the progression of it, which I'm going to go into as well. And the formal sort of way to describe diabetic neuropathy is that diabetic neuropathy involves the presence of signs and symptoms of peripheral nerve dysfunction in people with diabetes mellitus after other possible causes have been excluded. This is important because a lot of these symptoms that I'm going to be discussing shortly can be very vague, can also be caused by various other types of conditions. So that's why it's usually a diagnosis of exclusion. Diabetic neuropathy encompasses a range of different conditions that impact the nervous system as a result of hyperglycemia and microangiopathy. What this means basically is that these high blood glucose levels cause the cells that line the blood vessels to take up more of this glucose. This causes the blood vessels to become thicker and unfortunately weaker as a result. And this can manifest in many different ways, but in terms of diabetic neuropathy, these nerves are not receiving the blood because of these blood vessels have become weaker and thicker, and therefore they're not receiving these nutrients that they need to function properly. And this is why this condition can manifest so differently, because it really just depends on the type of nerve that's not receiving these nutrients or this blood supply or the location of these nerves. The main types of nerve damage seen in diabetic neuropathy include distal symmetric polyneuropathy, small fiber predominant neuropathy, radical plexopathy, mononeuropathy. And these conditions can result in significant patient morbidity, increased mortality, and pain, unfortunately. So this is the classification system that was proposed by P.K. Thomas and recently modified in a recent position statement by the American Diabetes Association. I'm not going to go into too much detail about the differences here, but I just think it's important to note that the disease or the condition can be presented so differently. For example, with small fiber neuropathy, we're seeing that it's symmetrical. It's affecting both sides of the body pretty equally. It involves predominantly the sort of distal area, so your fingertips as well as your toes or your feet. And it seems to affect the small diameter sensory fibers known as A delta and C fibers. This can manifest as pain. The patient sort of perceives this as a burning or stabbing pain, for example. There's also a loss of temperature sensation. So that's just kind of an example. I'm going to go into detail about the different symptoms shortly. So I mentioned earlier that distal symmetrical polyneuropathy is one of the types of that this can present as, and it is actually the most common manifestation as well. In type 1 diabetes mellitus, we'll see that distal symmetrical polyneuropathy typically becomes symptomatic after several years of prolonged hyperglycemia or untreated diabetes. Whereas in type 2, we'll see that it can manifest pretty early on, just after a few years. And so with that being said, diabetic neuropathy, like I mentioned, can manifest as a wide variety of symptoms. I've kind of categorized it as sensory, motor, or autonomic symptoms. And this is from a paper that I read recently where the author suggested a structured list of symptoms should be used as a screening tool. So I think this is very important because a lot of these symptoms, like I mentioned, can be very vague. You might not really think it's a big deal, like, oh, like I'm having sort of this pain in my hand. I'm not sure. Maybe I just slept on it weird, or maybe you're not thinking about it like that. But if you have this list, the structured list of these potential symptoms and are more aware of it, I think it could really help in the progression of the disease if patients are able to sort of recognize the early signs and symptoms. So I'm going to begin by talking about some of the sensory symptoms associated with the disease. Sensory neuropathy is usually pretty insidious in onset, most often presents with a stocking and glove distribution, meaning your hands and your feet. Some of the negative sensory symptoms include loss of balance, getting injured and not feeling any pain, feelings of numbness, or sort of a deadness type feeling. Patients sometimes describe this as they feel like they're wearing gloves or socks, but they're not actually wearing gloves or socks. Some of the positive sensory symptoms are burning pain, tingling, aching, and electric shock-like pain, or very hypersensitive to touch. In terms of motor symptoms, we'll see patients are having a bit more difficulty with fine hand coordination in terms of simple tasks. This could manifest as even just, oh, I've been having a little difficulty turning keys lately, or opening jars, tying a tie. There's also foot slapping or dropped foot gait. This can be an early sign of diabetic neuropathy foot weakness. Patients also seem to have difficulty climbing stairs, difficulty getting up from a seated position, or difficulty raising arms above their shoulders. In terms of the autonomic signs and symptoms, this can involve a vast variety of different organ systems within the body. For example, in the GI system, we'll see a lot of patients having gastroparesis, which can manifest as nausea or vomiting after eating. They feel like they're not fully digesting their food properly, which causes the nausea, as well as difficulty swallowing, abdominal pain, diarrhea, constipation. In terms of cardiovascular, this can present as persistent sinus tachycardia, which is increased heartbeat, or orthostatic hypotension, which is when your blood pressure decreases when you stand up, as well as an irregular heartbeat or altered blood flow, as well as edema. Specifically, I would say more so peripheral edema or peripheral swelling of your legs. Patients may also have a poor urinary stream, or they feel like they're not completely emptying their bladder when they are using the restroom, difficulty starting to void, erectile dysfunction. In terms of pseudomotor, one of the more, I guess, specific ones that we're mostly seeing with diabetic neuropathy would be gustatory sweating, which is when the patient feels sweating and flushing of a patch of skin near the ear when they eat their food. So like I mentioned earlier, those symptoms are pretty vague. They can be caused by a variety of different health complications. But in terms of diabetic neuropathy progressing, the diabetic foot ulcer or plantar foot ulcer is the major complication with diabetic neuropathy, and it's affected by both sensory motor and autonomic pathways that lead to the disease. Within sensory neuropathy, the tissue is exposed to increased trauma. The patient doesn't really feel pain, so they don't really feel like anything's going on in their foot, so they don't check their foot. In terms of autonomic neuropathy, we're seeing that there's less blood circulation to the area. Again, less nutrients are being delivered, so it's going to be more prone to infection as well as ulceration. In terms of motor neuropathy, we're seeing that there's atrophy of the muscles, which means basically that the muscles are not functioning properly. This causes increased susceptibility to callus formation, as well as skin breakdown and ulcer formation. So management of diabetic neuropathy focuses on controlling blood sugar levels. That is definitely the main key. I'm going to go into detail about that moving forward. But there are some other things that we look into. I would also like to note that it really just depends on the symptoms. If a patient is presenting with more pain, more sensory symptoms, we're going to treat more so those symptoms versus a patient who might have gastroparesis or difficulty swallowing. We're going to look into those symptoms. So symptom management really just depends on the modality of what the patient is going through at the time. But controlling blood sugar levels is, of course, very key. Medications are geared more towards those specific symptoms. There's also physical therapy, which is shown to be really great. I think exercise is always a great way to improve strength. Foot care is extremely important. I know this was also mentioned in the previous presentation, but I'm going to be going into a bit more detail about that as well. This is just to help prevent the complication, which is the diabetic foot ulcer. Lifestyle changes, of course, eating a healthy diet, quitting smoking, for example. There are some alternative therapies that have been suggested. There's been a lot of research lately on acupuncture as well as biofeedback, as well as counseling support groups, basically helping the overall well-being of the individual. But of course, it's always important to collaborate with a healthcare provider to see what might be best for the individual patient at hand. So of all treatment options, tight and stable glycemic control is one of the most important factors for slowing the progression of diabetic neuropathy. There was actually a trial done recently with the diabetes control and complications trial, which demonstrated that tight blood sugar control in patients with type 1 diabetes decreased the risk of neuropathy by 60% in 5 years, which is pretty huge. We haven't seen, there still are some more prospective studies done in terms of patients who have type 2 diabetes, but basically reiterating the fact that being aware of your blood sugar levels is very key in slowing down the progression of this disease, specifically with type 1 diabetes, but also there are some positive effects that we are seeing with type 2 diabetes as well, in terms of controlling your blood sugar levels, making sure you're taking your medications correctly and at the right time as well. In terms of diabetic neuropathic pain, there are a few first-line treatments that we are looking into. So that would include SNRIs, such as duloxetine, TCAs, gabapentinoids. For more painful diabetic neuropathy, there's also dextromethorphan, morphine, tramadol, and oxycodone, as well as some topical treatments such as capsaicin or transdermal lidocaine. That can be used in some patients, especially more localized pain. So this is just a little bit of an algorithm that I found with one of the articles that I was reading recently. And I think it's interesting because a lot of patients might also be dealing with comorbid diseases such as depression, for example. And if that is a situation, then a treatment such as an SNRI, duloxetine, would be really great in helping that patient who also has diabetic pain because it helps with the depression as well as the diabetic pain. There's also TCAs, but they aren't necessarily first line because they do have a lot of side effects. So this is just, again, just a little bit of an algorithm to help narrow down some of the key drugs that are used in today's treatment for diabetic pain. But I do think it's important to treat the individual as a whole, look at their whole medical history, see what medication might work best for that individual. There's also been some research done recently with the TENS, or it's like a biofeedback machine. It's called transcutaneous electrical nerve stimulation, which is actually quite interesting for me personally because I actually worked at a wellness clinic prior to starting medical school, and we used to use TENS machines on our patients a lot during that time. I didn't know too much about it back then, but I'm learning a lot. And this was a recent study that I read about the TENS machine and in conjunction with neuropathic pain. It was a 4-week study of the TENS applied to the lower limbs, each for 30 minutes daily, and pain relief was noted in 83% of the patients, compared to 38% of patients who were not using the TENS machine, but were on their pharmacological treated group. And with that being said, it seems like this TENS machine could be a really great adjunct to an individual with diabetic pain, and combine this with their pharmacological treatments. Acupuncture is also gaining a lot of popularity these days. There's still a lot of prospective studies that are going on with its effectiveness in treating neuropathic pain, but it's definitely something to look into, I believe. Okay, so we spoke about the treatment for neuropathic pain, which is more of the sensory symptoms we're seeing with diabetes neuropathy. Now I'm going to talk a little bit about gastroparesis. So again, this is when an individual feels sort of an incompleteness, or maybe they're getting food stuck. So I would say first and foremost are lifestyle modifications, small and frequent meals, head of the bed elevated, possible vitamin supplementation. There's also pro-mobility drugs such as erythromycin and metoclopramide, as well as Miralax, which is actually also gaining increased popularity. There is surgery as well, and that's for patients who are experience intractable gastroparesis. This can often lead to very, very severe nausea and vomiting. So that would definitely be down the line if medications or other forms are not really helping the individual. Surgery is available. I spoke about orthostatic hypotension earlier, when the blood pressure decreases as the patient rises. So to help combat that, increasing dietary fluid and salt intake, compression stockings have been shown to help a lot with that as well. In terms of the gustatory sweating, which is when the individual has, they're starting to feel like little sweating as they're eating. There are some compounds that can be applied to help with that. There's also diabetic foot treatments that we're looking into. So if it's in more of an acute setting, we may suggest a foot cast. If it's more of a chronic setting, there's footwear, infection management. There are also medical treatments for infections, as well as surgery if need be. Okay, so we spoke a lot about the pathogenesis of diabetic neuropathy, how it can manifest as well as the treatment options available. Now I'm going to talk a little bit about approach considerations, what we can do as providers or people in the medical community, as well as patients, to treat the disease, slow the progression, and signs that we should look into. At the time of the initial diabetes diagnosis is crucial for the primary care physician to be vigilant for the development and presence of neuropathy. So failure to diagnose diabetic neuropathy can have serious consequences. This can lead to disability, amputation. Therefore, managing diabetic neuropathy from the start would be really key in helping slow that progression. It's important to note that any patient who displays any sort of clinical evidence of diabetic neuropathy should be considered at risk for foot ulceration, and education on foot care should be provided. Many patients end up needing to get their foot amputated or become disabled if this is not taken care of. So that's why this is really key. With that being said, the pharmacist, nurse practitioner, primary care provider should educate the patient on harms of smoking, need for better blood glucose control as well. In addition, patients with diabetes need to be taught about appropriate shoe wear and control of any signs of hyperlipidemia as well, because that could also contribute to the disease. We also recommend being referred to a neurologist throughout the course of the disease. They are able to sort of help in terms of being able to treat the condition a little bit more thoroughly. We also recommend that the patient should have frequent follow-up examinations with a focus on foot inspection once again. In terms of the social worker should be involved in the care to ensure that the patient with diabetes has support systems and that finances, and this doesn't jeopardize any of their care that they need. We also recommend dietitians to improve with lifestyle modifications if need be as well. So it really is a team effort here. The collective should work together as a whole in terms of preventing any progression or any of these serious complications that we can see with the disease. Apart from the healthcare providers, patients should also be very vigilant in the course of the disease. They should make sure that they inform their healthcare provider if they experience any symptoms of diabetic neuropathy. That's also why I mentioned earlier that I think it's great to have the list of the sensory, motor, and autonomic system symptoms at hand for the patient, so they can always direct to that sheet and see, oh, I've been kind of feeling a little numbness in my hand lately. This is also a symptom of diabetic neuropathy. Maybe I should contact my primary care physician to see if anything else is going on. They should definitely seek treatment properly if there are any issues. And again, taking proper care of your feet. I know I've mentioned this quite a few times already, but it really is important. Actually, there was a video I watched the other day about a nurse who works with a lot of patients who have diabetes. And she has her set list of questions that she asks every patient. But she specifically asked, when you take a shower, are you also washing your feet? And a lot of patients were like, oh, I didn't really think about it. I didn't know that was a thing. And she's like, it's actually really important. And maybe it sounds a little silly to talk about, but it's just something that can be incorporated into everyone's daily and something maybe they don't think about, but making sure that they are taking proper care of their feet, washing their feet, inspecting their feet is really crucial, especially if they're not feeling any pain and might not be aware that anything is actually going on. We also could recommend maybe using a mirror to properly check the soles of the feet if you aren't able to see it or just want to be a little bit more thorough as well. There also are ways to protect your feet using lotions. If required, there are special shoes that are available. And I believe Medicare may cover the cost of certain shoes. I'm still kind of getting used to Medicare versus Medi-Cal here in California, but that is something to be looked into as well. And you can ask your healthcare provider about this possibility. Exercising is important, but there's definitely a fine line between exercising too much or too little. So again, this is something like it just depends on the course of the disease, the individual, what they're able to do. But in general, exercise is key. Just have to be a little bit more careful if you do have diabetic foot or foot ulcer. Okay, so I'm just going to talk about a few resources that can be used. The Kidney Cast Foundation, of course, has been a really great place. There's a lot of support education groups, monthly workshops, one-on-one consults, as well as the conference that's held every year. The American Diabetes Association also has their National Diabetes Prevention Program, which is a research-based lifestyle change program. You can check the website to see if there is one close to you for more information. They also have something called My Food Advisor. Not everyone can obviously afford hiring a dietitian, so sometimes it's nice to use these resources to see what type of foods you should avoid or should eat more of to help combat diabetes. Okay, so in conclusion, diabetic neuropathy is a common and very serious complication of diabetes mellitus. It affects millions of people worldwide. As I mentioned earlier, it is the most common complication of diabetes, and it's caused by hyperglycemia over a long period of time, which can result in a range of symptoms that we've mentioned, such as the pain, numbness, tingling, muscle weakness, as well as the difficulty swallowing, excessive sweating, for example. Early detection and management of diabetic neuropathy are very crucial in preventing further damage and improving overall quality of life. This includes checking your feet every so often, more follow-ups with your primary care physician. This can also be achieved through a combination of lifestyle medications, blood sugar control, as well as different types of medication or even therapeutic interventions if need be, such as the TENS or acupuncture, physical therapy that I mentioned earlier. And basically the take-home message that I wanted to bring home today was that, while there's no definitive cure for diabetic neuropathy, effective management can significantly reduce the impact of symptoms and prevent further complications. such as the diabetic foot ulcer, which is the major complication of the disease. Regular checkups with healthcare professionals, including endocrinologists, podiatrists, neurologists, are very, very key and important for monitoring and managing the condition. Overall, it's really important to raise awareness of diabetic neuropathy by promoting early detection. Management is essential, and hopefully we can work together to help combat this disease, prevent the progression of it, and prevent any major complications. Okay, so that's all that I have for today. Thank you so much, everybody, for listening. Okay. Oh boy.
This is coming from Rick. He wants to know, is it possible to reverse neuropathy with blood sugar control in the normal range in type 2 diabetes?
Okay, great question. So in terms of it being reversible, I don't believe it is reversible. However, I feel like it can be more effectively managed if you are taking proper medications, if you're taking care of yourself. I think that's super key. It will prevent the progression of it getting worse. But unfortunately, in terms of being irreversible, I don't believe so, at least not to my knowledge.
Okay, and let's see, Jasrina, we have another one. This is coming from Cindy. What are the contributing factor to diagnostic neuropathy?
Okay, so thank you, Cindy. So some of the contributing factors would include not taking proper medications or not taking proper care of your blood sugar levels. Like I mentioned earlier, the glycemic control is very, very key here, as well as some of those lifestyle modifications in terms of quitting smoking, living a healthy lifestyle. Those can all really play a key role. There's also been some studies that have shown individuals who maybe lead a more sedentary lifestyle that could contribute a little bit more further to the progression of diabetic neuropathy as well.
Okay, this is coming, looks from Angelo. For diabetics already that are on dialysis, what would be the range for glucose suggested, 100 to 200s?
Yeah, that's usually the range that we do look for in terms of glucose control. There's also the HbA1c monitoring that we do as well. But I would say the 100 is a good 100 to 120 is a good range to look into. Once you start going above that or below that, we do get a little bit concerned.
Fantastic. Okay. What type of medical specialty do you aim to pursue?
Okay. So I'm currently in my final year and I'm going to be applying for residency very shortly. I do have a lot of interest in internal medicine as well as family medicine. In terms of specializing further, as I mentioned earlier, nephrology is definitely something that I'm very interested in, just the study of kidneys, kidney diseases, which is also why I'm here today. But I still have some time to figure it out. So as of right now, those are my top.
Anybody here have a question? Those are online.
Yes. Yes. I had a patient who had terrible gastroparesis at one point, and I was wondering, do they ever do? Do they still use what is it, Botox to help with that?
Oh,
It was
yeah.
incredible for her, and I haven't heard that much about it since.
Yeah, Botox actually, it's interesting that you say that. So Botox has been used for a wide variety of sort of esophageal issues. I know that it's been used for something called Zenker's diverticulum, which is when they have a feeling of food stuck in their esophagus. In terms of gastroparesis as a whole, I do believe there is more research being done on that as an effective treatment option. I wouldn't say it's first line just as yet, but I know it's definitely being used a lot for a lot of those types of GI or esophageal issues.
Yeah.
So definitely something to kind of keep in mind as well.
Yeah, and migraines as well. But yeah.
Yeah.
And what about nerve ablation? I have a friend who's got a nerve that's being really hurt, and they're talking about like ruining the nerve root. Would that ever help like with some of the pain from neuropathy, or is it too more web-like in diabetes?
Yeah, see, that would be really difficult for me to answer. I think it really just depends on the nerve that's affected, because in which nerve root it's coming from, because we're not sure if it could sort of alter other pathways and with that if it were to be ablated. So that's really on an individual basis. A neurologist would probably be better fit to answer that question. Yeah, but there's just so much more. Yeah, there's so much research being done on ways to combat this apart from the pharmacological modalities being used. So it's really great that you brought that up, actually. Thank you.
Okay. Could you comment on the prevention of diabetes in the general population?
Sure. Okay. So I think in terms of the general population, leading an active lifestyle, eating healthy, not really contributing in any of these disease modifying situations such as smoking or drinking excessive amounts of alcohol. I think overall being a healthy individual, making sure that if you do have a family history of it as well, be a bit more vigilant on your glucose intake. I would say that's really key. But I think overall, just trying your best to live an active, healthy lifestyle. Sometimes, especially if you're more prone to it in a genetic basis, there's not much we can do to prevent it. But why not try our best to live our best, happy, healthy lives, you know?
Okay, we have another great question here. Can diabetes be reversed mainly by diet and lifestyle in the early stage, maybe within 1 to 2 years of detection?
Hmm. Type 1, definitely not. Type 2 diabetes, if I believe if the individual is pre-diabetic, that's definitely something that can be done in terms of they are dealing with type 2 diabetes. That would be hard to say. I think they would be able to better control it for sure with healthy lifestyle and glycemic control. But in terms of completely reversing it, it would really depend on how the patient did get type 2 diabetes, because there are different ways an individual can get the disease as well. And again, if there's a genetic predisposition, that would be a little bit tougher as well. But in terms of pre-diabetes, I believe so.
Okay. Can you make a comment on the importance of sleep?
Oh, okay. Yeah, sure. I actually think sleep is so important. And I feel like today, especially nowadays, people don't recognize how important it is. So when we sleep, our body actually regulates a lot of hormones, one of them being cortisol. And when an individual is not getting enough sleep, this can actually raise their cortisol levels. And cortisol can actually also contribute to high blood pressure, hyperglycemia, or I'm sorry, high sugar levels, so hyperglycemia. So as an adult, I actually recommend 8 hours of sleep. I mean, personally, if I have less than 7 hours of sleep, I definitely feel it. So I think it's super important, not just in terms of diabetes management, but overall well-being as well. I think 8 hours is a great. I know not everyone can always achieve that, especially if they're a little bit busier, if they have a lot going on, or maybe they have a newborn or a puppy. I don't know, but I definitely think try to get 8 hours if you can. 7 hours maybe minimum, and this does range depending as well on age. So of course, children need a little bit more sleep as well as newborns. The geriatric population, so a little bit older individuals, tend to not get as much sleep naturally as well. So that's something to kind of keep in mind. But 7 to 8 is great.
Okay, great. Thank you for that. Could you possibly comment on the relationship of arthritis to diabetes?
What, sorry?
comment on the relationship of arthritis to diabetes?
Okay. Of Artha, okay. In terms of if they're like can cause one another or just
Yeah, I'd say probably that's it. I'm getting the text here, so
okay.
I would say yes.
Okay, so arthritis is a little bit different. It's an autoimmune. It is also an autoimmune condition that affects our joints. In terms of its correlation to diabetes, I'm actually not sure about that. However, if you do have arthritis and have diabetes, you might be prone to some of the more motor symptoms of diabetic neuropathy, or you might even they might even kind of conjunct a little bit in terms of that weakness that we might see. A stiffness, that's a huge one for arthritis as well, or rheumatoid arthritis, I'm assuming, because there are different forms of arthritis as well. There's like osteoarthritis, which can present a little bit differently. So I hope that answers that question. It was a little broad. Sure.
I believe that sounded great. Yes, Rod.
Okay. Wait, like in terms of the patient education?
Probably, yeah.
Think we got it? Wow. Okay, well, let's give a great round of applause. Thank you, Jasrina. She's
you.
in her final year of medical school. What a bright future you have waiting for you. So
Thank you so much. Thank
We
you
sure
everyone for
appreciate you.
listening. I really appreciate it.
fantastic.
I have a question. I saw the truth in advertisement. Used to be commercials that, okay, with that you will lower yourself to less than 7 AIC7, and by that you're no longer diabetic. Is there a truth in that?
Um, sorry. Oh, okay. I'm so sorry. Would you be able to repeat that beginning part of that question?
Yes, I saw there were commercials, which I always doubt, about some medication that will help you to lower the AIC below 7. And the conclusion was for the advertisement that you are no longer diabetic. Is there any truth to the matter in it?
So there are definitely a lot of medications that will help lower the HbA1c. Is that the HbA1c? I'm assuming that's what you meant. In terms of completely reversing diabetes, I'm not sure about that. I don't know about that claim specifically, but I know there are many medications out there that can really help control the blood sugar levels and lower the HbA1c. I don't think that would completely reverse diabetes, but it definitely is a great treatment option. And again, this really just depends on the patient if they are considered pre-diabetic, type 1 diabetes, or type 2. So I would look at it as a whole and specifically what medication that is and what it's targeting as well.
Thank you. Thank you.
Okay. You're welcome. Okay. All right. Thank you, everyone. I
Thank
really
you,
appreciate
Jasrina,
it.
once again. And we will be getting Dahlia Ackerman up here to let her do her session. She is a BSN, RN, and CNN, and certified nephrology nurse who's worked in dialysis and nephrology for the past 21 years, 15 years as an RN. Dahlia, would you like to speak out of here or out of there?
Sure.
Give you your choice.
All right, thank you.
Okay.
Thank you all for having me. I am Dahlia Ackerman. I'm a certified nephrology nurse with DaVita in Bakersfield, California. I currently work in the home department, and I'm a community educator as well. I have been in dialysis 21 years now, and I started off as a secretary and worked my way through school and became an RN. I've had the pleasure of becoming an administrator, working with new builds of new dialysis centers, and some of our pharmaceutical businesses as well. But I was introduced to kidney disease a lot longer than that. So I think I was 7, and my grandmother was a kidney patient, and she was on dialysis. And I remember the struggles that she went through, but it wasn't just her. So her brothers were also kidney patients and some on dialysis. And then my uncles, her sons, were also kidney patients and on dialysis. And I would love to say that that part of the family tree stopped there, but it didn't. So there's still a lot of kidney disease within our family, and that's a story for another day. But unfortunately, as prominent as kidney failure is in my family, it's been said that you are either a kidney patient or you work with kidney patients. So I chose to work with kidney patients. And that's what brought me to DaVita 20 years ago. DaVita is committed as a healthcare organization to ensuring that patients have the necessary tools and the education needed to navigate every single step of their healthcare journey. We need to understand that diabetes is the leading cause of chronic kidney disease. And I guess I forgot to mention about my family. What caused all of these family members to all have chronic kidney disease? And it is diabetes. It is very, very prevalent within one side of my family tree. But if we only had some education then, as if we have now, maybe things would have been a lot different. Management of diabetes is absolutely key to patient health. Management of diabetes is key to preventing or delaying the progression of chronic kidney disease and, in turn, chronic kidney failure. Anyone with diabetes can take certain actions, lifestyle measures, to ensure that perhaps they do not become one of those persons on dialysis. But if they do, we have education for that as well. So let's delve into a few numbers. 1 in 10 US adults currently are living with diabetes. That's quite a few. That's a big number. 37 million Americans have some stage of kidney disease. And out of those 37 million Americans, according to the CDC, 9 out of 10 of those persons do not even know they have some type of kidney disease. So this is where they correlate. Diabetes causes kidney disease. It is the leading cause. 1 out of every 3 adults with diabetes has chronic kidney disease. And so then why does this matter? It matters because there isn't a cure. There isn't a cure for chronic kidney disease. We have recently teamed up with community resources and community partnerships to ensure that patients become their best advocate. Early management and early detection are complete keys to slowing the progression of this disease. Whether patients are seeking resources on prevention or they've already developed the disease, we want to ensure that they're prepared for what's next. Those resources include Kidney Smart, the American Diabetes Association, and then DaVita's Transplant Smart. Kidney Smart. So Kidney Smart is a no-cost community resource available to anyone. And what you'll find here is education from experts in kidney disease. They'll teach you kidney basics, nutrition tips, treatment choices. It also includes transplant and modality education. It also includes information if a person with CKD does not want to pursue dialysis or transplantation. Again, they're open to anyone. These classes can be done virtually, by telephone, or in person. You can go to this landing site on Kidney Smart and find these resources for yourself. DaVita also recently teamed up with the American Diabetes Association, and it's designed to help people with diabetes protect their kidney health. On the American Diabetes Association at diabetes.org, you will find this landing page right here. You go to Living with Diabetes Kidney Care. It's an interactive online experience. It meets people wherever they are in their kidney health journey. It features free guidance and it removes barriers, improves awareness, and supports people with prediabetes, diabetes, and those who may already have kidney failure. The website is free to use. It's organized a lot like this. So there's 3 spots in which you can go to. I want to prevent kidney disease. That's for someone or family members who may have a family history of chronic kidney disease and they would like some more information. The next tab is I'm living with CKD. That's specifically for patients and family members who may already have diabetes and are known to have chronic kidney disease. There's a lot of information within that tab as well. And the last one is I'm in advanced progression. This is aimed at patients and family members who already have chronic kidney disease, may already be on dialysis, have kidney failure, or are known to be progressing into those later stages of kidney failure. Additionally, on this website, it'll take you into additional information on on the Kidney Smart classes as well. Now, when CKD is a reality, there's really only 2 different options from which to choose from if you want to prolong life, and that's to get a transplant or to start on dialysis. If not managed properly, chronic kidney disease, it will progress to kidney failure. DaVita is dedicated to empowering its patients to choose the right modality for them and at the right time. So in 2019, DaVita developed Transplant Smart. In this tab, you will find quite a few motivating peer-to-peer interviews with patients who are going down the same or who have went down the same transplant journey. It's pretty well animated. It's really user-friendly. And it allows patients to understand what to expect in their transplant process. There's guidebooks and handbooks in there. And there's also a lot of information on how a patient can track where they're at in their current journey. They also have support from a licensed social worker that may be able to assist with any questions and maybe delving into the complicated process of transplant. Now, we really have to talk about when end-stage kidney disease is looming and we have not chosen transplant. We would like to ensure that patients make the best choice for themselves and for their family members. We believe that every patient who is empowered to do so and educated to do so becomes their own best advocate. Kidney Smart classes offer modality education, and in 2022, Kidney Smart developed a home program for modality education. But why home programs? We'll go into that in just a moment. But patients should be able to understand the different modalities available to them. Peritoneal dialysis would probably be my first modality choice. It uses the peritoneum of the abdomen and as a filter to remove wastes and excess fluid. And it's really quite gentle on the body as compared to the other modalities of dialysis. If I had to be on dialysis and had another choice, it would definitely be home hemodialysis, which works a lot like the in-center dialysis, but you do it in the comfort of your own home. It works a lot like the same way. The machine is smaller. It's a lot gentler on the body, and it circulates the blood, removing toxins and wastes. But why home? Why do we put such an emphasis on home dialysis? Well, there's quite a few potential benefits for treating at home. Staying home, for one, not having to go to a center, more quality of life, to be able to spend that time with family, friends, and pets. More flexibility. Patients who do home dialysis have quite a few different options. Some patients will dialyze at night. Some patients will dialyze before work or after work. It allows a patient to feel as if they are in control. And that's exactly what our patients need to be, is in control. There's also some clinical benefits to it. Many home dialysis patients feel less tired, and they report having a shorter recovery time after dialysis as compared to a traditional in-center modality. So, but why home? Why the emphasis on home? Well, the emphasis on home is because of residual kidney function. And why does that matter? So most patients, when they start dialysis, still have some sort of kidney function. We have some data that shows that making even just 1 cup of urine daily lowers the mortality risk by 36%. And that's amazing. But how does a home modality contribute to that? Well, it helps keep the residual kidney function in. I'll give you 2 examples. It's done more frequently, and therefore there's less waste and less toxins in the blood, and they don't build up between treatments like a traditional every other day dialysis. And it helps to regulate fluid a whole lot better. It puts less strain on the kidneys, and both of these things actually enhance and protect the patient's natural kidney function. So in closing, patients understanding their risk factors for kidney disease is highly important. As clinicians and as patients and as family members and advocates for our patients, we want to help everyone make the best informed decision for themselves. Utilizing different resources and community resources such as Kidney Smart, Transplant Smart, and the American Diabetes Association can help patients prolong the effects of their diabetes, prevent kidney disease from progressing. Thank you all for your time.
Thank you, Dahlia. Do we have any questions out here for Dahlia?
So how often is home dialysis? It depends on the physician's prescription for the patient and how much dialysis they actually need. We have patients on peritoneal dialysis who actually dialyze every night, or 6 nights or 5 nights. We have patients on home hemodialysis who will dialyze every 4 days to daily, up to 7 days per week. But why? Because they feel so much better. Their toxins are a lot lower than a traditional in-center dialysis because you're dialyzing daily. So those feelings of nausea and vomiting are decreased much more with home dialysis. You're welcome.
Go ahead.
They are. I actually myself have two patients who've had previous kidney transplants, and they are still eligible to do dialysis. Now, peritoneal dialysis may not be an option unless that peritoneum heals, because we're using that lining of the abdomen. But it's definitely not a no, because I do have one patient on peritoneal with a previous transplant and a few more on HHD. Yes. Oh, the question was with patients who are vegan or vegetarian or who have issues receiving pork products, what other alternatives are there to heparin, which is traditionally a porcine derived medication? So I am not exactly sure what other centers use. Ourselves, we can use a citrate type medication to ensure that the blood is thin. And the other item available on our programs is to just do saline flushes. So utilizing that heparin to ensure that the blood does not clot off in the systems is what she was referring to. And so sometimes saline is used as well. Now, I'm pretty familiar with home hemodialysis, and a lot of our patients don't use any heparin at all because the amount of time that the patient is on treatment doesn't cause as much of the clotting as it does in a traditional center. So educating patients about where heparin comes from and what it is, I think that is an individual clinic conversation to have with patients. Am I aware of an exact curriculum for patients on that? I do not know. But if you do, being a patient advocate, which I believe you probably are, is having those conversations with your patients that may have an issue with that. You're welcome.
I have a question virtually. This person asking, is home hemo gentler on the body than peritoneal dialysis?
Okay, so I will give you my education, and that would be no. So peritoneal dialysis is the gentlest form of dialysis that we have. When we were taught about peritoneal dialysis and hemodialysis, with peritoneal dialysis, you have like these gentle waves, and that's how dialysis goes. And then with home hemodialysis, you have maybe these rolling hills, and that's how a patient fluctuates. And with in-center dialysis, you have what we call the peaks and valleys. So you come into dialysis, we up here and we drain you, and then you feel really bad for many, many hours after dialysis. At least that's the experience. And then we go back up the mountain and back down. So the peaks and the valleys. So is peritoneal dialysis gentler on the body in the manner in which dialysis is performed? Yes. I don't believe they are, but no, not during dialysis. So warfarin is usually oral medication taken for other issues, usually cardiovascular issues, or if you have a mechanical heart valve or atrial fibrillation. It is going to thin the blood, but not to the extent that we would want it to be when we're doing dialysis. And that's why we use heparin. Yeah, so heparin and Coumadin would be the same. You're welcome. Okay, that is a very good question. So there's a few things that you can do personally to not have those drops in blood pressures is one, controlling fluids in between treatments. Also, ensuring that you have the correct target weight that you're going to. So let's just say, and people fluctuate weight all the time, a pound here and a pound there. So ensuring that you have the correct target weight. Also, pulling fluid too fast during treatment may be another issue that you're having these low blood pressures. So what you want is a gentler form of dialysis. So if you come in, a patient comes in with 5 kilograms over, we're there trying to take off about a kilo and a half to 1.75 kilos per hour. That's a lot of fluid to come off at one time. And not all of that fluid is inside of the vessels that dialysis, traditional dialysis, can take out. So the body needs time to move from the interstitial, from your tissues, into the vascular space so we can take that fluid out. Taking too much fluid out too fast is going to cause like the cramping and the blood pressure. Yeah, you're your own best advocate. Patients who are educated are their own best advocates. And if they say, I only want to take off this much and I want to take off this much per hour, as long as you're educated in how to do that, become your own best advocate and understand that, if I take off 1.75 kilos per hour, I am going to have a low blood pressure and I'm going to have cramps. But if I take off 1 kilo per hour, I'm going to be okay. So controlling that and ensuring that you're taking off enough fluid to not get other complications like fluid overload is important. There's a lot of factors that go into ensuring an adequate dialysis, making sure that you don't have as much extra fluid on you leaving than when you came in, ensuring blood pressure is good, and ensuring that you're not hurting yourself. If I were your nurse, I would probably say that you need a higher target weight, that you need to go maybe just a little bit more. Being just a little bit wet, just a little bit over, sometimes may help our patients feel a whole lot better. Remember, when you're cramping, that's also happening on the inside. And when your blood pressures are dropping, you are damaging, that cardiovascular system. So you may need a higher target weight. I would love to be at a lower weight. And when I weigh every day and, I've got this mental blockade, but we need to get away from that mental blockade of thinking I need to get to this weight and actually get to a weight where I'm going to feel good after dialysis. It's going to take you longer to recover. And that's an excellent point right there, is if we don't have that time with the nephrologist that we need during that rounding time, schedule that appointment. That's an excellent point. Yes, of course it does. If that is something that continues to be done over and over again, that water accumulation will occur. So you want to find the correct target weight. Okay, so yeah, the correct target weight. So let's just say you are a person whose target weight is 65.5, but you're having all of these symptoms. You know, perhaps your target weight is 66. It doesn't mean leave half of a kilo every treatment. It just means finding a correct target weight and how much fluid can be removed without you becoming symptomatic each treatment.
In the back, go ahead.
Well, it depends on the patient, of course. Nocturnal dialysis is generally recommended for patients who perhaps have really large fluid gains in between, and that is a more gentler treatment than an in-center. So let's just say you go to in-center traditional and try to remove 5 kilograms in 4 hours. On nocturnal dialysis, you can remove those 5 kilograms in 8 hours, which means there's less pull and there's less stress on the body. So nocturnal dialysis is something that you should definitely speak with your physician about if that's what you're interested in. And if you're having any issues with pulling all of that fluid, or if you have extra toxins and day dialysis is not enough, nocturnal may be an option.
Okay, thank you, Dahlia. Let's hear it for her. 21 years working in dialysis and nephrology. We sure appreciate you. That was fantastic. Great insight and wisdom with family to give some personal stuff. Okay, Ann Pugh's coming up here now. And I will, real quick, she is an MSW, LCSW, Patient Services Manager at Health Services Advisory Group, HSAG, Edge Stage Renal Disease, ESRD Network 18. She has more than 21 years, another 21 years of
Actually,
experience in
23.
healthcare. It's up to 23. So there we go. All these incredibly wise people. We're so blessed. 9 years as patient services for the ESRD networks. Is that correct?
10.
10. Okay. All right. We're just 1 year off on most of this stuff, Ann.
Hey,
So
it works.
also a skilled social worker. She's employed by Sutter Heath's Alta Bates Summit Hospital in Berkeley, California. So Ann, take it away.
Thank you. Will someone be loading up my slide deck for me? It's not on the screen, but you mean like on the desktop, you mean? Oh, okay, good. All right, so I'm Ann. I'm your patient services manager for Network 18. The previous network, which was Comagin, lost the contract to my company in June 2021. The Uncle Sam kind of contracts out work for quality improvement to various, currently it's all for-profit little groups that specialize in making sure that the right care is given at the right time. You know, so our company won the contract. It lasts for 5 years. And I wanted to talk with you guys today a little bit about patient services, which is my part of the network. I worked as a dialysis social worker for 13 years. So I know a lot about the stuff. And now at the network, 10 years. So I know not just a particular corporation and clinic and culture, but I also have had the chance to get to know overarching things for both Network 17, which is Northern California. And now recently I became yours in Southern California, and I'm really thrilled to be here. Got my slide deck yet? Patient services overview, Network 18 on the very bottom. Oh, I can open it. Is that what you're trying to say to me? All right. All right, and we'll go to the slideshow view, which is an F5. Isn't that correct? That's locked. Okay, so we'll go up here and figure it out this way. Slideshow, slideshow, slideshow. Boom. From beginning. Boom. All right. Thank you. Ranta. Okay, I'm a bit of a hyper person. I guess you guys can figure that out. All right, I'm really, whew, okay. I'm also thrilled to be invited to come here. I mean, a lot of the things that CMS is doing now is they're making sure that patients and families and people in the community are getting more and more integrated into care and trying to make sure that the best care is given to everyone that's either has end-stage renal disease. So I wanted to talk to you a little bit about the network and let you know what's going on. I have no financial relationships to disclose. I do perinatal social work. That's stuff around childbirth. So moms and babies, and I do that on the weekends in the hospital, just to get a little direct care practice going, you know. So these are objectives today. I've got a very short time period, so I'm going to talk fast. You guys can wave at me if I'm going too fast. I can slow down some. But I kind of use ESKD and ESRD interchangeably. Some people say end-stage renal disease. Some people say end-stage kidney disease. I think end-stage kidney disease is more understandable, but hey, they're both doing the same thing. I'm going to review the contract goals. And so the way it works is like Uncle Sam comes up with their goals and they kind of put them out. It's like a bid. Everybody bids on them and they say, well, we can do that work for this much money. And this is how we think we can do it best. And then you know, when you get the contract, then you have to do those goals and meet the little metrics and steps along the way to get paid that CMS comes up with. You know, stuff like, 25% of your patients will be more happy by the end of March, you know, stuff like that, right? And then also we do other things that are always been part of the network since its inception, from the very beginning, which I'll talk about super briefly. And I'll talk about that a little bit as well. So that's a little bit outside the CMS part, but all of it helping patients, helping people feeling like they're having a voice, educating clinics about best practices. It's all part of making things better for people that have the need for dialysis, people that have transplanted and may not have as much support, people that don't know whom to talk to, don't know the rules. We're here for you. And también yo hablo bien español, yo puedo hablar con la gente que tiene problemas en las clínicas. Mientras que soy gringa, pues a veces tengo que ustedes repiten cosas, pero les puedo ayudar. Also, all of our resources are in English and Spanish per contract and more as well. So the network was established in 78. We're paid by the Medicare Trust. So out of each treatment, 50 cents goes to the network system. And so there's 18 networks across the country, and I'll show a map what they look like. So it's like, if you think of the US as a piece of pie, there's 18 pieces of pie, and they're all geographical, right? And so everybody in that geographical pie is governed by one of these contract winners. So we're piece of pie 18. And so I was telling you, private quality improvement companies, 5-year contracts at present. So as the contract starts to end, everybody starts to get jumpy saying, okay, let's see if we can get the contract for 18. And I start worrying like, oh, I hope I keep my job. It's very exciting, but we're not there yet. That's 2026. So, and goals overall, there's a few things that I think are really big goals that are just keep coming back. And I'm probably going to use these phrases several times. I want you guys to remember them. And that's right care, right time, and at the right place. I think it's really important and we keep thinking about that because things, I mean, the human condition, all of this stuff keeps varying, right? We were talking about weight. I mean, I don't know, you notice how your clothes fit or not. Our weight varies all the time. So we need to kind of work with patients and patients also with clinics as things keep changing. COVID is an example. How much change do we have behind that? So, and also, let's see, we work with the federal government. The federal government sometimes changes our goals. They come up with things. They said, oh, good grief, there's COVID. We better change some stuff in the network work so they can help with this because we're already in place. Everyone at the network is some kind of dialysis professional. We've got nurses, dietitians, social workers, and almost all of us have incredible experience. And I think we're some of the best, people of our fields. A lot of us have lots and lots of experience and we've been through stuff. We also have good stories, but I don't have time to tell stories today, not very much. But the other thing is also, you guys, if anybody ever heard the phrase "nothing about me without me"? Okay, it's basically the idea is that the patient is the number one person. They should be part of decisions. They should be told about things. They should be consulted. If they have questions, people shouldn't go, you know, if they have a question about like, say you've got a doubt about your care and you think like, I don't know, I cramp a lot. Maybe they're not watching my dry weight. You should be able to say that like, hey, I got a question without getting any crap from anybody. Pardon my French. But okay. So nothing about me without me is the idea that, you know, we need to change healthcare, all of healthcare, so that it's not just we fancy professionals who may be very smart and have great charisma and be very persuasive and speak a ton of languages. That's fabulous. But if I'm not talking to a patient, there's only so far we can go. Right? And if the patient doesn't get it, I don't know. So maybe they understand they need to come to dialysis, but they're miserable. So that's something that and so as a result of that, patients are being integrated into healthcare and communities as well, even more, into healthcare at every step of the way with end-stage renal disease. And you guys probably don't even know this. You may not know even that your clinic has a monthly report card meeting where they talk about their goals. For 3 years now, we've been trying to get clinics to invite patients to these meetings. So the patients can say, you know, you guys are really harsh on us when we're late. We'd appreciate it if you weren't that harsh. You know, just the feedback, for Pete's sake. If we're not talking to our customers, consumers, what are we doing? So that's a big theme here, and I'm going to kind of go on with this. I'm probably going to zip through some stuff because some of it's more interesting to professionals than patients and all of us right around lunchtime. So we are here to make sure the regulations are followed. I know the regulations really well. I know a lot of variations of them. I know the kind of trouble clinics have gotten into and how they get out of it. I'm getting to know surveyors. I know what they're looking for. So sometimes it's a good idea to reach out when things are kind of really not going well. So here's the piece of pie. Here's the 18 renal networks. Ooh, that's a little blurry from here, but you can see 18 is in the bottom part. So my company currently has 5 networks. So we have all of California, we've got Hawaii, Guam, American Samoa, and the Commonwealth of Saipan, and Marianas Islands, basically. And then we also have network 15, that's this big glob in the middle here. There's a lot of that, some of those states have very few clinics, lots and lots of land and cows. Sorry, I'm totally generalizing, but like, you know, Montana, Wyoming. We also have Louisiana at 13. We have network 7, which is a really populous state because of so many retirees that go to Florida. So with age and retirement and having a few miles on those kidneys of yours, you may be more likely to be in dialysis. And a lot of older people seem to like Florida. So lots and lots of clinics there. And also here, it's a warmer climate, nice place to be, Southern California. This is incidentally my first time in LA. I'm based in Berkeley, so I'm really thrilled to be here, you guys. You guys have been so welcoming. But anyway, aside. So this is a current contract. We call it a statement of work, boring, that name. This work is not boring. And so essentially the network gets told by CMS, you have to do some quality improvement activities. And those are kind of like projects, things like all facilities in network 18 are to reduce their bloodstream infections by 30% by May 2024. It might be something like that. And that's told to us and every single other network in the country. So all dialysis patients and all clinics are all working the same goals. And we get graded on them. Yay. Anyway. And then there's patient and family. And also, you know that some of the grading is showing up on the Medicare Compare website. You know that there are it's like kind of the Yelpification of healthcare. There are scores for individual clinics. So if you're thinking about changing a clinic, or you kind of want to see what's going on there are patient experience scores on that website, how well the clinic's doing with getting fewer patients that have high calciums. It's interesting stuff. And that kind of comes from our work with clinics. We process grievances. Grievances are a big deal with a network. We have brochures that I share with facilities. Please wipe me out. I don't want to take my brochures home. I can email PDFs to people. The idea of the network is that I have nothing to do with any of the companies that do dialysis. I'm a neutral third party. I work basically for Medicare and Medi-Cal, right? CMS. And the idea is that people have the right to talk to whoever they want if they're sad. There's no rule that says you must talk to the FA if you're sad about something. You can call whoever you want as a patient, and there's to be no retaliation or retribution for having filed a grievance or asking a question or having pointed out that so-and-so was rude to you yesterday. That's the dream. In reality, it's hard sometimes. I mean, but that's another story. The culture of dialysis clinics is very complicated, and every clinic has its own culture, but there's a lot of things we can do to make things better. And a big part of it is patients and professionals getting to know each other and working together, not just being the professionals that just talk, and that kind of thing. The patients need to say, wait, say that again? As well. But we have to create an environment where that's okay. And that's a big part of my dream, my goal for dialysis. And often I get calls from patients saying, hey, what are the rules around this anyway? And I don't share anything from any calls that patients make to me until I get permission. Because otherwise, it's scary enough for a patient to say boo in dialysis, let alone, oh my God, say he doesn't smell very good. I don't know, right? So it's a good idea to have a neutral third party. You can call anonymously. Sometimes I get calls like, this clinic is always short and it feels so unsafe. Or you can have somebody represent you if you want. Or you can write me, you can email me. Anyway, any way that gets the job done. And I've got all kinds of clever ways to kind of reach people and say, you know, a little bird told me that in your clinic, it might be good if you. And you know, my style is collaborative. I try very hard not to be punishing. Nobody does anything very well, at least not for very long, when you're kind of jumping on them or being scary or frightening or rude or anything like that. And you know, being that I am a representative of the government, you know, it's important that I don't kind of come in too hot on a FA who maybe new, maybe they worked at Target or Starbucks before this, right? Maybe there's really good managers, right? But they don't know dialysis. So anyway, and that's interesting. And again, every network has a different style. So you guys, as you call me, social workers call me just with questions. In general, I tell social workers, like, call when you kind of have done the normal first rung of things and it's still not going great. Not a bad idea to reach out. Email is good because then I can try to put you on my calendar. So grievances, big deal. That's often how I hear from patients. Now, a lot of the patients I hear from are the ones that talk a lot. They may be more, I don't know, but we don't need to get into that. I don't get hardly enough calls from patients. I would like to get more calls from patients that are saying that they have a concern, because over and over, I hear that patients do not feel safe bringing things up. And COVID did not help one bit, because we had short staffing. We were all just terrified. I mean, I remember vividly just kind of thinking like, oh my God, I touched the door handle of my car and my mirror and then my eyes. Am I going to die of COVID? I mean, it's been awful times. And for dialysis patients and staff, it's been horrible as well. We lost a lot of our community in the beginning. I mean, it's been an awful time. So even more, it's important we create a safe place for people to talk about things, and the network is there to help you. I mean, I do the best I can. I mean, often I can offer a training and suggest things, and then they may just need to be done again. Maybe we all need to be reminded how to do things. What's a better way to do this? The other thing the network is tasked with by the government, by Uncle Sam, is to try to help people stay in their clinics. If somebody's not acting right and the clinic is thinking about showing them the door, there are specific rules on that. Every patient should know that the rules are there, because invariably I find out patients think it's really easy for them to kick them out, which is not the case. Or that it's really hard to kick them out. Oh, you're never going to get rid of me. I can do whatever. And you know, the rules are there, and there's a certain point in which the things can tip. And if you're a dialysis patient going in and out of the ER, it's not a good scene, because they're just stabilizing you. Nobody's watching your minerals, your dry weight, you know, your blood pressure, suggesting home to you. Any of the bells and whistles that come along with the actual basic treatment you're not getting if you're going in and out of the hospital. So access to care is a big deal. I do what I can to try to help people stay in their clinics, get back to their clinics. There's been a disturbing trend of discharging patients while they're in the hospital. It's like, what? They're, just because somebody had a stroke doesn't mean they get to lose a dialysis spot. And we're going to be giving education to everyone around this. There is no 30-day rule. You just wait 31 days and Mr. Antonio, who's annoying, won't be able to come back. That's not a rule. Now, there may be a temporary rule in which you can say somebody can't, is not dialyzing at your clinic because they're in the hospital. That's fine. You can transfer them to the hospital briefly in the data system, but it never means, aha, you ain't coming back here. Good luck to you. And these are protections. If anybody's if you hear of any of these things going on, you give me a call. And social workers are traditionally rabble rousers, and currently we're fighting hard for those who need a leg up. And that is dialysis patients big time. We also manage the database that gets you your Medicare. If you need that magical 2728 form that goes to Social Security. We also, now a lot of the outcomes things by which clinics get graded go into the system that we maintain. I've got a colleague, Rosa Rincon, she's great. She helps people with all those issues. Like, why can't I enter this person in the database? It says they're already there. That kind of stuff. I get to pass those on. I'm happy about that. Okay, and then we have our own little things that we have to do. Like the government will say, like, hey, Ann, we want you to look for trends among the grievances for the third quarter of 2021. And I'll go through them and I'll be like, damn, look, there's a lot more staff-related stuff. That's a trend. And you know how it is. When you're busy, you don't notice the trends, really. You have to slow down and say, okay, it's trend time. And your clinic does this every month, by the way. Every month, your clinic looks at the trends in the clinic. Things going good, going bad. So that's an opportunity where patients can kind of weigh in because, how do you change some things, staff-related, for instance. But the network, we have various things we have to do. And if we do them well and on time, we get the money that we've been promised throughout the contract. It's really fabulous. I have less to do with the money part. Overall, these are the goals for the next 5 years. We're already, 2023. We're getting to the halfway mark. Behavioral health outcomes do really fast. They want us to get as many patients screened accurately for depression. And the accurately, before you ask me, what does accurately mean? It means hopefully getting the patient to tell you how they're really feeling, as opposed to, I'm not going to tell you what I feel because then you're going to be laughing, right? So accurate depression screening and its lovely cousin anxiety, a lot of anxiety and worry in dialysis. It's so scary, right? And then also the other secondary goal is to get as many people that screen positive to get help from a mental health professional. And that's been expanded a bit to include clergy and like LCSWs and MFTs. Mental health professionals doesn't just have to be a psychiatrist with their pills. It can be different ways. And then the big one, engaging and incorporating the patient into their care. In an ideal world, you would be asked and somebody would actually slow down how you felt between Monday and Wednesday. And then they would gauge your treatment settings to that. But, dialysis is a bit of a routine treatment and things go so fast. There's a little bit of a conveyor belt mentality. And it's often hard for patients. I mean, think about how fast the doctor's around. It's really hard to go, when you finally think of what you want to ask because the doctor's already over there. So there's ways and ways to get your voices heard, and we can talk about that. One of them is to ask to kind of be a patient representative in your clinic. You can talk with other patients. Every single clinic has somebody who knows how the patients are feeling. It's like the one who watches and talks to others in the lobby because their ride is always late, And if you go up to that person and say, hey, how do you think things went on Saturday? Saturday, I know we were short. That patient will tell you, everybody was cool, except 2 people had to sit in the lobby for an hour and a half. You guys might want to, so it's like patients can tell us stuff. And if the professionals don't slow down, you guys aren't going to feel comfortable asking us either. And we won't feel, and so it's something that we both kind of have to kind of go, ooh. And if you need to write a note, put a Post-it on the window where the AA sits, however you get the information through, it's important because your care will get better in that way. You'd be amazed when a clinic actually listens to a patient and enacts what a patient suggested, the power of that. I like to tell a story about a patient's wife who all she wanted was a hook to put her purse on in the patient's bathroom. Little thing, right? But it's powerful because number one, the professionals never go in that bathroom. So they don't even know what's going on in there, right? And number two, the clinic was like, oh, great, they put it up. And that woman after that was like, she was telling people like, hey, tell them your ideas. That's my hook. I came up with that idea. And it's powerful stuff. And some of it may be dreaming. If you're a clinic who's got a new FA and they're short all the time, and you're in a huge nursing home facility with lots and lots of very sick patients, they can probably still put a hook up, right? Maybe it might take a while to get barbecues in the summer, but hey, it all starts by, what is it? The squeaky wheel gets the grease. If you don't say it, it won't happen. Anyway, then improve patient safety and reduce harm. You guys can read this stuff. If the social workers can tell the patients all the goals that all the networks are working on. Some of them are in all clinics. Some of them are in in clinics where they're not doing well. Some of them, some clinics have been in a home dialysis project and they've gotten so many people on home, they're out of the project now. It's all this different stuff. You don't need to know the ins and outs of that part. Getting more people actually waitlisted on a transplant. It's really easy to refer people. Hey, here's the number. Good luck. Hey, hope you get a transplant. Yay. But what happens between handing that piece of paper to a patient and getting on the list? Often patients think they are on the list. It's awful. It's really a very sad thing when you hear that. Luckily, the rules have changed so people don't get as penalized for not following through. But so that's something that we've been working on with some success. During COVID, transplants slowed down almost completely. Again, decreasing hospitalizations, that one's really interesting. So many things that are kind of nothing about me without me kind of stuff in hospitalizations. Right care, right place, right time is a big thing with hospitals. If the hospital can get a patient a PT evaluation that they can't get in the community because of a wait list, maybe that patient won't fall so much when they get home and then they won't come back to the hospital, right? But it's like, it's kind of patients need to be telling what's going on. The professionals need to slow down and listen, doctors as well. And through that, we can make things better and reduce some of these incredibly bad things that hadn't happened to patients. And kind of nobody's meaning bad things to happen, but maybe we're too busy or something, or the patient didn't say the right word and the professional didn't go, whoa, wait a minute, you said what? So these are things where if you have an open communication and you're focusing on getting right care, right time, right place, and nothing about me without me, and actually trying to be where the patient's at, I think it's a very good thing. There's a very sad propensity in dialysis, especially when payments started getting linked to outcomes, that professionals just figured if they could just scold people enough to think that patients would do better. If you miss any more treatments, you might end up in the hospital, or you miss 3 treatments, now you have to go to the hospital. And it's like, well, couldn't we maybe dialyze me slower, maybe for half the time, so I don't have to sit in the ER? There's options. But fear and kind of telling scary things to people, it only goes so far. And if you don't know what the patient's going through, that patient may just tune you out. How many people have seen patients close their eyes and pretend to be asleep when the dietitian is going around with report cards? Me too. I'm like, wow, there's a lot of people sleeping here at 2 p.m. But, and often that can be a sign of just so much lecturing. It's like, yeah, I know ice cream isn't good for me. All right. So if you want to talk to me about it, you better slow your roll because I've got this roll because I like ice cream. And so you have to use some tact, Anyway, so that's enough. Some things are changing. The COVID work is being taken out of our contract and maybe substituted with some other things. There are rumors that maybe the network will be looking into weight and I think diabetes management. Anyway, we'll see. It's all the man. So patient experience of care is exactly what I was telling you about. This is straight up the work I'm doing here. The grievances, the access to care, patient discharges, facility concerns. Some things I can only be supportive in. I can't stop a doctor from getting rid of you if the doctor is done with a particular patient. I can, however, talk to the doctor and say, hey, well, what have you done so far? Does a patient even know that you feel so doubtful that you can help this patient because they won't tell you what's going on? If the patient doesn't know, I think it's really unfair to say, I can't work with you anymore. You know, so sometimes with my persuasive ways, I can work that kind of thing. The other thing I can't do is make a doctor pick up a patient. If a doctor has a practice that's full of complicated patients that are all angry, they may say, you know, I can't take another right now. And I, you know, as long as they're thinking it through and just not kind of being like, I'm just tired of all y'all. You know, I dig it. You know, doctors have a lot of rights. It's a very individually motivated society here. So there's some things where the network can help and some where we cannot. We also can't force a clinic to take someone. If a clinic says no and the medical director says no, I may grill them and go through their paperwork and say, show me that schedule that's so tight. Let's look at that together. There's ways. But also, anyway, and it also depends if the patient even wants to go there. We've got a closed Facebook group. We're running a peer mentoring program. It's pretty neat. A lot of patients say, there's so many things I wish people had told me before when I started. I want to give back. I'm okay now, but it was so hard. We've got some Spanish speakers. You can be paired up individually with a mentor. My colleague Brittany runs the peer mentoring in Network 18. Facebook is neat because you can kind of go on Facebook whenever you want to, and you can write things and you get real-time responses from maybe a patient somewhere else who can't sleep. Also, Facebook never asks you like, but how are you really? You know, and Facebook doesn't see you crying. At least I hope not. Anyway. And the other newest thing, and I'm probably going to wrap up pretty quickly after this, is a life plan. And that's not an advanced directive. It's not about like, you know, crafting the plans, what will happen to you should you start to die. It's not about that. The idea is currently the framework in dialysis is when it's time for your annual assessment or your 90-day assessment, the team all come up to you and they ask you a whole lot of questions, right? And then there's a meeting and you're invited to the meeting with a whole lot of not very much pressure for you to come. They may give you a paper and say, it's coming on Wednesday. You may not want to go, but here you go. But anyway, the patient should be invited to the meeting. This is where, if you got some things going on you want to talk about, nothing about you without you, right? You should be at the chair saying, hey, you know, looking at my calendar, like I cramped really bad 7 days this month. What's up with that? You know, that's something a patient can say. And it may be better with the whole team because there may be all kinds of things. There could be the salt you're eating. There could be the changes in activity. There could be a medication. I don't know. There's a lot of things that get into things. There's no single answer. And then people are all different as well. But the thing with a life plan, and so currently the care plan system is set up. The patient decides to show up, then the professionals tell the patient all the things they're worried about. And then say, do you have anything to say to that? And that's the same old model. That's us, like Charlie Brown's parents, you know, whoa, whoa, whoa. You know, many patients, like most of us, we're adults. We know what we're supposed to do. We're not doing it to piss the professional off. You know, so it's the idea with a life plan is to talk to give a patient a piece of paper or maybe ask them 2 key questions saying, hey, if you had a magic wand, what would you like to be doing in your spare time in 3 months? Isn't that a great question? Or if you had a magic wand, what is something you used to do that you would love to be able to do again now? Because a lot of people, nobody's asking these questions of them. Any of them, it's often the social workers or their friends or family. But if you start with that, and if you bring the answers to even 1 or 2 questions like that to the care plan, and you say the patient's piece first before the doctor starts launching in on, so what's going on with anemia here? Are they getting their Mircera? You know, which is all very important, right? But if the patient wants to be doing something such as traveling to a country where it's very hard to get iron drugs, or something, then if the patient says, well, I'm actually traveling to Mexico next week to visit my auntie, and the doctor sees that the anemia is high, like say the hemoglobin is very high, the doctor may say, well, in that case, let's just not change this yet. I'd rather you go down to Mexico with a little bit higher stuff in you, red blood cells, I don't know what all this stuff is, but that'll be better for you, just in case the clinic does not have the drug you need to keep your red blood cells up. And so there's ways and ways, if you know what's going on with the patient, the team can react accordingly. And it's just, it's not, this is something newer. It's, I'm going to give you a sample of a care plan here, of a life plan here. Oh, let's see. Depression outcomes. These are just some numbers about, there's a lot of depression in dialysis. It's a very, very hard treatment. And people are very tired. And there's a lot asked of them. And often the cultures in clinics and dialysis are hard. And some of the education that the lovely Davida lady gave a minute ago, some of that just doesn't even penetrate, because if you're burnt and exhausted and you're getting a headache because your blood pressure is dropping, you can't hear. You just want to go home. So a lot of the good things that are out there are very hard. And so a lot of these can lead to depression. So sometimes we have to kind of back up the bus and forget about all the numbers and your weight and all this and say, hey, maybe it might help for you to talk to somebody just like you about your age who's gone through this a little longer than you. It can be amazing, because like if you talk to another patient who's going through the same thing, it's like you don't have to fill in all the background. You can say, oh my God, you know, like my flow rate, they keep changing my flow rate. You don't have to explain that to another patient. You know, and that can be a real blessing. And you don't know it until you try it. I mean, again, we professionals are great, but talking to another patient can be very helpful. And these can help a lot with mental health and anxiety. It also can make you realize that you're not alone in how you're feeling. Grievances, here's my number. This should be posted in all your lobbies. There should be posters up from Health Services Advisory Group, not Comagin. If there's a Comagin poster up, it's got a dead office address on it. So that needs to come down. And I always look at a patient grievance as it's what the patient thinks is not up to their standards. It doesn't matter whether or not the standards, whether other people agree. It's about talking with the patient. We help clinics give better care. I've talked about that. This is about keeping patients in the chairs and in outpatient centers in the community. I do a lot of work in this. Periodically, some doctor says, oh, just discharge them. And the social worker calls and says, hey, Ann, doctor wants to discharge. And I was like, why? And we get into it. That's a way we can help protect patients and also educate, because we're all human after all. And doctors as well. Sometimes they're like, you know, they're not coming. Why should I put my time into them? Well, I get the feeling, but there's rules behind what's expected. You know, Uncle Sam is paying the lion's share of all of this dialysis care, transplant care. We don't give up on people lightly. And there's certain things that are expected. Failure to place, I spoke about. A patient that can't get into a clinic for whatever reason, we call a failure to place patient. And I put a lot of time into those. I often get to know patients and work with them for months to try to figure out, like, where could things change to make it better for the patient and the staff. Some patients maybe should not be in clinics right now. Maybe they should be in the hospital and be stabilized psychiatrically. Maybe their wound care is so intense that their insurance needs to pay a little bit more money and send them to a place where they get serious wound care for like 2 weeks. I mean, rather than kind of doing the outpatient thing and seeing if the guy shows up, you know, there's ways and ways. And sometimes we can help social workers advocate for you because we've been through this. Here's my big plug. I need more patients to work with me in the network. We've got opportunities to be on coalitions where you just kind of hang out with doctors, nurses, social workers, other patients to hit a particular topic. Or we've got other groups where patients work with a group of 29 other patients nationwide to create new ways to look at things. I'm going to share some of the patient-created resources in our next newsletter. Some of them are amazing because, again, the professionals make your handouts. But what if the patients made the handouts? What if the patients did the layout and the colors and the choice of words and the way things are put? Some of these are really great. We also need peer mentors if anybody has any patients that need peer mentors. But going forward, I always have a group of patients I can work with and I have to work with. I'm going to be reaching out to all the centers saying, hey, You have a patient who has great ideas, who's always watching, which is many of our patients. What else do you do on dialysis? Go ahead and ask them to work with us, and we can maybe help them work with you guys as well. Because there's ways and ways to give feedback as well, and we can help with that. So that's my plug. Social workers, help me out here. And patients, put your hand up. If you hate doing it, what the heck? You've tried it. But it can be fun. It's not a big ask. It's usually like an hour call once a quarter. These are the goals for the next 4 years about how to increase incorporating patients and families into dialysis care. It's a big need. They're trying to we're trying to redress the power balance. The patients should have way more power and much more of a pulpit than the professionals, because you guys are doing the hard work, and you're also working when the professionals are off at Disney World or Disneyland. So the patients, I mean, we need them more at the table, and we're asking, and we know it's a big ask. So anyway, this is a sample life plan. What's bothering me? I want to be able to maybe get towards this. I need to talk to these people. And you fill this out, bring it back to the social worker, and you guys talk about this before you launch into the usual questions. So who's in your corner? How's your insurance? Are you sleeping okay? You know, these are normal things. This is different. What do you want out of why are you doing this in the first place? Are you doing this to live and see your grandchildren? To become a bodybuilder? What's going on? What do you want out of this? And then the social worker currently will be bringing it to the team and starting the meeting with that. This is newer. It's a little harder to get our heads around. But I think it's important. It could really change our care as we know it. And I thank you so much. I went like 4 minutes over, but I thank you for your time. I'll be part of the panel so you guys can ask me questions. You got a question?
I have a question for you from two people virtually.
Aha.
They are new to dialysis social workers, and they want to know from you, is there any particular academic articles that are must reads for them?
Well, we share articles every 2 weeks. There's an attachment you probably just gloss over as social workers because there's so much, right? But every 2 weeks, we share the latest, most interesting things that are coming out. Must-read articles. I've got some must-read resources. One of my favorites is What Do You Do When Your Patients Don't Come to Dialysis? And it's really good. It talks through the regs. It talks to all the reasons people may not come. I was asking about gastroparesis. You can't do dialysis if you're throwing up and having diarrhea all the time. Certainly not in a center. And it might be an infection risk with PD, right? So it's like, you know, but it has a lot of things. I can share I've got 2 emails that are greatest hits of how do we get patients to, how do we get past like what we have to do as professionals, and how do we bridge the gap to what patients want to do? And so I've got a lot of resources with that, a lot of different ways to approach things. I've got them all grouped in one email. It's a lot. And then I've got another one that's essentially, how do you deal with people that are mean or abusive or angry, and they take it out on the dog? The staff, right? It's very human. If you're pissed off and angry, next person that walks in, you're like, "Nyeh." And that's normal. But patients sometimes get crap for that. Like the nurses be like, you need to lower your voice. And they get a whole lot of, but it's normal to be upset sometimes. It's normal to have a bad day, right? On the same end, there are some patients, and often it's mental health issues, they can't turn it off. They're always just saying crummy things to people. And that's terrible, because the people that are being told these terrible things all the time are those that are keeping lots of people alive. And they also have families and stuff. So there's ways and ways. Those are very important things to know the basics of, because those are the 2 big things. There's like aggressive and abusive behavior. Sometimes that can even lead to violence. And our clinics are at least the in-center clinics are very vulnerable. We've got patients that are not in tip-top health that are tied to chairs with their blood outside of them. So that's something where if you've got somebody who's escalating to the point that you're worried about something, there's things as a social worker you must do earlier. And even if it means not treating that person that day and saying, you know what, buddy, we'll try again on Friday. Anyway, so I'll help with that. It depends what kind of article she wants. I'm a bit of a dialysis nerd, I must say. I got lots of stuff. So they should reach out to me and let me know exactly what they would like.
I have another question now. A dietitian is saying, how can she reach out to your network?
Oh, so my email is right here. I've got all the names here. It depends what she wants to ask about. She can reach out to me and I can direct her. And if it's something I can't answer, I can find people that can. And there's also my phone number on the slide here. It's 650-389-1082. And it's a direct line, so you won't have to listen to, hit 1, hit 2. You don't have to do that. You can just call me. I may not answer. I have to call you back. But anyway. That's it. Thank you. Thank you so much for your time. So glad to be
Question in the
here.
back? Go ahead.
Question. Call me. Let's talk. It's illegal. It's not okay. There's a few caveats with that. It's very hard to be, I don't know. Sometimes I think about the times I've been written up at a job, and it's happened. Full disclosure. It's really hard to be normal again after you've screwed up professionally. And so sometimes patients will see their staff being more distant, and they'll think like, great, this is how it's going to be. Or they can be overtly retaliating. I find a lot of patients are not really, I find there's a gap between professionals. You ask a professional, do you feel like you've ever retaliated against someone? The professionals be like, oh no, I adore my patients. I love them. Oh my God, big hearts. People that give dialysis are very well-intentioned. And we think of things like I would never jab them harder or not give them the lidocaine or anything, and then you ask a patient, the patients are worried about more subtle things in general, totally in general, but it's stuff like maybe people are not joking with you anymore, little things. And dialysis is not a fun thing. And it really sucks to have people kind of not looking at you or not giggling. It's the little things that get people through treatment. You ever go to an infusion center for people that are doing cancer treatment, the nurses half the time are sitting with patients just jawing. So it may feel like retaliation or retribution, like say the boss changes your chair the very next day. I often tell bosses, hey, this patient took a risk telling you how they were feeling. If you're thinking in general about rearranging TTS shift 3, don't do nothing to him for a few weeks. Even if I understand, boss, you're doing it to make your money work, whatever. But he's gonna, it's hard to point out, it's hard to criticize in any way. And dialysis even more. And we can talk it through as well. There's different ways. Sometimes it can be good to be paired with a different tech for a while, so both parties can kind of get their bearing back. Because sometimes, stuff happens, right? But as long as it's addressed, most of us can get through it. Provided we don't die or something. But, many things that don't go well in healthcare, if you kind of approach them with an open mind and fairly and privately, if the patient prefers, if I were a patient on dialysis, I would want to be called when I've got my slippers on, I've had my lunch, and I'm at home. If something happened during Wednesday and you saw me blow off steam, I would love it if the social worker called me on Thursday and said, hey, Ann, even if they weren't there, said, hey, what happened on Wednesday? Somebody told me you were kind of hot. I would love that, because then I can say, what's the real deal is? That person needs to slow down when they talk to people, because I just felt so disrespected. And then social workers in general, we know how to interpret things, hopefully to keep you safe. Also, we know tricks. The social worker can say things like, what? Maybe we'll just do some education for everybody about how professionals come across. Professionals often just need to be reminded. We're so busy, we wouldn't even see an elephant walk across the room because we're not even looking at patients' eyes as we cannulate patients. We're just, so if you're feeling that for reals, give me a call. We can talk about it a bit. I do have some really good patient-created resources, again, on retaliation. It's very hard to get at the meat at it, but if somebody's feeling it, it's real, provided they're not delusional or paranoid. If a patient calls me and says that they've put ants into their bloodlines, it's a little harder for me to do retaliation on that. But people may not be telling that patient what they're doing as much because they're kind of freaked out now. So then maybe the patient runs with it. So there's a lot of stuff in that. Thank you. Good question, man. Sir. All right.
Okay, let's give it up for Ann. Wow.
Thanks, you guys.
MSW, LCSW, everybody's got her numbers.
I've got business cards over there and handouts, grievance brochures. Wipe me out, please.
Fantastic. Wow, that was just wonderful. Without further ado, we will introduce our first speaker for the second half here. She is an attorney at law with PC Immigration Law Firm. Please welcome Elham Sadri. Thank you.
Thank you. Thank you so much. Hi, everyone. I'm Elham Sadri. Can you hear me now? Better? Here? No, that's too close. Then I need this one. Should I turn off? Okay. Is it better now? Okay. So, hi, everyone. I'm Elham Sadri, immigration attorney in San Jose, California. We mainly represent immigrants across the United States in their family and removal proceeding, in their humanitarian basis. And the reason that I'm here, how my work relates to you, is that there are a lot of patients out there are using public benefit to receive their medical care, right? So receiving those public benefit may impact their eligibility later down the road for changing their status or getting green card and legalizing their status here. So it's important to know what they are using now and how they're using and plan ahead. Doesn't mean that they shouldn't use that benefit, but they need to plan ahead to make sure that they are not jeopardizing their future immigration status. So the concept that I'm talking about today is about public charge. Public charge is a concept that have been hot topic last few years because last administration expanded definition and using public benefit for immigrant and wanted to punish most immigrants for using public benefit. They eventually it was litigated and eventually was withdrawn. Later, a couple months ago in December, they passed new law. So now that's why we're talking about it, because there are a lot of misunderstanding about public charge and using public benefit by immigrant. Okay. So those misunderstanding about public benefit are in many different categories. People may be worried about if they use those public benefit, the government will find them and track their location. Or another misunderstanding is that if they use it, their family or children, U.S. citizen children, are using those benefit, that may impact their immigration status. Another thing that they may think they should stop receiving benefit, which is not. We will tell you why. And I think they may think that their family cannot access to those benefits. Well, I'm going to start with defining what is public charge. Public charge is a person who likely to become primarily dependent on government for income purpose. Well, the definition is vague in our point of view, and it's saying primarily dependent. What if they use some sort of benefit, but it's not primarily? It's temporary. So we can still argue that it's not primarily affecting the person. So patient can still use those benefits, health benefit, nutrition benefit, children benefit, right? And it might not be considered primarily. And it might not be for income support. It might be just for health benefit, might be only for food benefit. So that there are still ways to argue around it and find a way to help the person legalize their status, but still they use those benefits before in their life. So there are programs are counted specifically, clearly by government as public charge. The first one is cash assistance for income maintenance. So any cash assistance, no, definitely. We can't do anything about it, right? And long-term institutionalization, long-term hospitalization. Not many people may use that, but we will get under what category they may end up using long-term institutionalization. And I don't know the font, why it looked like this, but anyway. There are programs that benefits that don't count toward public charge. CHIP, SSA, housing, public health benefit, any benefit that relate to immunization or testing for communicable disease. These are strictly listed in the final rule that came out December. So it's on the rule with this detailed information. Any benefit that is related to education and childcare. Any benefit related to disaster relief, pandemic, any benefit that people received during pandemic, those check that they received, vaccination, medical treatment they received, test they received, all of them are okay because that's listed here. Rehabilitation for short period and home and community-based services. So if someone is, there's a part of it that are tricky. People are eligible for Medicaid, okay? Medicaid itself is fine. Immigrant can use it. It's not subject to, it's not a public charge. But what if they use long-term hospitalization benefit from Medicaid? That part is not okay. That part is public charge. That means primarily dependent on government. And we can still argue around it depending on other factors, but that part of Medicaid is different from whole concept of Medicaid. So it's okay to use Medicaid, but long-term hospitalization, it's different. And rehabilitation. So if someone received hospitalization, then move to rehab, that's fine. The rehab part is not count as a long-term hospitalization. So knowing that ahead of the time helps a lot because you can plan your benefit that you're receiving based on how and where to receive it, if possible. Imprisonment, well, that's an institution, but it doesn't apply here. That not count as public charge. Unlawful institutionalization under federal law, which if someone is ordered to be in an institution for a long time by court order, which is unlawful. Well, people, when they want to apply for green card or legalize their status, there are different ways. There are three main categories. People can apply for green card and legalize their status under family category, family-based green card, employment-based green card, and third category is humanitarian. For the first two categories, if their family is sponsoring them or if their employer is sponsoring them, they are subject to public charge test. That means government tests them, whether or not they have used public benefit and whether or not they are public charge. So 2/3 of those immigration cases are being tested for public charge. That's why it's very important to know, and most people worry about it. But there are humanitarian category, which mainly people are victim of a crime here, either here or out their own in their own country. They are receiving these reliefs because they have been victims. So they are not subject to public charge. They don't test them whether or not they have used public benefit while they were immigrant. So those categories are, the first one is refugee and asylee. Whoever is afraid to go back to their home country because they either have been persecuted before or they are likely to get persecuted in their home country. So if that person is here, they had to use Medicare, Medicaid, and then long hospitalization, they're not even subject to it. That's fine. For another category is U visa and T visa. A lot of people are here, they're immigrant, they're a vulnerable community, they get victim of crime and like domestic violence, robbery, felony, or T visa is for human trafficking. We have a lot of it, but unfortunately, sex trafficker, victim, and labor trafficker. So those people are also not subject to public charge. And if they used public benefit before, that's fine. they don't test them when they apply for this type of green card. WAWA is for Women Violence Against Women Act. That means women and women, doesn't matter. The law says women, but it's applying to women and women, and in any concept of relationship that if they have been in abusive relationship, but there was no a police report, and they didn't report it to police for many reasons, and they have been in abusive relationship with a U.S. citizen or green card holder, they can apply for green card because of the nature of their relationship, and they don't need the U.S. citizen spouse to sponsor them. The situation of that person just getting out of that relationship and stepping up and getting back their own independence, they need this support. They need this green card to get their green card, get work authorization, and also if they use public benefit, they are forgiven. That's fine. Okay. So DACA holder, that's another category. TPS, a lot of it stands for temporary protection status. There are a lot of people here from different countries that are subject to TPS. For example, Afghan, people from El Salvador, Ukrainian. These, depending on what's going on in those countries, government give them every 2 years, give them a TPS and keep renewing it. It's not a pass to green card, but if they are using public charge, that's fine. And people who have already green card, they're on green card for 5 years and they want to apply for citizenship. They don't test them for public charge. It doesn't matter if you use public benefit during the time that you have green card. And then we're going to talk about what is the test that government is running to see if someone is public charge or not. Current public charge policy that came out back in December is focusing on affidavit of support and totality of circumstances. Well, there are situations people have to use public benefit, health benefit, nutrition benefit, childcare benefit, right? So how we can explain to the government that that was temporary, they had to use that benefit, but they're not going to use it anymore, or they won't likely be dependent on government later down the road if they get green card. The first way of doing it is affidavit of support. There's a contract between their sponsor, the family member who sponsored them, right, in the first category. And second category of people who wanted to apply for a green card were employment-based, right? So their family or employer have to sign affidavit of support saying that they support that person. And they have enough income to support that person in addition to their own household member or their own employee, if that's employment-based. And also totality of circumstances. Well, totality of circumstances are different factors. The age of that person, their skill, their education, their employment, whether or not that person has a job at the time of applying for a green card. They may not have a job at the time that they used public benefit years ago, but they may have a job now. They may have received education now, or they might have assets. They may be healthy enough to be able to go and work. These are factors that government consider to see if the person will likely become public charge or not, or primarily dependent on government or not. So that's why it's important to discuss this matter if there's someone they have used public benefit with their lawyer before applying for any sort of immigration benefit, to be able to plan ahead and set up a good strategy how to overcome possible issue that government may raise down the road. And there are factors that there are some points that is important for everyone to know. Public charge tests only apply to some immigrants and some programs. So as I said, it's long-term hospitalization and cash assistance, nothing else. But Medicaid offer long-term hospitalization, right? So that's why it's important. COVID-19 testing, treatment, vaccine, relief payment, stimulus check, none of them are public charge. That's okay. There are a lot of people coming to us say that they received those checks. They're worried about applying for green card now. That's fine, because that under current law, which came out December, that's okay. Some and also some simply using government benefit doesn't trigger immigration enforcement. Some people are worried, undocumented immigrant, if they use some sort of public benefit, ICE will go and pick them up. They find their address, go and pick them up. That's not the case. That shouldn't be the case. That's better to say. And if your family member, US citizen children, receive any of those benefits, that's okay. It doesn't impact parents' situation and green card application. So children are okay as long as the application and benefit is under their name. And use of health, food assistance, housing program, they have been listed in the PowerPoint. They are not considered public charge. And as I said, if anyone wants to apply for any sort of immigration benefit, it's good to know ahead of the time to discuss and disclose using those benefits to plan ahead how to overcome possible issue. And the main issue right now is that the law came out December. It's just 2 months now. And we're not sure how government is going to interpret this law into cases. It takes a year usually until we see the result and how strongly they want to enforce this law. Sometimes they have different approach to those new laws, and we want to wait for, it may take a year, up to a year, that we start seeing their request for more evidence, request for proving that the person is not public charge. So we're waiting for them. And from now, we need to know to plan ahead to make sure that our clients and immigrants are aware of the possible issues that may come up in case they apply for any immigration benefit. And that being said, I think I covered everything about public charge that your patients or anyone who is receiving public benefit or health insurance now, health benefit, I'm sorry, through public benefit might see in their future immigration journey. And they just need to know what is okay, what is not okay, and just disclose it. Everything that I said doesn't mean that they shouldn't use this benefit. The only thing that they shouldn't use, long-term hospitalization, cash assistance. No to that one. But the rest of it, that's okay. They need to disclose it to their lawyer before applying for any benefit. And that's it, I think.
A question for Ilham?
Yes.
Yeah, whatever you want.
Patients that have lost
Up to, they're not gonna be deported. Okay, that's not gonna. Yeah, it's not predictable. That's right. So if they use and end up to the point that they have, they're using public long-term hospitalization, that's when they just need to, if they need to discuss with their immigration attorney about possible solution, because they may be qualified or be eligible for one of those humanitarian category that I said. And if they are eligible for any of those humanitarian category to apply for green card or stay here, that's fine. That's okay. Yes, that's fine. And even if they're not eligible for humanitarian and they end up applying for green card through family base or employment base, we can still argue that it was not, depending on this case by case situation, right? We can still argue that it was not primarily dependent. It was just the time frame that that person was sick. Now the person is better, for example, and healthy enough to go and work, or the person has a sponsor. family member or employer who is sponsoring that person and is signing affidavit of support with government to promise that they can cover their cost. That's part of the process. Every family that apply for green card, they should have that sponsor. And that sponsor knows about what they are signing about. Yeah. Any other question? There are different category of families that can apply for each other. Okay, mostly when a child becomes 21 or older, they can apply for their parent. And generally speaking, parent can apply for both under or over 21 years old kids, but the time frame and situation change. So if the kid is under 21, usually it's faster. If the kid is over 21, it takes longer. But they can sponsor each other both way. Yeah, under certain circumstances, yeah, both way can sponsor each other. Yeah. Yes. Well, there is no specific category of green card or status for as a caregiver. Okay, but usually what we do is that during the session that we have with person, we screen them for all of these category. I usually ask a lot of questions from the person and see if they are eligible for any sort of green card or temporary status to see if we can get something that might not directly be related to being caregiver of her mom, but there might be other reason that we can apply for that person. And her mom, if mom is has a legal status, there might be an option to sponsor girl, depending on that situation, right? Depending on status of the girl, mom can, if mom has a green card, they can sponsor their kid. So we need to discuss and talk, or sometimes we end up having mom become citizen and then apply for kid because that's faster. So we go like we do a lot of game to get what we want. Yeah, you have to plan strategy to get what you want. Of course, you need to be careful about public charge and many other factors that make people ineligible. And knowing that help you to navigate which option is better for the person. Maybe one option is good for someone, but because of possible inadmissibility ground, which one of them is public charge, we don't choose this one. We go with the other one because we know that one is better. There's no all of those inadmissibility ground will be forgiven. Yeah. Yeah, of course. Any other question?
Hello. Thank you, Elham. No, thank you, guys. Let's give a round of applause. She will now be headed right over. Actually, it looks like we'll begin at 2 o'clock, but it's actually, I believe, do you want to do it at the same time or do you want to go now?
I think now we should.
Yeah, okay. So your location is the Catalina Room. For those that want to go to the workshop, you'll go right outside the doors and it's right across. And Elham will go over the independent workshop with her. So if you want to go, that's where it's going to go. And we're going to get that started right away. And then we'll get Siapa up here. Siapa Manzoor, she's our next guest speaker. Okay, well, yeah, let's see if we can get her. Our next speaker is Siapa Umanzor. She's going to be handling chronic illness and mental health. She works for the Department of Mental Health. She's an LCSW. And by the way, Siapa's workshop will be directly following her presentation, and that'll be across at the Cabrillo, right next to the Catalina. So Siapa, I'll offer you your choice. You can do this microphone or try and speak into that one, your choice.
Okay. I want to see that slide so I can follow.
Oh, yeah, you'll have the slides. It's just the microphone. If you want to hold one.
No, you stay there.
Here, go ahead. Why don't you just take that?
Okay, thank you. I think this is louder though. I don't know how you feel, since it's a big, small crowd, I don't know. It's fine? Okay. Well, good afternoon. My name is Suyapa Umansor, and I'm a clinician with the Department of Mental Health. And I work I'm also the coordinator for one, I don't know if you guys are familiar, we have a program, it's multicultural, and it's a United Mental Health Promoters Program. And the Promotoras de Salud Mental, I'm going to do my workshop bilingual. So what we do is we provide free workshops to the community in 13 different topics. If people participate in those workshops, they can only miss 3 if they want a certificate. And they get a certificate for participation. And then if you are a provider, you can host those also virtual or in person. Okay, so before we start, I have 2 bags to raffle. So if someone can tell me what is mental health. Buenas tardes, mi taller va a ser bilingüe, así que quiero nomás, voy a rifar 2 bolsas y nomás la pregunta es ¿qué es salud mental? Okay, tell me whoever is close to the answer, you get the bag. Okay, a ver, one more, anyone else? Here, yes. Okay, I don't think that is the same question, okay, for the next one. Who can tell me the triangle of health? ¿Quién me puede decir el triángulo de la salud? El triángulo de la salud tiene 3 componentes. No es solo salud física. Ya les di la respuesta, ¿verdad? De alguna. Okay, social. But you were close. Oops, that's high. Okay. Oh, so that's cheating, huh? Okay, thank you for participating. So I'll be talking about chronic illness and mental health, enfermedades crónicas y la salud mental. Les quiero dar la bienvenida. Espero que les gusten las bolsas a las ganadoras. I'm gonna talk about chronic illness. This is my agenda for today. Chronic illness. What is mental health? The relationship between chronic illness and mental health. Mental health and chronic illness connection, risk factors, and management and treatment. Okay, so esta es mi agenda para hoy. Voy a hablar de qué son las enfermedades crónicas, qué es la salud mental, la relación entre las enfermedades crónicas y la salud mental, la conexión que hay de la salud mental y la enfermedad crónica, también cuáles son los factores de riesgo y cuál es el manejo y tratamiento. So, chronic illness is a health condition that is present in a person's body for a long period of time, or that recurs over a long period of time. Some chronic disease cannot be completely cured, but can be managed. Example of those chronic disease are like diabetic, heart disease, cancer, arthritis, asthma, when there is already a chronic condition that it cannot be reversed. So, las condiciones de salud que esté presente en el cuerpo de una persona es durante un largo periodo de tiempo o que puede volver a aparecer durante un largo tiempo. Eso es considerado una enfermedad crónica. Y algunas enfermedades crónicas no se pueden curar completamente, pero sí se pueden manejar. Y los ejemplos que tenemos es como la diabetes, la enfermedad del corazón, el cáncer, la artritis, el asma. ¿Y qué es salud mental? ¿Alguien quiere leérmelo? Thank you. And this is the definition that we had based by the CDC, the Center for Disease Control. And we want to make sure that we understand when you live here, the goal is that you really know to define what is mental health, because some people think mental health is when there is already mental health condition, and that's not it. Okay, so mental health, la definición es que es la salud mental, es una parte importante de la salud, el bienestar general. La salud mental incluye nuestro bienestar emocional, psicológico y social. Esas tres cosas es el triángulo de la salud. Uno no depende del otro. No podemos tener uno y no tener el otro. So, nuestra salud no es solo la salud física, también es la salud mental y emocional, ¿verdad? Entonces, afecta la forma en que pensamos, sentimos y actuamos. También ayuda a determinar cómo manejar el estrés, que la persona, ella que ganó la bolsa dijo, ¿verdad? Cómo puede lidiar, enfrentar cosas estresantes, ¿verdad? A veces tenemos retos en la vida que podemos lidiar con ellos porque tenemos una buena salud mental. Cuando hay ese desequilibrio, entonces es cuando empezamos a tener como ya condiciones y esto está durando por mucho tiempo, ¿verdad? También ayuda a determinar cómo manejar el estrés, cómo nos relacionamos con los demás y tomamos decisiones saludables. La salud mental es importante en todas las etapas de la vida, desde la niñez a la adolescencia y hasta la edad adulta. So, esta es una definición que nos está dando el Centro de Enfermedades y Control de Prevención. Entonces, eso es lo que es la salud mental. Entonces, es importante que entendamos que es ese bienestar emocional que nos podemos tener el balance. Okay, so when you leave from here today, I really want you to understand and live with the knowledge about what is mental health. Like if at the door someone asks you what is mental health, you're not gonna say, oh, someone that is crazy or someone that has suffering depression. That's not mental health, you know. And by the way, the goal of our program is to reduce mental health stigma. And after my workshop, we're going to have another workshop in one of the rooms, in the Cabrillo room. And what we want is to make sure that we feel comfortable about talking about mental health, because everybody needs, you know, a therapist, especially after the pandemic, right? When, you know, we have seen an increase in depression and anxiety. So we want to feel comfortable that we can talk about our emotions, and that's what mental health is about. Okay, cuando se vayan de aquí, el objetivo es que cuando ustedes salgan de la puerta puedan definir qué es la salud mental. Y es ese bienestar emocional, psicológico, ¿verdad? Físico, que nos ayuda a afrontar los retos diarios de la vida. Esa es la salud mental. Que no se confundan, que piensen que una persona que tiene depresión, eso ya es trastorno de salud mental, ¿verdad? Y también dejar de usar la palabra loco, especialmente en nuestra cultura, es algo que lo usamos frecuentemente y eso nosotros queremos disminuir el estigma de salud mental Entonces tenemos que llamarle por el nombre, ¿verdad? Trastornos de salud mental. Cuando una persona ya tiene retos para afrontar porque tiene alguna depresión o ansiedad, entonces esos ya son trastornos de salud mental. Eso no es la salud mental. Okay? So, the relationship between chronic illness and mental health disorders. These are some of the chronic disease, and how they relate with the mental health disorders. The diabetics, they have 2 times more commonly diagnosed mental illness than those without diabetes. Heart disease, 3 times more likely to experience depression when compared to someone without heart problems. A stroke, depression often occurred following a stroke. Chronic respiratory disease is 3 in 4 people with severe COPD also experience anxiety or depression. Cancer, high risk of development depression due in part to high level of stress, emotional upset, and change in body images. So, esto es como se relacionan las enfermedades crónicas con el trastorno de salud mental. Las enfermedades crónicas como la diabetes tiene 2 veces más enfermedades mentales diagnosticadas que aquellos que no tienen diabetes. Las enfermedades del corazón tienen 3 veces más probabilidades de experimentar depresión en comparación con alguien sin problemas cardíacos. Y a los accidentes cardiovasculares, la depresión a menudo ocurre después de un accidente cardiovascular. Una persona que tiene stroke, la mayoría de veces siempre va a tener una depresión, a veces severa, dependiendo cómo le afectó el stroke. También enfermedades respiratorias crónicas, 3 de cada 4 personas con problemas pulmonares graves también experimentan ansiedad o depresión. Cáncer, mayor riesgo de desarrollar depresión debido en parte a los altos niveles de estrés, malestar emocional y cambios de la imagen corporal. También ahí incluye las enfermedades renales, ¿verdad? Que es como cuando una persona está teniendo diálisis o que también está teniendo problemas, ¿verdad? Para darles un poco de experiencia. Mi esposo el año pasado tuvo deficiencia renal y le dijeron que necesitaba trasplante de los riñones, ¿verdad? Necesitaba trasplante de los riñones y del hígado. Entonces, tuvo una depresión, pasó por una depresión porque pues es lo que menos quería. En una de las hospitalizaciones que tuvo, le dijeron que necesitaba diálisis, ¿verdad? Él decidió que no podía, que él no quería tener diálisis. Se fue para la casa, nomás para hacer la historia corta. Quiero dejarles saber, ayer fue al doctor y el doctor le dijo, no sé qué estás haciendo, síguelo haciendo porque tus riñones están funcionando casi normalmente. Le hicieron su fístula y todo porque lo prepararon para empezar con diálisis y pues gracias a Dios, ¿verdad? No la ha necesitado hasta ahorita. Sí está en la lista, pero ya bajó mucho, porque le dijeron que necesitaba trasplante de hígado y trasplante de riñones, pero ¿quiere que le diga? ¿Quiere que le diga? Nosotros tenemos la salud, nomás que no estoy hablando de salud, yo le empecé a dar jugos verdes. Si quiere la receta, la salida se la doy. Ok, pero eso es muy bueno nosotros. Y también le ayudó mucho con su depresión y con su salud. Okay, I was just giving a short story. I don't know if you guys, that my husband was having renal failure last year and he was put in the wait list for kidney transplant and for liver transplant. But yesterday he had a doctor's appointment and the doctor said, whatever you're doing, just keep doing it because you're almost close to the normal kidney function. He did refuse back in June last year. He refused to have dialysis and they discharged him from the hospital because they said they couldn't do anything other than give him dialysis. And he said, nope, I don't want dialysis. They prepared him back in, I think it was in August, they prepared him with a fistula to have him prepared. But he's almost close to the normal. He still has his fistula because he still have the liver problems. And that's something that actually he had also gotten better. And that's just with natural, natural like veggies and things like that. So, but just wanted to share with you. So what is the chronic illnesses and mental health? Depression typically occur in 70% of cardiovascular disease cases, 25% of stroke cases, and 27% of diabetics cases, and in more than 20% of cancer cases. Studies have shown that depression increases the likelihood of developing a chronic disease. And it's like a circle. One depends on the other. And we don't know, because someone with chronic illness can have mental health disorders. And also if person has mental health disorders, they can have chronic illness. Sometimes it's based on the medication and things like that. So adults in the United living with severe mental illness die an average of 25 years earlier than those without mental illness, primarily due to durable medical conditions. There is a relationship between positive mental health practice and good health. For example, people who are more optimistic are less likely to develop heart disease. So that's very important. So depression and anxiety most commonly occur simultaneously with chronic illness. Also, I don't know if you have heard about the ACEs study, because that's very important for you to pay attention. The ACEs study stands for adverse childhood conditions, and that also predict that people having chronic medical conditions as well as mental health problems. So no sé si han escuchado de un estudio que hizo Kaiser con el departamento de CDC de aquí de los Estados Unidos, donde estaban mirando la relación de las personas ya adultas que tuvieron experiencias adversas de la infancia. Y esas experiencias adversas son como, por ejemplo, abuso infantil, algún padre que hayan perdido, ya sea por divorcio, abandono o como sea, ¿no? Abuso sexual, que hayan también tenido una pérdida, ¿verdad? De un padre que haya estado en prisión. Hasta parecer del bullying es una experiencia adversa en la infancia que cuando la persona está adulta va a aumentar el riesgo de que la persona tenga condiciones de salud, como diabetes, obesidad, problemas cardíacos. Entonces, hay mucho riesgo de que la persona también va a tener trastornos de salud mental. No sé si quieren que pause para ver si hay alguna pregunta hasta ahorita. ¿No? Ok, le seguimos. La enfermedad crónica de la salud mental. La depresión suele ocurrir en 17% de los casos de enfermedades cardiovasculares, 23% de los casos de accidente cerebrovascular y 27% de los casos de diabetes y más de 40% de los casos de cáncer. Estudios han demostrado que la depresión aumenta la probabilidad de desarrollar una enfermedad crónica. Los adultos en los Estados Unidos que viven con una enfermedad mental grave mueren un promedio de 25 años antes que los que no tienen una enfermedad mental, principalmente debido a condiciones médicas tratables, ¿verdad? Entonces hay como condiciones, a veces la persona no sabe que las tiene, ¿verdad? Entonces eso es lo que necesitamos que sepan y es lo que nosotros hacemos, incrementar la concientización de los trastornos de salud mental, promovemos el bienestar emocional y pues también damos recursos, ¿verdad? Que pues hay recursos disponibles en el condado de Los Ángeles. Tenemos grupos de apoyo en español que son completamente gratis. So we promote our program, decrease mental health stigma, promote wellness, well-being, and also we have a program for Spanish-speaking support groups that are completely free, besides the workshops that we do. También existe una relación entre las prácticas de salud mental positiva y una buena salud. Por ejemplo, las personas que son optimistas son menos propensas a desarrollar enfermedades del corazón. Más comúnmente, la depresión y la ansiedad ocurren simultáneamente a enfermedades crónicas, ¿verdad? Entonces, una va con la otra. Entonces, es un ciclo, ¿verdad? Entonces, tenemos que cuidar, como les mencioné, el triángulo de la salud. No es solo nuestro físico. So causes of mental illness and chronic illness, both are caused by a combination of risk factors. So what are the mental illness risk factors? We have family history, stressful life conditions, have a chronic illness, traumatic experience, drug and alcohol use, child abuse and neglect, lack of social support. And the chronic disease risk factors are family history, lack of physical activity, tobacco use, excessive use of alcohol, environment living conditions, socioeconomic status, bad eating habits, and age. No one can tell me which one do you see are common in both of them? That's one. There's three common. Okay, one. Can you name? Okay, drug abuse. What else? No. No, I think trauma? No, but I don't think I put it. It was like lack of a space. Actually, the three in common in both is family history, stressful events, and stress. Age? No, that's not a common one. That's only on chronic. That's a risk factor in chronic. And then the other one, that's drug use. That's the three. That's the three that are common. So, las causas de enfermedades mentales y las enfermedades crónicas, ambas son causadas por una combinación de factores de riesgos. En los factores de riesgos de la enfermedad mental es el historial familiar, condiciones estresantes en la vida, tener una enfermedad crónica, experiencia traumática, el uso de drogas y alcohol, abuso y negligencia infantil y la falta de apoyo social. Y los riesgos que encontramos de factores de riesgo que encontramos en las enfermedades crónicas es la historia de familiar, la falta de actividad física, el consumo de tabaco, el uso excesivo de alcohol, medio ambiente o las condiciones de vivienda, estado socioeconómico y malos hábitos alimenticios y también la edad. Esos son factores de riesgo. Los tres en común es el historial familiar, el estrés y el uso de alcohol y drogas. So, estos son factores de riesgo relacionados, son related risk factors. Las personas con enfermedades mentales son más propensas a fumar, a beber o a utilizar drogas, ser físicamente inactivas, tener hábitos de sueño irregulares, tener malos hábitos alimenticios. So people with mental illness are more prone to smoking, drinking, or using drugs, being physically inactive, having irregular sleep habits, having bad eating habits. And then las personas con enfermedades crónicas son más propensas a sentirse estresadas o ansiosas, sentir frustración o culpa, sentirse aislados, tener sentimientos negativos sobre sí mismos, sentirse como un fracaso o sentirse inadecuado. So people with chronic illnesses are prone to feeling stressed or anxious, feeling frustrated or guilty, feeling isolated, having negative feeling about yourself, and also feeling like a failure or inadequate. So, estas son las similitudes entre las enfermedades mentales y las enfermedades crónicas. So, I'm going to talk about the similarities between mental illness and chronic illness. So, we have a sleep change, change of appetite, change of energy level, a stomach ache or digestive problems, muscle ache or tension in the muscles, feeling anxious or depressed, of having depression. So, los síntomas de las similitudes que hay entre las enfermedades mentales y las enfermedades crónicas es el cambio en el sueño. Eso es muy importante. El sueño es muy importante tanto para la salud mental como la salud física. Y ahorita muchas personas están teniendo problemas de trastornos de sueño por el celular. Activa mucho nuestro cerebro. Entonces, por eso a veces cuesta que la persona se quede dormida. Estamos usando el teléfono antes de acostarnos. So, también en el cambio del apetito, cambio en el nivel de energía, dolores de estómago o problemas digestivos, dolores musculares o tensión en los músculos, sentimientos de ansiedad o depresión. So, estos síntomas los vamos a encontrar en los dos, ¿verdad? Tanto en las enfermedades mentales como en las enfermedades crónicas. So, ¿preguntas? ¿No preguntas? Okay, so voy a entonces hablar de management and treatment. So, manejo y tratamiento. Es muy importante, ¿verdad? Recibir tratamiento que involucre la mente y el cuerpo. Por lo general no hacemos la conexión, como les dije, siempre estamos como, nos duele la pierna, nos duele el pecho, lo que nos duela, vamos corriendo al doctor, ¿verdad? Y a veces lo que pasa es que a veces hay enfermedades, se va a manifestar primero físicamente, ya sea por síntomas psicosomáticos, ¿verdad? Entonces se va a manifestar, pero nuestro cuerpo es nuestro cerebro es muy inteligente. Primero se va a proteger, entonces va a ser algo, ¿verdad? Entonces va a una emergencia porque sienten como que les va a dar un ataque el corazón y resulta que salen de la emergencia referida para un terapista, porque lo que tuvo era un ataque de ansiedad, ¿verdad? Entonces, nosotros tenemos que hacer esa conexión, saber de que a veces la ansiedad puede causar problemas estomacales, la ansiedad puede causar dolor de cabeza y también pérdida del sueño. Entonces, poder reconocer esos síntomas, ¿verdad? Para saber si es, a veces un doctor le hacen muchos exámenes y no, pues no tiene nada. no tiene nada, nunca supieron que tenía, porque son manifestaciones de síntomas emocionales, ¿verdad? Que la persona está teniendo. So, es muy importante hacer esa conexión. También aprender a manejar eficazmente la enfermedad, ¿verdad? Si la persona tiene, no solo porque la condición es médica, ¿verdad? No tener un terapista, porque a veces sí se necesita hablar con alguien, ¿verdad? Porque la persona que ya sea que haya tenido un trasplante, que esté teniendo diálisis o está enfrentando una condición crónica que no tiene cura, nomás puede manejarse, pues necesita emocionalmente desahogarse con alguien y lo que no hacemos es hablar de cómo nosotros nos sentimos, que es algo que es muy importante para nuestro bienestar emocional. También usar programas de apoyo, como les mencioné, ¿verdad? Esos grupos de apoyo son muy importantes porque vamos a encontrar personas que a lo mejor están pasando por lo mismo que nosotros. La práctica de técnicas del manejo del estrés, terapia, aprender a usar medicamentos adecuadamente para alguna de estas condiciones, recibir apoyo con las decisiones relacionadas con la salud, mejorar el conocimiento sobre la salud. Mientras más la persona se eduque acerca de la condición que tiene, mejor va a saber tratar su condición. Eso también va para las condiciones de salud mental. Y también recibir el apoyo de amigos y familiares. Okay, so these are some of the management and treatments that I recommend. Receive the treatment that engage the mind and the body. Do not just think about physical health alone. We need to include, the mind, the connection, because sometimes people go to the emergency room thinking that they're going to have a heart attack, and then they get discharged with a referral for therapy, and they don't understand why. And sometimes, they don't get an explanation either. But sometimes people are having, an anxiety attack, and it feels similar symptoms than having a heart attack. So usually our brain protects our mind. So we're gonna start manifesting the emotional symptoms are gonna be physical before they start having, like a mental health condition. Like, for example, anxiety can give diarrhea, can give stomach ache, depression can give body ache. So, and sometimes people do not think that they're having like emotional or a mental health condition, and they just relate it to like having physical symptoms, because they are physical symptoms. They go to the doctor and the doctor can't find anything. So that's why it's important that you also take care of your mental health. So that also include the effective management of the illness. The more you know about your condition, then the better you're going to be able to manage it. Also, peer support programs, like, support groups that other people might have same conditions that you can talk about it. Also, practicing stress management techniques, therapy. Learn to use medication appropriately for some of these conditions. Receive support with health-related decisions. Improve health knowledge. And get support from friends and families. So there are three that, have been proven to be scientifically, that scientifically work for us to practice, and that is, exercise, healthy habits, and stress management. You cannot go bad about that. If we practice those, we're gonna have good health and also good mental health. Any questions? No? Okay, so because I went too fast and I'm like kind of finishing, but like I really want to invite you to go to our next workshop that we're going to have in the
Cabrillo room, right outside to the right.
Yes. So I just want to give you the definition of it actually is in the Constitution of the World Health Organization. that it says health is a state of complete physical, mental, and social well-being, and not merely the absence of the disease or infirmity. So, les quiero dejar con esta frase que es parte de la Constitución de la Organización Mundial de la Salud, que dice que la salud es un estado de bienestar físico, bienestar mental y social, y no solo se refiere a la ausencia de enfermedad. So, es muy importante que ahora que ustedes sepan, ¿verdad? De que yo creo que ya todos saben qué es salud mental, ¿verdad? Ya les voy a hacer otra, a ver si sí. A ver, y también estos son los recursos del Departamento de Salud Mental. Tenemos una línea de ayuda. Es el 1-800-854-7771. También tenemos apoyo en línea, tenemos los volantes en la mesa de recursos, donde puede haber conexión con una persona, un consejero por medio de chateo o como sea en línea. También recomendamos el uso de una aplicación que se llama Headspace. Es gratis y ponen así como está aquí, porque si no se le cobra. Es headspace.com/LA County. Es una aplicación para meditación, para que pueda la persona manejar el estrés. También, pues, como les mencioné, tenemos grupos de apoyo en español. También nos pueden encontrar en la social media. So, these are some of the resources. We have a helpline, and also the helpline have emotional support from like 9, I think it's from 9 to 7 at night. If you press option 2 when you call the phone number, it's just to talk to someone, a professional person that has been trained in mental health. Si llaman a ese número de ayuda y presionan la opción 2, es para hablar con alguien, nomás por hablar, para pues ayuda emocional. También, we also have the Prevail line where you can get counseling. You can get counseling, and you can do it like through an application. And then we also recommend Headspace app. And then we have a Spanish support groups. If you wanna, just call that number, and we can tell you where the groups are, and we can connect you. We do some that are virtual, and some are in person. We're not in person yet for the support group. We are for the workshops, but not. So I think we have out of 20 support group that are countywide. We have, I think 5 that are in person. And then also you can find us in social media. So I don't know if any questions. Family history? No, that's a risk factor. Like, for example, if you have a family history of diabetic, most likely that risk is diabetic. So, for example, I have a risk factor of having osteoporosis because my mom has osteoporosis. And I hit menopause too early. That increased my chances of having osteoporosis. So that's a risk factor for my family history. And the same thing for diabetic, So that's the family history, that risk of family history, that if you see who in your family, how many members have, suffer from diabetic or any illnesses. So the risk, especially if it's like parents, grandparents, or siblings, that risk is going to be higher. And that's the same thing for also mental illness. Any other questions? No? Okay. So what is mental health? Okay. One more. Okay, whoever wants, I said it. Got it? Okay, we have one more back. Okay, let me see. I think she was on the right way, on the right path. A ver, again. Emotional, physical, mental what? You have that right, but close. Keep going. No. Okay, you need to, that's something I want you to get it right, okay? When you leave today from this workshop, I want you to get right that mental health is not about having depression or having anxiety or being stressed. That's not mental health. Gloria, you want to tell them what mental health?
You do it.
No, tell her. She's good.
¿Qué es la salud mental? I'm going to say it in Spanish. Psychological, physical, and what else? Yeah. So let's go. Who? She get the closer one. Yeah, you were the closer one. Emotional and social. Balance.
And the emotional balance that we have to, like that we have challenges in life.
Every day is a
And
challenge.
then, I can still balance. I have that balance, to deal with them because I have the physical, the emotional, and that, yes.
That's a social too.
I can reach out to someone for help. I can tell you, you know what? I feel overwhelmed. I'm really stressed out. I'm, yes.
It's
Talking
kind of
about
resilience.
resilience, that you can talk, to someone you can trust about how you feel, because that is also a big part about your mental health, that you can talk to someone.
And it's
So-
and the importance to have that balance every single day. Life is always, a challenge. Every single day is a challenge. How do we deal with that every single day? That's the importance, to keep the balance in our life and the good mental health. Usually we always take care of our body. That's the most important most of the time, but we forget to know and feed our mental health too. And that's the best, because that's gonna continue with everything in life and in balance, like everyday issues. Every day, like I was saying before, every day it's hard. Every day, since we get up in the morning, all the issues we have every single day. And if we don't keep that balance, then we're not gonna have a good mental health.
Thank you, Gloria. Gloria and Carmen are mental health promoters, and they're going to be doing the workshop after I'm done.
Cabrillo.
Tengo dos promotoras aquí, a Gloria y Carmen, y ellas van a estar haciendo el taller. Pero nomás, tómenle una foto a esto. Le voy a dejar que saquen el teléfono y le tomen una foto. Y se aprendan esta definición, ¿verdad? Dice... La salud mental incluye nuestro bienestar emocional, psicológico y social, ¿verdad? Si tenemos balance en eso, tenemos buena salud mental. That's it. Okay? So you just need to know that. That's mental health. Include emotional, psychological, and social well-being. If you have balance in the three, that's mental health.
And we have to feed our mental health
And
every day.
There is no health without mental health, because that's the triangle of health: social, emotional, and physical. So if you miss one of those, then that triangle is like, there's not good health. Because social include that connections that we do with others. So si hay en el triángulo de la salud está físico, emocional y social. Si uno de esos tres está desbalanceado, no hay salud. El físico, nuestra salud física, emocional, ¿verdad? Que nosotros sepamos expresar y manejar nuestras emociones. Y el segundo, el tercero, social, que nosotros podamos hacer esas conexiones, pedir ayuda, tener buenas relaciones saludables. Eso es la salud. ¿Ok? Pregunta, everybody clear? What is mental health? Yes? Okay.
She got me on guard. huh?
Thank you. Thank you, Siapa. Okay, whoever wants to go see Siapa at the workshop, right now you can follow her over.
What's this, my?
Cabrillo,
Yes.
right now. And she'll continue on and
Thank you very much.
great job. Thank you. Guys, let's give a round of applause for Siapa, please. That was fantastic. Thank you. Yeah, so on over to the Cabrillo room for more Siapa. And then we're going to get started with our panel discussion up here. A panel discussion, so then the doctors will join in on this online. But if you want to, like Jasrina, if you want to kick us off, just a discussion and y'all can share it and it's going out to everybody, but amongst yourselves. And then I'm sure there'll probably be maybe some questions coming as you guys are speaking. So if you want to kick off just your thoughts on today or something you want to speak about, and then we'll just kind of take it from there.
Okay, sounds great. So I thought today went really well. I feel like I learned so much just even entering my medical career. Maybe we can talk about things that we've learned or that we want to learn more about after today. And I guess like just to start off, like personally, I thought it was interesting to talk about the different mental aspects in terms of diabetes and how kind of coming together as a community and those sort of psychosocial factors can come into play.
Doctors are online now.
Okay.
Up back also.
Oh, okay, perfect.
Well, I really liked hearing from the LA County mental health folks because I'm new to this network and I had no idea that there's 10 million people in this county. And that I was at a National Kidney Foundation presentation where there was a doctor from Harvard who was talking about health equity. And he was saying that at a particular period of time, they had done a research study on all the procedures throughout LA County, and they among people of color, and they found, if I'm misstating this, I do apologize, but they found the two most common treatments two most common procedures in LA County done among African Americans were shunt placement and amputations. And I was like, wow. And this is like across the board. It's not just dialysis. And it was a conversation about how we failed a lot of people in the society that are people that have not been at the same table as some that have a lot of privileges and how much more work needs to be done. And so hearing, and then of course, this is all during COVID. So having the county mental health here presenting in both English and Spanish, I thought was really helpful. Although it was a lot of things I knew, it's just because I know it doesn't mean it's not great. And having it be done bilingually is wonderful because also this is LA County in all its hugeness is also not very wealthy. And unfortunately, people that are Hispanic or African American are often of lower income. So I thought that having the county here with their mental health support was great. And then I was focusing on the Hispanic population because it's a big deal. And if we're going to offer treatments like shunt placement for dialysis, which is so complicated, and if we're going to have a population that's at risk for amputation, which is so permanent, oh my goodness. So I really like that.
Question Victor is asking, is PD dialysis better than hemodialysis?
I'd be happy to take it.
Go ahead.
I mean, I think it kind of depends what you're looking at, right? I mean, if you cannot do PD dialysis, then in-center is better. And that's provided that, you know, your life is worth living and your quality of life and all that kind of stuff works. But all things equal in terms of preserving kidney function, and keep in mind, I'm not a doctor, I'm a social worker, but I kind of look at the whole picture, is that it's just more gentle. It approximates, like, I always think of it in kinds of things as layman's terms in a way. And for me, anything that gives you more dialysis is getting closer to approximating your old kidney function, right? So if you're getting some dialysis every day, you're going to have, what did they say? It's more like waves. right? Whereas in center, you get a whole lot of dialysis really concentrated, like for like 3-4 hours, and then you get the big peaks. But if you can't do one of them, it doesn't, the question doesn't apply. But I think, and then she was saying it waves for PD and it maintains your kidney function better.
PD is more like Gentle Hill.
Gentle Hills, and then waves was HHD. Yeah,
And hemodialysis
was the mountains and the, yeah. And so, yeah, that's right. But I like the analogy and I forgot all the pieces of it, but I think that's helpful. On the other hand, I mean, I talk with patients that have said, PD is a fair amount of work. You have to do something every day. You can't just kind of go to dialysis, have a in-center hemo and have a long nap and then have the next day free.
But PD dialysis usually is done at night while you're sleeping. You up.
Not in the beginning. Yeah, not for everybody. Not everybody can do it at night. So it's a complicated question, but I would say it depends on a lot of factors. But I think all things like when they look at mortality and how people feel, like the people that I talk to as a social worker that are feeling better and working, or maybe more, I know for sure the PD patients and home patients are more likely to transplant because they're really used to doing things themselves. And in center, unfortunately, and this is kind of why I feel so passionately about my job, is we kind of do for instead of do with patients. And we kind of sometimes unintentionally we breed a culture where patients just lie in their lazy boys and become more and more and more weaker. Whereas in PD, you can't just lie in your lazy boy. You have to kind of set some stuff up and then you get to lie in your lazy boy. I don't know anyway, but that's my thought.
Mike?
Hello, testing. Okay. And they would come to me saying, Carol, is there any way we can start our residency because they're not going to let us get a transplant? And they were young, people that were very young. So that's what my biggest interest to you is, all these years, the collaboration with immigration and kidney disease, it's been there for a long time because they're here from a different country with just an emergency medical and they're left just right there. Just up until 2 years ago, not even 24 months, they opened the doors at the harbor for now emergency medical patients can get transplanted. But yet patients that are here that are getting dialysis, getting a transplant, they want to stay here. They don't want to go back to where they can, they want to stay here and stay where their existing healthcare is. So tell me, how long is the transition for somebody to get a residency? Is it case by case? I don't know because I don't sit in your consultations with the patients I refer or going to refer or the future together. I know it's case by case, but there is hope, right?
Yes. Well, our goal is to figure out a way for people to legalize their status and keep them here, right? There are different categories that people can stay here. And what we usually do, screen them for all kind of green card and residency that may apply to someone and see which one they might be eligible. So we're going to apply. If there is something that they can do something to get, increase their chance legally for that type of case, yes, definitely we advise them as long as it's legal. And it might not be directly related to their illness, but indirectly, yes, there are ways. There are asylum cases that are based on people have a disease, and if they go back to their home country, they will die, and they need to stay here. There are some cases, but it's very case by case. So if they can there are like case law. We have to go through it depending on the sickness and illness and how serious and how their country have how is their medical situation there, insurance, their skill, they can speak that language or not, they can work and earn enough money to afford medical treatment in their home country, or there are other stuff because of their sickness, they are vulnerable community and they will be attacked by specific group. These are all factors that come to play to help us to see if there's anything we can do related to their sickness to keep them here. So yes, and on top of that, we screen them for every other thing. If they are sick here, they have an illness, they are vulnerable community here, right? There are situations that may have happened to them that they don't recognize as being a victim of that situation. There are immigrants here that are living, working in a horrible situation, and they think that just because they are immigrant, they have to stay in that situation, not complain. And if their boss is threatening to deport them, if they complain about their salary not getting paid, they think that's okay. They have to leave because what if their boss deport them, right? But the boss doesn't have that right. And also that person is most likely victim of labor trafficking. And then we can apply for T visa, get that person here, keep them, apply for green card. Whole family can get green card. Their sibling, their kids, their spouse. So whole family will be fixed just by one person. And those are stuff that coming out of being a vulnerable person in this country, you know. So yeah, we ask a lot of questions that directly or indirectly arise from their situation, and then we most likely will get somewhere. Thank you. I appreciate you inviting me to this program and also building this relationship because well, there are a lot of patients, and I told you I have family history of this, that my family has illness, that they have also immigration issues. So I have personal thing with this topic. But the thing is, there are a lot of patients, they don't receive medical, they're a patient that they don't know what to do with their immigration situation. On the other hand, we are dealing with a lot of immigrants, our clients that are looking for health benefit. And today I learned a lot of resources that when they are contacting us, asking us, I don't have social security, I don't have work authorization, our application is pending, but it takes years to get the result. What can I do now? And now I got to know some people here who advised me and gave me information that I can provide to them. And that's actually a topic that was well needed. And I appreciate you building that connection and relationship.
I have a question for you. Oh, sorry. Oh, me. I was wondering, one barrier with, we used to use the Immigration Law Center in Northern California, but one barrier was often that the funding for immigration issues, because it's a civilian case, would be difficult. Are there any ways that patients can work with that, or how do you ever do sliding scale, or do lawyers do pro bono with immigration, or are there funds anywhere for that?
Yes,
Ah,
definitely.
I'd be interested.
Well, lawyers are required to, depending on which state they are licensed to, they're required to do some specific hours of pro bono every year and report it to their state bar. So we are required, okay? On the other hand, there are nonprofit organizations that are receiving funds from government, different resources to assist immigrants with their status. Each of these nonprofit organizations, depending on where that fund is coming from, they represent and help people with specific cases. So if you go to a nonprofit organization that is saying, we only help you to get citizenship, that's because of their fund. resources. So go to another nonprofit organization that is helping with non-documented who are in removal proceeding, for example. Or there are other nonprofit organizations that are specifically helping for asylum. There are many,
Okay.
and we actually are working with numbers of those nonprofit organizations. I personally am on the board of Immigration Lawyer Association, and we are running local immigration clinic, pro bono immigration clinic for people in the Bay Area. That there are 3 clinics that we are organizing for next month for employment based people who are working in companies and they have questions. They cannot afford a lawyer. They come there and ask questions, and we help them. There are other immigration clinic that we are organizing for, I think 2 months later, and that's about asylum. We have 10 attorneys sitting there. People come and we fill out application if they are eligible. They have been screened before. We will fill out their application and write down the declaration, have it ready, give it to them, just mail it to the asylum office. That's limited helping of immigration. We are not representing them at that moment is clinic, but there are nonprofit organizations that actually represent them and go to court for them or go to asylum office and USCIS office for them. So there are out there. What I think you need to look for might be like just looking for the right place. And I always happy to refer and find the local nonprofit organization that you're looking for. There are ways for us to figure out and find that and give it to you.
Oh,
the
thank you.
information.
That's
Yeah, of course.
interesting.
Okay, this is also from virtual. I'm not sure if I even understand this. For patients that are on dialysis, what would a fasting and 2-hour postprandials be? Patients often struggle with their renal diets and are not sure how to manage their glucose. What glucose levels are recommended? I read that word for word.
Well, postprandial just means after a meal, right?
Yeah.
Okay,
Yeah,
thank
yeah,
you,
it does.
Doc. I think that one's yours.
So are they asking what are, I'm sorry, it was a long question. So they're wondering what is the recommended postprandial glucose levels?
That's what I'm thinking they're trying to ask.
Oh, okay. Okay. So those numbers obviously can vary, obviously depending on the type of meal that was ate and whatnot. Are these diabetic patients that are also on medication and they're wondering what the is? We don't know.
No.
Okay. Okay, because there are postprandial medications that are given, Lispro, Aspart, for example, which could alter those glucose levels and they're a bit more fast acting. So I'm not sure if they're asking questions in regarding to those specific medications or just in general. Yeah. Okay. Yeah. So I did go over a few of those risks on my presentation. Basically, trying to make sure that you are keeping good glycemic control. You are living an active lifestyle. You're keeping check of any potential symptoms, and if you do feel like you might be experiencing any of these signs or symptoms, definitely make sure you do contact your healthcare provider. Of course, like I mentioned as well, checking your feet regularly because that can often be a sign. So I would say just really making sure that you are keeping healthy, active, and trying your best to live a healthy lifestyle in terms of your diabetes as well. If there's also any other alternatives such as smoking, I would definitely recommend quitting smoking and stuff like that as well.
I have a question about, you mentioned that there's more weight loss drugs. Was that you, I think?
Oh.
That have come out that could be considered, and I wonder whether they've been used in dialysis patients to help people get to transplant, given that dialysis is so energy sapping. It seems like a little encouragement boost might be helpful if there was a drug that would help with weight loss or cravings or.
So that wasn't in my presentation, but I believe what you're referring to is Ozempic. That's
Yeah.
gained a lot of popularity recently.
Mhm.
That has been shown to help with weight loss because it decreases satiety, it increases gastric emptying, for example. In terms of that, helping an individual be able to get on dialysis, I wouldn't have the information on that exactly, but if that's one of the requirements, I could see how that could essentially help.
Yeah, well, people on dialysis often are having issues with fatigue and mobility or neuropathy, and so say they need to lose just like 30 pounds or something. And, I mean, like getting off dialysis if you can is very desired. And I wondered if, any of those drugs could be done temporarily to help that person over the hump or permanently just to keep them at a better weight to get off dialysis.
Yeah, of course. Yeah.
That's interesting.
Yeah. There's actually been just a bit of a segue. There's actually been a bit of a shortage of Ozempic lately as well.
I heard about
so-
that.
Yeah.
Lots of stars taking it. I also heard they have to stay on it, which could be a drawback for some.
And that's what a lot of people don't realize.
Yeah.
You'll lose weight while on it, but as soon as you're off of it, a lot of people will gain the weight back.
Yeah, that's one thing I've appreciated about the conference here is that, and this may be the same for people on dialysis or professionals that are working really hard in dialysis. It's like, what you know the last time you studied or went to a conference, and you may not know that there's been advances in stuff. So the idea that there are drugs on the horizon that may slow the advance of people going to dialysis is exciting. And I wouldn't have heard about that had Carolyn not invited me here, although I read a lot of papers, but it's like, it's great to come out here and learn things that are positive, that are being figured out because it's such a hard thing.
What would be my question is for each of the panel. What would be your main takeaway of today's conference?
Well, for me, was that I didn't know there are that many resources available for patient. And it's not just if there is a cure for a disease and people can go to hospital and get it. There is actually a campaign here of mental health, doctors, insurance, and now lawyers. So I couldn't imagine all of these people get together and help patient to receive and go through this journey with more ease. It's not easy, but at least help them and support them in this journey. And that's amazing to see that, and good to know there is such a resource.
Yeah, I definitely agree with you on that. It's really great to see the community come together. And I guess studying medicine, we're mostly just taught medicine, but it really does encompass a lot more. It encompasses, law, it encompasses social work. We're all working here together to help these patients. And it was really great to see that for me personally. I also feel like I learned so much more about diabetes and all the different aspects of it and how it can, like I mentioned previously, like affect even like psychosocial factors and whatnot. So that was really great.
I guess one thing that struck me is that it's a different type of education session than the one you might get referred to. Like say you're part of Kaiser and they tell you, you know what, we're going to decide you're diabetic now. We're going to put you on metformin. You should go to this class next week, 2 hours for 6 weeks. It didn't feel like that here. It felt like a bit of a community out here. your volunteers were really sweet. Somebody walked up and offered me a chocolate. I mean, it was nice, a nice way to learn things you need to know, as opposed to, this is your new sentence, now go to the kidney class to learn what your life's going to be like, which I think when these classes, although they can be great, I think a lot of people can't concentrate for nothing. You're told you have cancer and then you're referred to classes. All you hear is like, oh. So I think this is sometimes a better way to learn, and we kind of learn together and be able to ask questions. And plus there was a lovely lunch and swag and vendors. I like it.
We just got a really good question from Victor online. He says, I was in PD dialysis and the nurse recommended to drink 1.5 liters of fluid. Now I am in hemodialysis and the nurse said I need to drink less fluid. How much fluid do you recommend? Also, does my diet have to be different?
We need a nephrologist up here to answer that well. Do you want to take a stab at it?
I wouldn't be able to tell you how much fluid the patient should be taking, but in terms of diet, I have a feeling he or she might need to live a healthier lifestyle. It really is one of those things where it's a case by case.
Yeah,
You
it
kind of
is.
need all the numbers to really see in terms of his or her electrolytes or kidney function tests for me to really help with that.
I mean, what I always think is like PD and home hemo, you have the potential of having a whole lot of dialysis, like at night you were saying. And so when you've got more dialysis, you can be more liberal with what you eat, because you're getting, whatever. I know dialysis removes potassium pretty well. It removes some phosphorus, but I think you can be more liberal in your diet. I know PD patients have to do a whole lot more protein than in an in-center hemo. And in-center hemo, it's all about what kind of kidney function you got left, right? And so when patients come in with more than can be removed, it can be difficult. I don't know, there's a lot of stuff, but that's something really for your care plan and your doctor and your own particular preferences and what you eat and your body and what other comorbid things you have and what time of the year it is. I mean, we used to lose our minds around cherry season, because we had patients come in and they'd gotten cherries at the market, and in-center hemo luckily can remove the potassium quickly. But the PD patients, it's like they might get in trouble because we might be in between clinic. You know what? Didn't you have a question a few minutes ago, sir? I don't mean to point, but.
I was just going to point out about.
Yeah.
There's no coverage by any insurance.
Oh, really? Oh, if you could get it
Really?
even. Yeah, and then you have to be on it forever. So interesting. Yeah, there's some other stuff. I just wonder, I mean, I don't know. It's something that I'm very interested in, because I think weight loss is very hard. And I like that a lot of the tips that have been given in this conference are pretty, it's not just one thing like eat better. It's like, exercise more. And I like the description why exercise is better with diabetes, because, we always hear this, but the fact that it makes what you've got work better is great to hear. That's more, I can get it in my head better as a social worker who isn't a doctor. Right.
So Dr. Dobb, if I can jump in here just for a sec. So.
Oh, that's right.
Fluid control is really a issue of several things, right? So how much you can drink is an issue of several things. The first thing is whether you make any urine, right? If you make urine, generally your fluid control doesn't have to be as.
Oh, look, there he is.
Controlled. The second is really how long you're on dialysis, right? So we want to try to take off only a certain amount of fluid in any given hour. If you take off too much fluid in a given hour, you're likely to get sick. Your blood pressure is going to get low. You're going to get nauseated. You might even vomit. You're going to get cramps. And then we know from studies that if you try to take off a lot of fluid all the time, you're likely to die faster. It's more strenuous on your heart. So on hemodialysis, the general rule of thumb is, you don't want to take off more than about 3 liters at each dialysis session, right? So if you think about it, you're going to go 2 days without dialysis, then you're looking at about 1.5. It gets to be really hard if you're gonna, go the 3 days without dialysis over the weekend. Because then when you go in, you're going to have about 4.5 kilos of weight that they're going to have to try to take off. And again, that's probably a little more than you could do in about a 3.5, 4-hour session.
Recording in progress.
And then the last thing is
your weight.
Oh, we're echoing here somewhere. But it is really your weight. You know, if you gain, if you're a small person, you know, you can't drink as much. If you're a larger person, you might get away with a little bit more in your age. You know, again, 25-year-olds can usually tolerate just about anything you want to do. If you're, 65 plus, it's much more difficult. On peritoneal dialysis, because you're doing the dialysis every night and you're doing it over a much longer period of time, or the few remaining patients that are not on automated dialysis at night nowadays, you really don't have as much of a restriction, right? So because you're doing it longer, and again, you're doing it every day. Lastly, most people with peritoneal dialysis are sort of do make some urine. So they have a little more liberal fluid restrictions. So that's the fluid restriction. So another question is was peritoneal dialysis better than hemodialysis? The answer to that question is sort of changing. If you would have asked me that question 5 years ago or 10 years ago, I would have told you they're both about the same, right? It's just really a lifestyle issue predominantly. We're starting to kind of rethink that issue as a lot of things are changing, as I showed you in my talk this morning. There is starting to be some data that shows that people on peritoneal dialysis live longer than on hemodialysis. Rosingen in New York has really been the predominant champion of this, showing that although it's not like a huge difference, but there does seem to be some difference because we're kind of getting better at dialysis per se. The second thing is your quality of life is a lot better. If you ask a nephrologist if they were on dialysis, which one they would want to be, if they couldn't get a transplant, obviously, universally, almost 90% choose peritoneal dialysis. Whether you can do peritoneal dialysis or not is really a question of whether you've had a lot of abdominal surgery, whether you have a house that's capable of storing some supplies, whether you're comfortable learning it. We're now moving towards a little bit more, and again, Kaiser recently showed, satellite dialysis recently showed this, was that if you do staff-assisted peritoneal dialysis training, the success rate is much higher. Because what we used to do it in the old days, and we still do it right now predominantly, is you come to the home dialysis center and they teach you how to do it, and then you go home and do it on your own. And that's still challenging for people. So now people have shown that maybe having somebody go into the house to teach them, and remarkably, satellite has shown that it only takes a few sessions. They've in their study, they offered it up to 90 days, and I don't think anybody went much more beyond 3 weeks to learn how to do it. So, you might want to ask about that, because a lot of people are starting to do that. And it's a better diet and a more liberal fluid, and your quality of life's better. And so I think overall people are trying to do that. And then I saw one last question I'll answer real quick before I shut up is, can you switch from hemodialysis back to peritoneal dialysis? And the question centered around peritonitis. But I will say that, whether you can switch after peritonitis really depends on how your abdomen heals and whether you can medically do it. But if you can do it, yes, you can go back. You can also go, if you've been on hemo, you can switch over to peritoneal dialysis. When I was in practice, we took a lot of patients who were on hemodialysis. When they started dialysis, they just weren't ready to do peritoneal. They were sick and they didn't know about it, and they weren't comfortable and they were scared. But then after a few months of hemodialysis, they wanted they started thinking about peritoneal, and we educated them, and we switched a lot of people. And DaVita has recently shown that they've been very successful at what we call switch, which is really switching from hemodialysis back to peritoneal or to peritoneal dialysis after somebody's been on hemodialysis. So yes, you can do the switch if you're medically able to do that.
Okay, I don't know who wants to take this one, but we have some optimistic people out here because we heard that optimistic people live longer. So are there any dialysis at sea cruises on the West Coast that anyone can recommend? Any dialysis at sea cruises on the West Coast? I guess when the clears up a little bit out here and stuff. So whoever, anybody aware of anything like that?
Yeah, I'm
Cruise
not
line
able-
with that?
Yeah, well, I know about dialysis at sea and that one pays out of pocket, but being that I'm a government employee, I can't really recommend anything that's money making. I mean, I would probably try to get on one of the Facebook groups, maybe like Home Dialysis Central's PD group, because a lot of the PD patients travel like heck because it's pretty easy for them. And I would just kind of say, hey, anybody out there do a dialysis at sea? I mean, and ask
So on
them
Facebook,
directly.
PD
yeah.
group, okay.
And they often will talk to you about barriers. Some of that stuff's crazy. Like, I mean, there was this big drama a few months ago about a patient who went traveling in Georgia, and the hospital she was at, the nephrologist couldn't handle that she knew things, and it was this big blow up on Facebook. It was really, really great seeing people saying, hey, we can do stuff, and these doctors need to kind of step up. It was wonderful. So, and dialysis at sea is kind of, it's, why are we doing dialysis? To live, to go somewhere. Catalina Island, Alaska, I don't know, you know? So the other thing also with cruises is the coronavirus hasn't gone away. So I would say talk to your nephrologist as well. Because I don't know, depending, especially if you're about to transplant, maybe. Might want to do it after. I don't know. Anyway.
Okay, thank you.
There was a question over here, this young man here.
Aware of or in the lookout or anything like that?
That might be one for Dr. Davda. Do you know anything about anything coming down the pipeline to help patients post-transplant in terms of like managing one's health?
Or essentially becoming essentially off the pills or anything like that, or just in general, kind of.
Well, there's a few things I've heard. I mean, I know there's there's a program in which patients can do blood tests and catch signs of rejection earlier than maybe like the next monthly appointment. I've heard of, there was, oh, and I just blanked, so maybe the doctor can jump in.
So to get off all medicines is, I haven't heard that. I mean, there are experimental programs going on for chimeric and stem cell transplantation, but I wouldn't say that those are drivers. The medicines have gotten a lot better, right? The major medicine that was having complications was prednisone and steroids. And there are lots of programs that now either do steroid-free transplantation or steroid minimum transplantation so that you don't get all the side effects of steroids, weight gain, diabetes, bone disease, those sorts of things. So they're very common. So, I mean, if you're going to your transplant center, you should ask. And if they say, no, we don't do any of that, you should look around because there are lots of centers that do that. And there are lots of centers that do immunosuppression minimization, right? So either they're not doing medicines like tacrolimus or Prograf or cyclosporin, but doing other things that minimize immunosuppression side effects. So I think you have many more choices in terms of immunosuppression regimen than we used to in the past. In the past, everybody got cyclosporin, Imuran, and prednisone, and they were just loaded with side effects. But now we've done a lot better along that. So I would kind of ask about different immunosuppression regimens to reduce the side effects from immuno. Like I said, it's really, at this point, I don't, unless you have a completely identical twin match or something like that, it's pretty hard to get off all immunosuppression.
Question, sir?
Yes. We know a lot of things in life, right? I know for as far as sickle cell trait and me being a carrier, sometimes the A1 test for diabetes can give off a false positive. And then also there's a rare kidney cancer connected to sickle cell trait. So how would an advocate like me encourage my community to come and have these screening processes done?
There's a lot of work in community organization outreach. I mean, this is part of it, big time. You've been doing this longer than many. I don't know. I mean, there's a lot of problems with communities not doing, helping with clinical trials as well. You know, so I think as much as, I mean, the current contract, at least with the network, has us trying to create these coalitions that are like from patients all the way up to psychiatrists, for instance, or transplant surgeons. Now, of course, transplant surgeons usually don't want to hang out with us for an hour every quarter, but it's the idea of having lots and lots of stakeholders in the community, because the more kind of people are talking, the more people you have saying, hey, you know, I can do this. I know there's some interesting things around transplant. It may not affect you, but does anybody remember Fixing Paco? The telenovelas is made by the Mendes. It's like a series of it's like, you know, telenovelas are like kind of like soaps in Hispanic land. And it's like this a group of people, it's a guy and his family all tripping about transplant and diabetes. And it's really fun. It's great actors. It's engaging. I mean, my mind's eye, I can still remember the daughter who's the narrator. It was amazing. And it got a lot of people really learning about transplant and having fun with it. And so they've just done a follow-up and the red carpet was just like a week ago. And it's called, Linking for Love, I think. And it's for the African-American community to get people talking about, you know, living kidney. And the doctor can probably attest to this. If you can have a relative who says, yeah, I'll spare you one. And if they're, you know, a good match, I mean, that's something in some communities have really been sorely served. So I think there's some work out there. I don't know your area as well. Of course, churches do a lot of like blood pressure screenings and all that kind of thing. It might be something to go in there. Sickle cell, I don't know enough about. You might want to talk to your doctor, your nephrologist, but yeah. Anybody else want to chime in? I'm the social worker here. I'm just a chatty Cathy.
I'm sorry,
Go
the
ahead.
question was about sickle cell and transplantation. Is that what I heard?
It was about sickle cell trait and having false positives for diabetes screenings, and then also the rare kidney cancer that's connected to sickle cell trait. Like, how do we encourage our community to come and have even even have a screening done to get those tests completed?
I think knowing if that it doesn't hurt might be a good idea. It kind of reminds me, who was it? Will Smith, who had his colonoscopy filmed to try to get more people to kind of go through it. Sometimes it helps to talk to somebody who's done the testing, but what do you know about that kind of testing, doctor, to get people to do it? Any outreach?
Yeah, no, I don't know about sickle cell trait and cancers and screening for that. I would be remiss. A geneticist or somebody like that would really be helpful in terms of community screening. I mean, that's within your belly work. I mean, it's not. I don't know of anybody I've never seen it done. So I'm sorry, I don't have much information about that.
Is there a recommendation? Like I said, if people have inherited genes and that gene impacts that kidney, like, is there a screening that one needs to start taking? Like, I guess that's what I'm trying to figure out. Like,
again, you may need to talk to the doctor that's treating you for sickle cell. We may need to talk to a nephrologist. What I could do, if you want to contact me, there's a grouping, there's a listserv through NKF, the CNSW listserv, and I can just kind of type out to all the social workers in the country saying, hey, do y'all have any sickle cell patients dealing with this as they're dealing with workup? And I can see if I can get some stuff back. There are transplant social workers on that listserv. So I could try to get some information. I love learning this kind of thing because it's so important.
and I appreciate you, because the one thing that you said is the trust. There's a
Yeah.
lot of distrust. So how are we going to even come to clinical trials and things like that if there's a
I know
lack
as
of
a
trust?
person,
So-
if I wanted to do something as radical as giving a kidney to someone, to know that the testing was easy and cheap and didn't hurt, that might be helpful. I'm a chicken. Thank you.
Any further questions from anybody?
Popped up on the video?
We see her, but she's not reaching out to us here.
Oh, can she chat in a question maybe?
No, that's what we're looking at, but
Oh, too bad. Hold up a pad. Well, let us know if you have any other questions. Any other questions from the audience?
Well, if may, I wanted to mention some nonprofit organization that offer pro bono immigration help to immigrant, and maybe those names are help you to like navigate and share that with your patient if you need to. There are nonprofit organization in the Bay Area, but they might have offices in other places in California. Catholic Charity, they represent clients in removal proceeding, undocumented, in their humanitarian type of cases. And we are actually organizing a clinic with them to file application for asylum. 10 Afghan clients that are looking for asylum application. There is another organization, Santa Clara County Office of Immigrant. They are also organizing immigration clinic for employment-based type of cases who are trying to get green card through their employer. And there are 3 clinics that we are going to sit there, and then people come and ask questions. There are other organizations. One of them is CARE, Coalition Against something. I don't remember. I'm sorry, but they are for I think against something, and then Muslim. It's for Muslim community, but they obviously represent everyone from any country, any nationality and religion. The only factor for them is income. And so CARE has also office in LA and San Francisco, Oakland. There is another organization, Siren. That's also a big organization that support, and they run annually. They run a nationalization clinic. They help people to apply for citizenship, especially before election. They want to more people apply for citizenship, that they get their citizenship so that they can vote. Another organization, Parse Equality Center, that's an organization, nonprofit organization, offer support social work and also legal and advocacy. And they have office in San Jose and also in LA.
What was the name of that one?
Parse Equality Center.
Parsa?
Parse, P-A-R-S, Parse.
Oh, cool.
Equality Center.
Parse Equality. All
Yeah.
right.
And what else? There are many others, honestly. La Raza is another one. And there are a lot of other organizations that I personally work with them. There are many others that I haven't worked with them. But there are a lot out there, and I just wanted you to know that there are resources out there for pro bono for immigrants here.
Well, if anybody wants to be a patient subject matter expert with a network and help change the government's opinions on things, we need you. I mean, every month I need a patient to talk to Medicare and tell them what they think. It's pretty neat. So reach out, let me know how we change the world. Oh, kidney disease, yeah, for ESRD, yeah.
if there's nobody else, thank you, Anne. Thank you, Dahlia, Jessrina, Dr. Modoc, who was on earlier, Dr. Davda for getting back on. Siapa's out there now. Elham, you're done out there, right?
Where?
Out for the workshop out there? Are you
Yes,
going?
yes.
So it's all done out there? Okay. I know Siapa's finishing up, but maybe we give another round of applause for everybody. What an amazing
Thank you.
event we had again this year. Carolyn, for all of your hard work, why don't you do your parting words? Come on. None of this would happen without you, the president.
Hello? Okay, hi. I can barely hear it. I just want to thank all of you for making this happen, because we're all in this together for the patients and for the community, and just bringing awareness on how we can make it better, through all their, their journeys of where they're at in each part of their way through the condition. And then we, like you said, and there's professionals, there's patients, and there's just community. And it really matters. It really matters that we take this time to nurture and to just guide each other, and especially the patients. So thank you all for just taking the time and giving it to us. And
Thanks for
thank
having
you,
us.
everybody,
Yes.
for being here. And everybody that's online, we thank you, and we'll see you next year.
Those of you that don't know, Carolyn will be working on next year's tomorrow. She doesn't stop, and she's just a machine for so many years. It's amazing. She was up at 2 a.m. and I don't know, she probably got here this morning at about 4, make sure the parking lot was ready for everybody. But you're amazing. Thanks for all that you do, and thank you. We had such an incredible panel of speakers today covering so many different, wow, we got from every direction. It's such an amazing event, and it seems to get bigger and better every year. This is great. We had this going on. Great to be back in person, which is wonderful. And already looking forward to next year. So I guess if you guys are going to hang around, somebody wants to meet with you. But otherwise, thank you to everybody so much. And we'll do it again next year.
It looks like there's going to be a raffle
Yeah.
drawing.
Oh, online raffle.
Uh-huh.
Okay.
Yeah.
Separate one online.
Better call me if you
And
need
here.
me. Yeah. Yeah, or sometimes there's ways and ways. Yeah, you're welcome. You're welcome. We all have to use our voices. Yeah. 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 Uh-huh.
Of course. Glad it was helpful.
Thank you.
Yeah, that's great.
Absolutely. Remind everybody, if you're on the online raffle, you will be notified and your gift will get to you. And also, once again, just want to bring up for the survey, make sure you fill it out. It's in your little packet that everybody got. So if you could please fill out that survey. Also been emailed. Yeah. So if anybody has one of these that they filled out or could take a minute to do it, get it over to Carolyn. We sure appreciate it.
And don't forget, the network has peer mentors of other ESRD patients, both transplanted, like people have been transplanted for years. They can talk to newer transplant people and kind of say, how did you manage this? Same with people that are newer to PD or newer to HHD or newer to in-center. So those are great.
Thank you.
Thank you.